Morning.
Okay, good morning, everyone. On behalf of Buoy Pump, I welcome you in the first phase of our virtual training, which is the basic life support. So I'll be getting the lecture using the interim guidelines of 2022, which is the latest guideline on basic life support. So welcome, everyone. Basic life support is our requirement in case we need to go to taking advanced cardiovascular life support. So this course or this training is mandatory, not only in hospitals, but in even in private entities, or hindi ko alam kung sa mga government agencies may requirement. Pero sa DOLE kasi, once you have 50 na tao, requirement na siya. And this is our way of jacking up the resilience culture na we are trying to build up. Last year, 2022, I'm gonna start up with the bad news. Yung Pilipinas ay nag-number 1 na tayo sa World Risk Index. Ibig sabihin, sa lahat ng mga, ano bang Tagalog ng hazard? Panganib. Sa lahat ng mga panganib na pumapasok sa mundo or na-experience ng mundo, numero 1 na ang Pilipinas. So with all the incidents happening, the phenomena, no? Natural hazards, like tulad ng bagyo, although kausap ko yung scientist, mas medyo less daw yung bagyo ngayon. Salamat naman. Pero kasi sa bagong statistics, tumaas siya. From 21, umakyat ng 24. Para daw sa Pilipinas, simula sa 20 or 21, umakyat sa 24 daw. Yun na yung expected na darating sa atin. And out of the 20, 11 ang maglalandfall. Umakyat sa 24, 13 na daw ang maglalandfall. And out of the 13, mga 3 to 4 ay malakas na bagyo. Even categories 4 and 5. Pag sinabi kong 5, the likes of Yolanda. So natuwa ako na kahit papano, meron tayong pangtugon. Although hindi naman siya direct kasi very reactive naman yung pagtugon na yan sa issue ng climate change. Ang kailangan natin ay mga magagandang proyekto ng katulad ng forest restoration programs, no? So dapat ganun tayo. Which in the where I am taking off, I'm a consultant in Energy Development Corporation. Doon kami. We have forest restoration for 7 years. Meron na kami more than 7 million trees na na-plant. Anyhow, sa reactive issue, kahit papano, makita niya na may ginagawa din yung pamahalaan. Ginagawa tayong resilient by being trained on this. So, huwag nyo ikasama ng loob kung bakit kasi required to eh. Mas maganda yan. Mas maganda kung lahat ng Pilipino ay marunong mag-first aid at marunong mag-basic life support. So today, although sa healthcare provider, we are healthcare providers, and it's also mandatory amongst health practitioners to be trained and retrained. Kasi minsan, madali lang yan. There's a Japanese saying, kasi sanay tayo to learn 10 skills and practice 3 times, or 100 skills and practice 10 times. No? 100 skills and practice 10 times. Sa Japanese, hindi. Learn 10 skills and practice 100 times. So, ito tayo ngayon, kahit simple siya, pag kailangan, we should be very, very good in intervening and using basic life support to save somebody else's life. So, I'm Dr. Ted Esguerra. I'm a field rescue doctor. So, my specialty is the pre-hospital world. So yung training ko mainly sa abroad ko nakuha. Tapos yung mga responde ko, hindi dito. Minsan sa abroad, like this September, I'll be going to Ukraine. And on same date also, may ka-meeting ako doon, mga taga Netherlands na mga kasama ko na nag-responde sa Ukraine. Pupunta rin sila sa Pilipinas kasi i-follow up namin yung improvement ng donation galing sa Netherlands doon sa 2013 Yolanda. Kumusta yung mga community kong maayos, no? I'm at the outset, the sorry. Uh, Another bad news is cardiac arrest is taking its toll, no? Siya yung pinakamataas na morbidity and mortality sa buong mundo. Ipunin mo yung namatay sa mga gera sa Ukraine, sa Marawi, sa Aleppo, walang makakatalo sa cardiac arrest. The bad news is, lalong dumadami at pabata ng pabata ang nadadali. So, you have to be scared because while I'm talking here right now, I don't know, but maybe a number of you kandidato. Lalo na kapag mataas ang blood pressure na hindi natin kinokorek. There is hypercholesterolemia na hindi natin kinokorek. There is mataas ang sugar na hindi natin kinorek. And smoking, naku po, sedentary lifestyle, paupo-upo, ayaw mag-exercise, katulad ko. Natamad na rin. Kaya nung nagturo ako doon sa Cagayan de Oro, kaya lalo pa akong umitim. Maitim na ako, lalo pa akong umitim. Bundok pala, nahilo ako eh. Sabi ko, nawala na yung tikas ko sa bundok. Ano pa? Obesity, stress. So these are the correctable, no? We can correct contributors sa cardiac arrest. Yung mga hindi natin makorek, yun yung gender. Pag lalaki ka, mas prone. Kasi siyempre, ang hormone ng lalaki, testosterone is a fighting hormone yan. Fight, fight, fight. Wear and tear. Grabe. Ano pa? EDAD. Ano ang EDAD? Edad. Siyempre, pag umi-edad ka, madadali ka talaga. Ano pa ba? Nasa lahi. Pag nasa lahi mo na may sakit sa puso, wala na tayong magawa dyan. So, I don't know, but this is the World Health Organization coined the term before, so many years ago, as a global scare. No? Mas, pag na COVID ka pa nga, nakaka-TikTok ka bago ka maging abo. No? Galing sa ubo, maging abo. Makaka-TikTok ka pa. Pero pag bumara yung mga coronary arteries mo, wala. Walang goodbye. Diretso yan. No, walang mga paalam-paalam. Pag nangyari sa gabi, hindi ka na magising sa umaga. Now, another bad thing, no? Ugly thing in this country, hindi sa lahat ng lugar sa Pilipinas ay very aggressive or active yung ating emergency medical services. Anong ibig sabihin? Yung mga ambulansya. Siguro kung nasa Davao kayo, maganda yung Davao 911. Nasa Cebu, maganda yung Aerof ng Cebu. Sa Pasig siguro, hindi ko pa nasubukan kung ano ang bilis ng emergency response sa Pasig. Sa Valenzuela City kasi naka-preposition yung mga ambulance. Pero mahina pa rin yung ating pre-hospital care sa Pilipinas dahil wala tayong standing law. Tingnan nyo listen. Despite the fact na we are a country along the disaster corridor. We are a country with lots of accident. Pero ang ating pre-hospital care law, wala. Yan. So that's quite scary. Now, that's why we want CPR training to be given to almost everyone. Now, what is our objective, or what are the objectives? First is we have to describe what basic life support is all about, and then let's visit the two the links of chain of survival, yung in-hospital cardiac arrest at out-of-hospital cardiac arrest, and BLS and COVID protocols following the interim guidelines of 2022, at saka yung mga tinatawag nating stations or batteries of learning when you take basic life support. So basic life support is simply an intervention. Basic intervention siya, hindi siya invasive, wala siyang tusok-tusok, no? Para sa treatment of any unconscious individual, pag sinabing unconscious individual, undergoing respiratory or cardiac arrest. Adult, child, or infant man yan, lalo na yung mga walang pulso, yung into agonal breathing or with no breathing, tapos may airway obstruction. And lately, dinagdag kung hindi niya pa tayo tawag tayo, naloxone induction. No? Bakit? Kasi kahit gaano kagaling mo mag-basic life support, pero ang opioid ay nasa loob ng katawan, hindi mo talaga ma-reverse ang respiratory depression, no? So kailangan meron kang naloxone. Pag pronounce is naloxone. Kinorek ako kasi ako pag kasama ko yung mga foreign counterparts, naloxone. Naloxone pag pronounce mo. Then we have to be trained in BLS to become basic life support provider. So meron siyang parang 2-year certification. So every 2 years kailangan i-renew. So anong mga scope? So alamin natin ang protocol, ASCO 2020 and interim guidelines of 2022, yung compression mechanics. Tapos idagdag ko lang, hindi lang idadagdag ko yung Arizona sa Badger County. Kasi nung 2010, medyo maraming nainis sa akin kasi hindi na talaga ako naniniwala yung mga hihinto ako para magbigay ng mouth to mouth. Kasi nang binasa ko yung ganong, yung physiology sa gayton, para continuously ma-oxygenate yung brain, tuloy-tuloy lang yung compression kasi every time mag-recoil ang chest mo, ang hangin pumapasok. I mean, the oxygen comes in. So, I'm an advocate of a all hands. We even call it CCR, cardio-cerebral resuscitation, hindi CPR. Kasi actually, it's the brain ang kailangan mong resuscitate. At saka tingnan natin paano ang rescue breathing saka yung pagbigay ng naloxone. So basic life support is a mandatory requirement for ACLS. Pero pag kumuha ka ng ibang mga medyo advanced life support, katulad ng advanced trauma life support, no, for doctors, ang ATLS pang doktor lang talaga yan. Hindi yan pwede pang nurses and EMTs and paramedic. Ang pwede sa nurses and EMTs ay yung PHTLS, Pre-Hospital Trauma Life Support, saka yung ITLS, International Trauma Life Support. Tapos, meron tayong PALS, which is for pediatrics, no? Pediatric, it's an ACLS for pedia, and then neonatal resuscitation program, ACLS for neonates, then management for obstetric emergency and trauma, advanced disaster life support, advanced medical life support, and wilderness advanced life support. Like years ago po, nakuha ko talaga yan lahat. Kasi siyempre sa field ako, alam ko itong iba wala sa Pilipinas. When I was still abroad, lalo na yung WALS. Although tinuturo ko dito yung WALS, no, Wilderness Advanced Life Support. It's a combination of ACLS and advanced trauma in the field. Kung makita niyo dito sa picture, balik po yan. Yan. Nagbigay ako ng morphine, nagswero ako dito sa lugar na ito. Letter C. May maraming lansones. Island na mas maraming volcano kaysa mas maraming town. Anyway, dyan yan. Isang Britisher, balik ko yung kanyang tibio-fibula. So, binigyan ko ng field advanced trauma. Now, again, Ang dadaanan natin ngayon ay yung chain of survival, yung compression, yung foreign body airway obstruction, yeah, no? And then AED operation, paano i-operate yung AED? Although simple lang naman, hindi naman siya rocket science. Now, ito ang bungad sa lahat. Yung konsepto ng BLS at ACLS ay hindi siya pwedeng ipurso without following the chain of survival. Kasi dito ang sunod-sunod mo. Ito yung parang pinaiksi ko lang yung storyline of what you will do. So BLS and ACLS, iisa lang yung chain of survival. So ngayon nadagdagan, no, sa 2020, nadagdagan ng recovery. So sa in-hospital, which is yun yung inyong scenario, so pinakauna, early recognition and prevention, kasi yan naman talaga yung primary dictum ng medical practice, no? The prevention. So yan, no? We have to recognize yung sinabi ko kanina, yung modifiable versus non-modifiable traits ng cardiac problem, no? Or arrest. Then, activation of emergency response. Dati, activation of EMS. Hindi naman lahat ng lugar may EMS. Emergency Medical Services System, no? Pag sinabing EMS, yan po yung pre-hospital, ha? Tapos, high-quality CPR, then defibrillation, then post-ACLS care sa lumang chain of survival. Ngayon, ginawa nilang post-cardiac arrest care. So, ito na yung scenario mo, simula sa ambulance or sa helicopter na naglagay ka na ng mga inotropes, chronotropes, kung mabagal o mahina yung puso, hanggang dalhin sa CCU, hanggang ma-discharge. Tapos pag-discharge, dinagdagan natin ng recovery. Kasi nakitaan, according to statistics, ang mga tao na ayaw sa ospital, okay, the patient is well treated, given all the modalities in the hospital, pero ang problema, okay, makinig kayo, lalo na sa Pilipinas, pag-uwi sa bahay at sa community, wala na sa ayos. Hindi siya, ang ating community ay hindi friendly for patients. No? Hindi lang naman yan sa cardiac eh. Even in other illness, lalo na may mga CKD, chronic kidney disease. Tingnan mo pa lang ang ating kalye. Yung kalye ba natin, friendly ba siya sa mga elderly at saka sa mga persons with disabilities? Wala ngang ramp. Yung ating mga city na kalye, wala siyang marka na daanan ng mga blind, no? Hindi katulad sa Japan, no? Nag-ikot-ikot ako sa cities of Japan, uniform. Merong corrugated material doon. Pag bulag ka, hindi ka meron kang dadaanan. Pilipinas, walang ganon. Siguro may ilan, konti, pero it's not national. Kaya, I don't know. So, yun yung ibig ko sabihin, yung PSG or Primary Support Group Program natin, family and community, ay mahina. So ako ngayon, galing ako sa ospital, kaka-cardiac arrest ko. Okay na ako. Pag uwi ko sa bahay, ang, ang family and community ko ay hindi sumasangayon sa akin. Tataas ulit ang alta pressure ko. Kasi nabibuisit na naman ako dahil yung community hindi maayos or yung family ko. Yan yung point. The next chain of survival, dalhin ko lang kayo konti sa world ko sa out of hospitals. Nasa labas, kailangan activation of emergency response kasi syempre hindi ko naman kilala yung mga pasyenteng bumubulagta lang dyan. Tapos high quality CPR, defibrillation. Ang nadagdag lang is yung ambulansya, yung advanced resuscitation. Tapos yung CCU care, cardiac coronary unit care, and then recovery. Meron din tayong PDA. Although hindi naman tayo pulse, pareho, the same lang din. Except lang dito sa out of hospital, ang pagkakaiba lang ay merong dinagdag dito na prevention. Magtataka kayo, bakit sa adult walang prevention? Bakit sa bata? Okay. Meron naman sanang prevention. Pero dito kasi sa mundo natin, mas grabe kasi yung favor towards I'm not gonna use the word marginalized. Vulnerable sectors of the society. Katulad ng kabataan. Na, alam niyo naman yung mga vulnerable sector, yung kabataan, nursing mothers, sinama na yung women, no? Mga katutubo, may kapansanan, may sakit. Ang isang progresibong lipunan ay isang lipunan na ang pagkalinga niya ay nandoon sa mga tinatawag nating vulnerable sectors. So ayan. So makikita mo, grabe yung favor sa bata, no? Kaya binabantayan natin na sana ma-prevent natin magkaroon sila ng cardiac arrest. So ano yung mga rundown na ginagawa natin sa BLS, lalo na sa arresting, no? Arresting case. Siyempre, assess responsiveness. Mamaya tuturuan ko kayo paano mag-arrest responsiveness. Magugulat kayo, hindi lang pala tapik dito sa balikat. Meron na tinatawag na trapezius pins. Tapos, how do you call for help? Sa ospital, tawag natin code blue. Hindi ko alam kung ang hospital ninyo ay gumagamit ng gano'n, no? Code blue. So, sa mga hindi gumagamit ng code blue, sige, shortcutting ko na lang. Yan po yung emergency call kapag may kasong cardiac arrest. Code blue. Ha? So, parang naging international distress call siya sa loob ng ospital. Ganito po pag tinawag, no? Kunwari, merong nag-arrest sa surgical ward. So, nag-start ako ng CPR, blah, blah, blah. And then yung isang kasama kong nurse ay magtatawag via public address. Tatawagin niya, Code Blue, Surgical Ward, Bed number 3. Code Blue, Surgical Ward, Bed number 3. So yung mga member ng Code Blue team ay magpupuntahan kung sino yung bakante, pupunta sa surgical ward to intervene. Sino yung mga Code Blue team? Sila po yung team RAIN ng BLS saka ACLS na maging part ng Code Blue. Okay. Hindi lahat ng BLS saka ACLS ay pwede maging Code Blue. Usually, Code Blue, ito yung mga medyo, sabihin natin, matitikas talaga. Okay. Then, cover the patient with bago daw mag-CPR, 20 protocol, hindi yung 2024 BLS and ACLS, COVID is not mentioned. Pero 2020 nag-start si COVID. Bakit? Ginawa siya 2018 to 2019, na-roll out sa 2020. Kaya, hinabol sa interim guideline of 2022 si COVID. So, 2023 tayo ngayon, ang pinaka-latest na anchor point natin for basic life support is the 2022. Kung magulat kayo, wala pang ganun ang Pilipinas kasi hindi pa sila sumusunod sa 2022. The funny thing is, binaba na po yung ating alert level, ay ating way of looking at COVID. Hindi na tayo nagmamask. So, halos itong 2022 interim guideline, it does not mean na inutil siya. Nandyan pa rin siya. Pero pwede tayo bumalik konti doon sa parang pre-COVID days lang. But, if you're working in ER and you're not sure of the patient, mask pa rin. Okay? Pag nag-address tayo sa pasyente, meron pa rin tayong kahit papano mask. At saka eye shield man lang kasi it does not mean the COVID run away, no? The COVID is still there. Although, ang katawan natin kaya nang umaway. So this is the pedia. Sorry. This is the what's gonna happen inside your brain when it's not oxygenated. So yan po ay ginawa sa non-tropical country kaya hindi po yan masusunod. Ang susundin natin is sa tropical country is not 10 minutes. 7 to 8 minutes lang talaga max natin. So 0 to 1, cardiac irritability or less than 1 pa nga. Ibig sabihin, nag-fibrillate yung heart. And from 1 minute to 3 minutes, brain damage not likely. 3 minutes to 5 minutes, brain damage possible. 5 minutes to 8 minutes, brain damage very likely. Binabaan ko lang siya kasi tropical tayo. So if you look at this picture, this is what's gonna happen in your heart. So when your heart goes into arrest, ang heart po natin ay nag-fibrillate. So tingnan niyo itong cursor ko. Pag nag-fibrillate yung heart, ganyan po, no? Parang kung sa Bisaya, nagkikirig-kirig ba? Hindi ko alam paano sa Tagalog. But fibrillate yung, ganito po, kung titingnan niyo po. Ganyan po. So yung heart natin, ganyan mag-beat. Tapos pag nag-fibrillate, gumanon. So pag nag-fibrillate, ganun siya, wala na po yung hemodynamics. So arresting heart yan. Yan. So pag wala tayong ginawa, deads ka. Goodbye, my teacher, goodbye. Ito naman, nag-fibrillate yung heart, hindi ka sinipr, nag-defibrillate ka, kahit pa paano, may percentage na pwede mabuhay. So sabi dito, 2%. Dito naman, nag-CPR ka, okay. Pero yung fibrillation mo late, tumaas naman yung chances of survival mo konti, but depende sa age. No? So, this is not fixed 8%. Depende sa age pa rin. Dito, maganda, may tawag, tapos na defibrillate ka early, umakyat ka into 40% in an age bracket of up to 40 years old. From 18 to 40 years old, umakyat ng 42%. So, hindi na yan ang statistics. Itong pinakaibaba, nagawa lahat hanggang post-cardiac arrest care, umakyat ng 76%. Taas pala, no? Yes, 76%. Pero, ang edad niya is 18 to 40. So, hindi na pala ako kasama dyan. So, what is the interim guidelines? Ang interim guideline of 2022, pareho lang except nag-emphasize lang on PPE. Ibig sabihin, naka-level 4, level 3, level 4, pag nag-attend ng isang cardiac arrest care. Tapos, nag-limit personnel. Hindi katulad dati, pinaka-optimum 6. Ngayon, 4 na lang. Ang team leader, hindi nakatayo sa paa. Ang team leader ay nagde-defibrillate na para mas less. Mamaya, ipapakita ko paano yung assembly. Tapos, kung kaya ng, kung bata-bata pa, tapos nasa height sa weight criteria, ginagamitan ng tamper. Makikita niyo yung machine na nilalagay sa dip, tapos siya nagbibigay ng air corridor. Merong inlet ng hangin, kahit naka-aircon siya, tsaka may outlet ng hangin. Para hindi matrap yung microparticulates. Tapos inuna natin yung tinatawag na first pass, hindi first pass, ng liver, yung first pass approach. Ibig sabihin, pag intubate kasi kaagad eh. Pag ACLS, although BLS ang topic natin, so hindi siya part. Pero sa kabuuan ng interim guidelines, pag may arresting patient, dapat i-intubate ka agad. Ang tawag, pag intubate mo, dapat sakto ka agad sa pasyente. Na-intubate siya, shoot ka agad. Hindi pwede magkamali. Sana. Ang tawag doon, first pass run. Ayun ang first pass success. Tapos, dati, nagpo-pause sa intubation, panahon pa nung intern pa ako. Tapos, nung pre-COVID, wala na. Habang nag-intubate, tuloy-tuloy yung CPR. Pero ngayon, hinto ulit. Tapos, hindi na pwede yung classic. Hindi pa dumating yung order ko kasi na video laryngoscopy. Sa Pilipinas po, kung maalala nyo, 2000, 2004. 2004 I don't know kung ano pa kayo dyan. Sa inyong history, sa 2004, wala pong gumagamit ng video laryngoscopy. Modesty aside po, meron ako. I'm using it. So meron akong fixed blade na Macintosh. Nasira na lang siya. Hindi pa maganda yung pixelation. Pero kitang-kita mo na. So gumamit na ako gano'n. Natuwa naman ako, it took COVID for us to have video laryngoscopy. After how many years? Almost 2 decades. No? Ang dali lang pag naka-video. Video rig na laryngoscope. So, before intubation, use bag mask device. Yung bag valve mask, hanggang ngayon, kailangan bumili kayo ng bag valve mask na yung kanyang exhalation port ay naka-HEPA filter. Kasi malay mo yung minamanage natin pasyente ni COVID, di parang din yung microparticulate sa paligid. For adults, consider passive oxygenation. No? Bago mag-CPR, muna nakalagay ng non-rebreathing mask para lahat ng bawat CPR mo, yung na-exhale, not exhale, sorry. Pag compress mo, lumalabas yung hangin, natatrap sa non-rebreather mask. Hindi siya kagad lilipad. So bago ka mag-CPR, another delay lang ang interim guideline of 2022. Lagyan mo na ng non-rebreather mask mabilis kung nag-iisa ka pa lang. Pero pag dalawa kayo, bago ka mag-start ng CPR, yung airway guy ay nakapatong na yung mask sa nose and mouth bago mag-start ng CPR. Baliktad na ngayon. Dati, compress bago magdating si airway. Ngayon, hindi. Madi-delay konti. There are 3 delays sa isang arresting patient. Bago siya mag-arrest, nag-arrest siya 3 delays. Number 1, yung hinigan niya, kailangan ibagsak mo. So, depende sa klaseng bed meron kayo. So, pagbagsak noon, delay yon. Number 2, maglagay ka ng cardiac board, delay ulit yon. I'm not telling you ma-delay ng mga 20 seconds. Kailangan 10 seconds, tapos ka agad yan. Max 10 seconds. Masahan pa isang delay, kailangan lagyan ng non-rebreather mask. Pero kung ikaw ay nasa pre-hospital care, katulad ko, at wala ka kagad available oxygen, nilalagyan mo lang ng surgical mask bago ka mag-start ng compression. So, saka na natin to pag-usapan kapag ACLS na tayo. So, ito yung mga risk na pinag-uusapan sa interim guidelines. No? So, I will leave this to you, to your reading. Ha? Hindi ko na yung effective use of PPE is critical for, ayoko na kayong gawing grade 1. Okay? So, basahin nyo na lang yan because this has something to do mainly on PPEs and room assembly. Yan. So yan na, yung nirarandan ko, if you look at it, ito po yung mga. So this is the 2022 basic life support algorithm. 2020 siya, 2020, pero ito yung ginagamit sa 2010. Saglit ha. Mapapansin ninyo, dito sa itaas, in-emphasize na yung don't PPE. Updated April 2020. Tingnan niyo yung date. Nung kasagsagan ng COVID, hinabol talaga. So ito yung algorithm. Don't PPE, limit personnel. Kung may exam, of course, may exam naman talaga, lumalabas tong dalawa. Ayan. In-emphasize yan. Sana payagan ako ni Ma'am Joy. Gagawa din ako ng pang-exam ko. Kahit mga 220 items lang. Biro. Then after that, you have to check responsiveness of the patient, activate code blue once the patient is found unresponsive. Tapos, sana may AED ka agad, no? Sana all. And the next box is look for no breathing or only gasping. What do I mean with that? So yung pasyente, nakita natin bumulagta, assuming okay naman pala, humihinga. Tapos may pulso, baka nahilo lang. Pwedeng dahil sa mainit kasi ngayon, katulad ngayon. grabe, no? Baka nagkaroon tayo ng tinatawag na heat syncope. So ilagay lang natin sa gilid, tipong ganun. Or nagkataon ng transient hypoglycemia. Pag dito naman, meron pa akong pulso, tachycardic siya, pero hirap huminga. Anong ibig sabihin? 10:30, merong distress, no? Okay? Or, para sa scenario ganito is, agonal breathing is less than 10. Yung gano'n, no? Huwag mo na hintayin 1 minute. Sapakin ka ng pasyente na naggagasping na siya, nagtumitingin ka pa sa relo to satisfy na it's less than 10 cycle, no? So, pag alam mong agonal breathing, bag valve mask or bag mask valve, no? Tapos, magbigay tayo ng blow. Boom! One breath, no? Every 5 to 6 seconds. No? Tapos, while you call for help or code blue, not code blue, you activate. Yeah, you can already activate code blue because this is an impending respiratory arrest. Tapos, rescue breathing ka lang while you check for pulse. Tapos, tingnan natin, malay mo kung kunwari, nasa ER, nag-observe ka lang, no, lumala pasyente, opioid overdose pala. Okay? Kaya, anong mangyayari? Para po siyang morphine. No? Siyempre, opioid derivative na si morphine. Respiratory depressant yan. So, pag opioid overdose ka, maghihingalo yung paghinga mo. So, ayan po . Ayan. Tutuloy na tayo dito sa corrugated line. What if the patient has no pulse and no breathing? Dito pa lang, na-check natin, na-activate na natin ang code blue inside the hospital. So, we perform CPR. Okay. So, ang ideal natin bago tayo mag-compress ay nakalagay na yung BVM or BMV, bag mask valve, na naka-tight seal, or continuous compression ka with passive oxygenation using face mask kung nasa pre-hospital care. No? So, all compression yan. Pero pag nasa inside the hospital ka, dalawang mangyari. Ano yan? Depende yan. Kung ikaw ay, ang hospital mo ay medyo nasa periphery, wala kay ganong staff, all compression ka pa rin hanggang darating yung kasama mo. Huwag kang, nag-iisa ka lang, compress ka, tapos hinto ka, lilipat ka doon sa airway, magbag ka. No way. Pag nag-iisa ka lang, lagyan mo ng non-rebreather mask, naka 15 liters per minute, compress ka lang all the way. Compress. Hanggang darating na yung mga kasamaan mo sa cold mo. So, pwede ka mag-30:2. So, yun yung tinatawag na hybrid. Ginagawa natin sa Pilipinas yan kasi hindi tayo katulad sa ibang bansa na kompleto. Kompletong staff, kompletong gamit. Sa Pilipinas, hindi. So, pwede mong gamitin yung all compression muna bago ka mag 30:2. Ngayon, dumating si AED, no? Paano yon? Gusto kong linawin dito sa atin. Sa hospital ba, AED ba? To tell you honestly, ladies and gentlemen, hindi po. Ang ginagamit natin ay manual. Pero kung meron kang manual with AED override, mas maganda. Anong ibig sabihin? Dahil tayo ay professionals, hindi tayo pang AED. Ang AED, ang intention yan ay para sa mga tao na mga civilian, the word civilian, mga lay people, okay? Tayo hindi. Manual talaga tayo. Pero yung ating manual, may AED override. Para kung nag-iisa lang ako, AED muna ako. Para may timer ako. Kasi yung AED, pag on mo sa AED, apply pads. Gumagano naman. So, apply mo yung pads, habang CPR, hindi ka hinto kasi ang guideline, push hard, push fast with adequate recoil, no? 2020 guideline. Avoid interruption, avoid hyperventilation kung nagbabaging ka. So, tuloy lang, kuha ka ng pads, lagay sa dibdib, kuha ka isang pad, huwag mo hintuan. Okay, yan. Tuloy-tuloy. Tapos, merong voice prompt yan. Wala kang hinto. Open check responsiveness of the patient. Huwag ka na mag-check responsiveness, tapos na yun eh. Huwag na siya sundin. Start CPR. Pag start CPR, tit, 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 yun ang sundin mo. 2 minutes yun. After 2 minutes, analyzing, diyan ka hihinto. Para hindi makuha yung electrical ano ng katawan mo, babasahin yan. Shock advice, stand clear. So doon ka na. Ilan pa kayo? Wala pa, nag-iisa ka pa lang. Pero gagamitin mo pa rin yung safety chant. Where I'm clear, titingin ka na hindi ka nakatouch sa pasyente or sa metallic object na kung ang pasyente ay doon nakalagay. One and clear, kung wala kang kasama, kay clear, pindot ka kagad. Pero kung may kasama, kunwari airway, to your clear, titingnan mo si airway. Be sure na si airway, nakapatay ang oxygen. Okay? Electricity yan, si AED. May oxygen ka dyan, kunwari basa yung dibdib, nag-spark yan, patay tayong lahat. Tandaan nyo. For us to have fire, okay? Alam niyo ba yung triangle of tetrahedron of fire? Tetrahedron. Para may fire, merong 4 na component. The primary three, the oxygen, the heat, and the oxygen, the heat, and the fuel. Yung pinaka-fourth niya ay tinatawag nating chain reaction. So, patay mo na i-zero kasi for us to have fire, alam niyo naman yung ano no? Do you know how many percentage of oxygen in the environment right now? Following Dalton's law? Dalton's law? So 21%, no? Familiar kayo sa physics, no? Dalton's law. I know you love physics kasi siyempre, pinakamagandang subject ang physics. Para maintindihan natin ang mundo, physics lang yan. Kaya dapat favorite subject ang physics. Hindi ko alam bakit takot sa physics ang tao na kung saan ang physics, ayan yung sasagot sa yung mga while you are still living. No? Tapos pag pumunta ka na sa tao, anafisyo ka lang. Pag magaling ka sa anafisyo, dako, yung medical practice mo, kuhang-kuha mo na malaking percentage. Kasi, you know, the normal, kuha mo na sa abnormal. So, si Dalton's Law, 21. Pero, tandaan niyo to, ladies and gentlemen, para makapag-start ka ng fire, mag-start ka sa 16% of oxygen lang. Eh, yung lumalabas sa oxygen mo na green is 100%. The more magka-catch ng fire yan. Okay? Tandaan yan ha. Dalton's Law. And then, AED na, check rhythm, shockable ba versus non-shockable. Pag shockable, ganito maririnig mo sa AED. Analyzing. Ilang segundo yan? Analyze. No shock advice. Continue compression. Ganun lang si AED. Or, no shock advice. Check pulse, check for pulse, or check responsiveness. Mga ganyan. So, susundin lang natin siya. Kaya tinawag siyang automated. No? So, I'm gonna discuss to you AED, ilalive ko na sa demo, ano na. Mamaya, meron tayong demo, no? Mga gagawin ko, siguro mga around, a little bit later. Demo lang lahat yan. So, ayan, no? Titingnan nyo ang buong algorithm ng 2020. Ito yung luma. Walang emphasis gaano sa bagbal mass, doon, yung using level 3 or level 4, wala. Ito yung luma. Halos walang pinagkaiba. Na-emphasize lang talaga yung sa bago, yung limit personnel, doon PPE, tapos kailangan bago mag-compress, may nakalagay na sa mouth para hindi magliparan yung microparticles. Ito pa rin yung luma for child and adult. Tingnan ninyo. No? Walang pinagbago other than PPE and then paatras ako ng paatras. Mga 2015 down. Okay, 2015 down. Ito 2010 down. Halos wala namang pinagkaiba. Ang latest lang kasi yung speed. 120 na tayo ngayon per minute. 100 to 120 per minute. Okay? So, this is still being followed. So, ayan. So, check victim's responsiveness. Tapos 911 sa depende. Adult and older child, if you are alone and do not have mobile device, leave the victim, no, and call for help. Okay? Pag child and infant, if you are alone and naka-witness ng collapse, leave the victim and activate call for help. So, the same pa rin. Okay? 30 compressions of 2 breathing, 1 rescuer. Kung in hospital. Pag out of hospital, hindi naka-emphasize dito, all compression lang. Okay. Ito yung mas luma pa. Tinitingnan nyo, I'm always trying to excavate how we developed ourselves, no, in the course of learning basic life support. Luma na to. 2010 down pa to. That's more than 10 years ago. Okay. Ito yung indinagdag nila sa 2020. Nakagawa na ng libro, wala na magawa. Nag-release sila nito. Pwede mong i-print para idagdag mo sa insert mo lang sa loob ng libro. So, sa chain of survival, pareho pa rin. Activate pa rin yung call 911 and get an AED. Nagdagdag lang konti na before you compress the patient, dapat meron kang protection, no? You cover your using mask, and then the patient also. So, ito yung American Heart during COVID-19. Now, in this picture, as you see, pag maganda ang compression mo, push hard, push fast ka, umabot ka ng 140 to 160 millimeters of mercury. Ganyan ka-effective siya. Pero ang problema natin, humihinto tayo kasi magbigay ng breathing. So yung oxygenation to the brain, namamatay for less than for a second or more. Kaya kung pansinin niyo, kung hindi tayo hinto, tuloy-tuloy lang yung CPR, ang oxygenation to the brain, mas maganda. Wala kang binibigay na breathing. No? Ang maganda nito, habang nagko-compress ka, pag naka-non-rebreather mask, ang pumapasok na hangin papunta sa brain ay nasa 90% oxygen. Continue CPR lang. Imagine niyo wala na tong itim na to. Kaya advocate ako ng all compression. Okay. Now, I'll discuss briefly on, kasi gusto ko siyang i-perform, no, sa demo. Ito, life-saving to. Nagawa ko na rin to. Not really so many. Sa field, no? Naka-anim yata ako. 3 foreigner, 3 local. Isa sa pinaka-nahirapan ako, isang foreign doctor. Doctor pa siya, Egyptian doctor, malaki sa akin. Balagbag kami, tumba kasi sobrang bigat. Nawalan siya ng malay, pero naalis ko yung obstruction. So dati kasi meron tinatawag na partial obstruction with poor air entry and partial obstruction with good air entry. And then complete obstruction. Ngayon hindi na, binago na nila. Mild obstruction, no? And then severe obstruction. So sa mild obstruction, usually ang breathing niya, may marinig kang wheezing, tapos pilit niyang iubo. Okay? So ang gawin mo, stay with the person, doon ka sa side, huwag ka sa harap niya. Tapos tinatapik mo yung likod cuff while you are calling for help. No? Tapos ang pag-inhale nito, short lang, gagawin mo pag-inhale. Huwag masyadong bigla para hindi lalong lalalim ang pagbaon ng obstruction sa airway. Kailangan, tapos sabay ubo, ganon. Tapos hinga. Although hindi talaga makahinga ng mahinahon ang pasyente. Talaga siya. Okay? Pero pagdating sa severe obstruction, usually meron tinatawag tayo, naranasan ko talaga to in several occasions, yung tinatawag na sense of doom. Ano ibig sabihin? Pati ikaw, hawakan ka, punit-punit yung ano mo, pag humawak yun, para kang kinikwelyuhan, sense of doom yan. Pasyente, alam niya para siyang mamamatay. So, clutching the neck, yes, nakita ko. Pero mas maraming pasyenteng pag humawak sa'yo, grabe. Okay. Tapos, minsan, hindi na makaubo ng maayos. Hindi makatok. Tapos, meron siyang stridor or high pitch sound. Yung stridor yung gumagano na. Tapos, nagbabago ng kulay, naging pallid na siya hanggang maging cyanotic. So, dito na tayo mag-abdominal thrust. Yung abdominal thrust, dati tinatawag natin itong Heimlich's. Pero sa mga bagong libro, ang term niya abdominal thrust na. So, okay. So, yan ang posisyon. Mamaya, i-ano ko. I will just demo it. But I want to correct some few things. Ang tinuturo po natin is, ang pinakamalapit sa program ng WIPAM, ang WIPAM kasi is ASI tayo. American Safety and Health Institute tayo, recognized tayo. Tayo ay parang sabihin na we are a provider under ASI. Ang sinusunod ng ASI ay AHA. Hindi tayo sumusunod gaano sa American Red Cross. Sa American Red Cross, tinatap parang bata ang likod, tinatapik yung scapula. So American Red Cross po yan. Ang sinusunod natin ay American Heart Association. Hindi po tayo nagbabackslap. Ang binabackslap lang ng AHA ay bata. Yung infant, no? Yung infant. Backslap, yung 5x5. 5 chest thrust and 5 backslap. Sa adult, no way. Okay? Sige, mamaya na lang to. I-demo ko na lang. Sa AED naman, very common ang AED, no? Ang pinakabagong AED ngayon ay merong halos 3 switch or 2 switch. The first switch is the on and off. No? Yung 3 yon. Yung 2 switch, ang switch niya ay yung lead. Pag inopen mo yung lead, magtutunog na si AED. Unit okay. Apply pads. Yan. So, depende, ano? Pa-mute lang po. So, apply patch. Yung 3, pindot mo, tapos, pinakabago ngayon, merong pedya sa ka-adult mo. Pag pedya, kailan may pedya? Pag 8 years old below, para mag-adjust siya ng joules. So, pipindutin mo yon, pediatric mode. Ayan. As yung mga 3 pindutan, shock po yon. Kapag ang pasyente ay nangangailangan na ng shock. So, yan lang naman ang shortcut niya. Turn on AED, place patch on victim, meron siyang drawing, at meron siyang command. Tapos, gagayad ka niya paano mag-start ng CPR. No? So, tulad sinabi ko kanina, pwedeng on and off button or by opening the lid or faceplate ng AED. Kung siya ay merong nitroglycerin patch, i-remove natin. Huwag idaan doon ang patch or ipatong ang patch. No? Okay, and then, dito lang naman is-sequence, pero sa totoong buhay, kailangan po walang humihinto na CPR. Tuloy-tuloy po yung CPR habang naglalagay ng patch. Pero pag ang pasyente may balahibo, almost all AED ay merong laman na yung pang-shade. So yung kasamahan mo, sinishade niya, or else, pangit ang delivery ng ating electricity. Yung iba naman, para mabilis, medyo magastos, nilalagay yung pads, tapos tinatanggal para matanggal yung balahibo. Pero hindi pwede sa Pilipinas. Bakit? Yung isang set ng pads po, lalo na Zol, ay nasa 8,000 pesos. Ba't ko gawin yun? So, merong tinatawag na one pad goes on the upper right chest, no, below the collarbone, yung sternum side, at saka yung tinatawag na apex side, no, doon sa lower left side chest wall. Yan, sa picture. Okay. And then, pag sumigaw ang AED na analyzing, shock advice. So, ikaw magtitsan ka. Sa totoong buhay, ACLS chart ay tuturo ko. One hand clear. Sasabihin mo ito lang, one hand clear. Tinignan mo sarili mo. Two, you're clear. Tingin sa airway. Then, three, everybody's clear. Sasabay lahat, sigaw, clear. Okay? Ulitin ko, one hand clear. Ako lang yon. Two, you're clear. Sisigaw sa airway, clear. Pero ikaw, bago sumigaw ng clear, tingnan mo kung naka-zero si oxygen. Two, you're clear. Minsan may delay ko. Clear. Then, tingin three, everybody's clear. Sigaw lahat, pati si airway, clear. Pindutin yung button na na parang may kidlat. Yun yung pang shock mo. So, sisigaw si AD, shock given. Check for pulse or shock given. Continue CPR. Yan. Or, kung hindi naman, no, analyzing. So, walang hawak sa pasyente. Segundo lang yan. No shock advice. Ayan. Continue CPR. So here, if you look at the picture, ventricular fibrillation po yan. Yan po ay shockable rhythm. Ang non-shockable rhythm ay yung assisted. So again, push the shock button, no, or AD prompts a shock, make sure no one is touching the victim. Okay, manood tayo ng palabas, minsan may mga nakakatawang palabas. Number one, may nakikita kang palabas na flatline, sinashock. So hindi po sinashock. Ang AD, hindi talaga magsashock yan sa flatline. So kung sa palabas nakikita niyo na kunwari lang nag-read out ng flatline or asystole, then nag-shock, kalokohan yun. Wala hindi nag-research yung researcher nila sa movie. Pangalawa, marami ako nakitang palabas na ginawang weapon ang defibrillator. Hindi po pwede gawing weapon. Bakit? Una, nagsuntukan kayo, kinuha mo yung defibrillator, sinyak mo yung pasyente, hindi po pwede mangyari. Kasi kailangan po, sa manual defibrillator, mag-charge ka pa po. So pag nag-charge, takes time, nasaksa ka na. Nasuntok ka na ng 10 beses. Bago na, charge up. Gano'n. Ilang suntok na, nalipad ka na sa suntok. So, doon mo makikita sa palabas, kalokohan, hindi yung nagsuntukan, nakakuha ang deprib, boom! Lipad yung tao, malayo. Lipad siya. No? He was like catapulted. Di po totoo yan. No? Bakit? Alam niyo, kung ibubultahe ko lang yung 200 joules, 20 volts lang yan. Masakit ang 20 volts, totoo yan. Lulukso ka. Pero not enough para lumipad ang tao. Ha? Tandaan nyo, 20 volts. 200 joules is 20 volts. Okay? So, ito lang yung I'm not gonna read. So, AED and children. Bihira po sa mga pasyente, sa mga children ang nagkakaroon ng cardiac arrest. Ang sa children is respiratory arrest. Pero meron tayong tinatawag na child mode at saka merong pads pambata at paddles na pambata. AED and wet person. Kailangan po walang basa. Bakit? Magfo-false read ang AED, mawendang siya, hindi niya mababasa. Kailangan walang basa ang dibdib kapag galing sa drowning incident. Tanggalin ang basa, walang basa bago lagyan ng ano. Tapos ang pasyente dapat nakalagay sa hindi basa kasi ang tubig ay conductor electricity. Ilagay natin sa dry very fast, no? Para walang contact doon sa basa. Kunwari, board. Tapos ilipat natin sa dry surface, doon tayo mag-CPR, mag-AED. AED and hairy chest, kailangan po natin i-shave yung hairy chest. AED and pacemaker, ang pacemaker ay nakalagay po dito sa itaas dito sa left upper chest. No? So hindi po siya matatamaan. Bawal po maglagay ng sa pacemaker, ng pads. Pero karamihang internal pacemaker ay nasa upper left chest. Kaya hindi madahagip ng AED pads. AED and bra, o syempre, tanggalin natin ang bra. Pero kung masyadong bare, pwedeng nakapatong lang yung bra kasi non-conductor naman. AED and jewelry, tanggalin po yung jewelry kasi conductor po, kung lalo na metallic yan, conductor po ang jewelry. Ayan. Yes, AEDs can be used. Meron silang pediatric paddles, no? Or pads. Pero kung adult pad, hindi tayo pwede mag-sternum effect, kundi sandwich position po ang tawag yan. Okay? Tingnan niyo sa picture, isang nasa anterior, isang nasa posterior. Ang tawag dyan, sandwich position. Okay. So, ayan, no? Hindi ko na, ano. Pero dito, ignore jewelry if it will not touch AED pad. Yan. Huwag naman ganito. So, ang gawin natin, i-bye-bye lang natin doon sa likod yung kung kunwari may malaking, what you call this, yung kwintas. I-bye-bye lang sa likod kung hindi natin matanggal. Kasi as long na hindi siya mag-touch sa pads, walang problema. Now, let's go into naloxone. So, dalawang available na naloxone. Narcan, yung familiar tayo, saka Cloxado. Si Narcan, mas lower ang dose. Meron siyang 2 mg actuator, saka 4 mg actuator atomizer. Si Cloxado, 8 mg siya. So, mas malakas si Cloxado. So, paano natin binibigay? Dahil basic life support, dati ang Narcan ay binibigay natin intravenously. Ngayon, available na siya as atomizer. Ano yung atomizer? Yung sa ilong. Sinusuksok sa ilong, kaya ganyan ka-mist, no? Atomizer tawag namin dito. Nasal spray. Suksok sa ilong, drive sa ilong. So, paanong forma? Ganito. Yan, no? Ilong, yan. Cursor ko, kung hindi kayo naintindihan, tumata. Drive para pumunta sa turbinates, ma-absorb doon. Kahit magaling ka pa mag-CPR, hanggat may opioid sa katawan yan, hindi mo talaga ma-reverse. No? Mamamatay yung tao. So, kinokontrahan natin yan ng naloxone. So, I will not discuss so much on the naloxone. Dito tayo sa 10 Commandments. Ang tinuturo sa Philippine Heart Association ay 5. Hindi ko sinabing magaling ako. Kasi 10. Kaya sinabayan ko 5C sa Philippine Heart Association. Ako naman 10C, pero ayaw ko sabihin 10C. Baka pag-isipan ako na mas magalingan ako kaysa sa Philippine Heart. So, tinawag ko ng 10 Commandments. Ito po, hindi ibig sabihin na gagawin nyo to sa inside the hospital, sa out of hospital. Baka tanungin nyo ako, bakit out of hospital? In hospital naman kami. Okay, guys. Alam nga naman, kayo may-ari ng hospital, hindi kayo uuwi. Doon lang kayo. Or, hindi na kayo umuwi, sa hospital lang kayo. Siyempre, uuwi pa rin kayo sa bahay. What if pagdating along the way na umuwi kayo, nakakita kayo ng cardiac arrest? Wala namang nakalagay sa PRC ninyo na hanggang alas 5 lang kayo magtatrabaho at sa ospital lang. So kahiya-hiya na nurse ka o doktor ka, hindi ka marunong mag-address sa pre-hospital care. Kasi yung kapitbahay ninyo, alam niyo nang gumraduate kayo, yung mukha niyo nakabalandra sa community. Congratulations! Kunwari, Mylene Ngoho, RN. Oh, kunwari gano'n, no? Kunwari lang si Mylene nag-shock. Binalandra. Pati every Tom, Dick, and Harry in your community knows you are the nurse. So kahit anong mangyari sa community, tatatakbo sa'yo. Ma'am Mylene, yung anak ko hirap huminga. Ma'am Mylene, naputo lang kamay ni Kulasa. Mga ganun. They go to you. Basta anyone in uniform, police ka man, sundalo ka, pag may mangyari sa community, tatakbo sa'yo. Kaya nire-require among sa kapulisan, kasundaluhan, na marunong sa first response beyond first aid. Yan. So, kailangan matikas din tayo sa field. So, itong commandments, ginawa ko po ito, kailan? 20, may date ba? I think 2020 ko ginawa to, kasagsagan ng COVID. No? Number 1C. Sa field, pag may bumulagta na tao dyan, rule number 1, consider it to be COVID positive. Yan. Para hindi ka kumumpiyansa. Number 2, check-in. No? Ang word na check-in ay ginagamit natin sa ICS, Incident Command System. Ibig sabihin, pag nandyan ka, meron kang gustong i-offer, you have to check in, mag-abiso ka. So, kaya ginamitan ko ng C. para hindi ako naligaw sa letter C. So check in. Pag sabihin mo, ay, sir, rescue po ako. Baka po makatulong. The word is maybe I can help. Sa Filipino culture, wag ka magsabing I can help. Pag namatay yan, hanggang libing, ikaw magbabayad. Pag na-ICU yan, hanggang ikaw magbabayad. Kasi nagsabi ka I can help eh. Pwedeng gano'n, no? So maybe I can help. Okay? So check in. Next is crowd control. Dito sa Pilipinas, nandoon sa Iraq, nagigira na sa Iraq, ang mga Pilipino nandoon sa penthouse, nanonood, nagliliparan yung mga missile, kumukuha pa. Osyosero ang Pilipino. So ngayon, nag-collapse dyan sa kalye, mas maraming osyosero kaysa sa maraming gustong tumulong. Lalabas ng cellphone, instead mag-CPR, nangyari yan sa akin. I came from CDO just a few days ago. Nagturo ako sa mga DepEd nurse. Nung pauwi na ako sa Manila, nasa airport, merong tao na pinansin niya ako, Esguera. Yes po, sir. Ay, ako po si Chief, nakalimutan ko pangalan niya. Retired Special Operations. Sir, thank you for saving my friend. Hindi ko maintindihan ng saving my friend. Si Chief Salyaw. Wala talaga akong maintindihan. Sa dami-dami kong nasagip na buhay, wala akong tala sa inyo. Sabi ko, saan po kayo? Retired Coast Guard po ako, Special Operations Counter-Terrorist Unit ako. Good, sabi niya. Naalala, yung nag-carjack arrest, ko po yun, bunkmate. Pag bunkmate, kabats niya. Naalala ko na. Sabi ko, yeah. I remember him. Salamat sir, na buhay mo siya. Grabe yung effort ginawa mo sa kanya. Kasi, namatay siya saglit. Walang nag-start CPR. Tapos nagtuturo ako sa counter-terrorist unit ng combat medicine. Bumulagta doon, walang nag-start. Isipin mo, in the middle of lots of rescuers ng Coast Guard, wala man na nag-start ang CPR. Very good talaga, no? So, sinipr ko. Nagkataon, may sarili akong defibrillator sa sasakyan. Dinifibrillate ko. Naka-twice ako nag-fire na buhay. Except nangitim yung dibdib, kinasuhan niya ako. Kasi nangitim ang dibdib. Kaya hindi ko siya makalimutan. Sa dami-dami ko nasakit na buhay, hindi ko siya makalimutan because he filed a case against me. Kasi nangitim ang dibdib eh. Sa defib at saka sa pag-CPR. Pero nabuhay siya. Kaya sabi ko, nagpa-picture kami dalawa, pinost ko sa Facebook. Na nagkita kami, nagpasalamat na siya. I recognize your effort. Grabe siya. Thank you very much. Buti pa siya nag-thank you, pero yung taong binuhay ko, hindi man lang nag-thank you, no? Kinasuhan pa ako, loko-loko talaga. Sabi nga ng counter-terrorist unit, sir, gusto mo, ilubog lang na namin sa dagat. Walang, it's just okay. Twice nangyari sa akin yan. Yung isa naman, nag-transcutaneous spacer ako. Transcutaneous space ko, foreigner, German. Nangitim din yung dibdib, gusto ako kasuhan. Pero totoo yun guys, kung nagkataon nasa US, Canada, New Zealand, Australia, London, doon sa baryo ko sa London. Kung nandun lang ako, kasuhan ako kasi nangitim ang dibdib. I can go to jail or I can be penalized. So nag-pacer ako, German national siya. Galit na galit, pero binuhay ko siya. Buong gabi, yung heart niya nagbibit na lang ng 30 beats per minute. Hindi na umubra si atropine, si dopamine. Nag-transcutaneous pacer ako. Kailan yan? 2004 yata? 2003, 2004. Sa Zambales, sa Philippine Merchant Marine Academy. Nabuhay ko. Pero na-ICU siya. Nalagyan siya ng pacer. Kinasuhan pa ako. Pero hindi niya ako makasuhan kasi nagsumbong sa government sa Germany. Sabi ng government ng Germany, he's not a German doctor. Punta siya sa St. Louis kasi nung sa Zambales, nang nag-pace na ako, naubos na yung diazepam ko, dinadiazepam ko, pinapatulog ko kasi masakit yung pacer. Kinabukasan, early morning, inermedib ako. Nilipad ko papunta sa St. Louis. So he stayed po sa St. Louis mga 2 weeks. Less than 2 weeks. Tapos, nung nakalaya na siya, meron siyang pacer, kinasuhan niya ako. So, pumunta siya sa German Embassy, tapos pumunta sa St. Luke's, nagreklamo siya doon, sabi ng St. Luke's, paano namin kasuhan? Hindi naman namin siya doktor. So, nahilo siya saan niya ako kasuhan. Nang nag-usap kami, parang normal lang, thank you for saving my life. but I'm gonna file a case against you. Parang gano'n. Parang normal niya akong kinausap, pinasalamatan at normal lang din magsabi. Sabi ko sa isip-isip ko, sira ulo 'tong tao na 'to. Pero you know what's the funny thing other than that? That guy, ang pangalan niya, ayaw ko i-reveal yung pangalan. Siya yung nakakontrata magtayo ng simulator sa Philippine Merchant Marine Academy. Nag-donate siya ng mga gamit doon sa clinic sa PMNA. Yung dinonate niya na gamit na defibrillator, may transcutaneous spacer, ginamit ko yun sa kanya. Ganda na. Yung gamit na dinonate niya, bumalik sa kanya. Galing na. So, yeah. So ito, crowd control tayo. Bakit? Kasi ayaw natin maraming crowd kasi nangyari na sa akin to. May tinulungan ako sa podium, binangga ng FX. May bit-bit akong Starbucks doon sa napakaganda kong Starbucks na lagayan. Aba, nilagay ko lang doon sa island habang tinutulungan ko. Yung Starbucks ko, tinubuan ng paa, tumakbo. Ninakaw. So, wag tayo maraming tao, pwedeng manakawan ka ng gamit or mag-super spreader ang COVID. No? Mag-super spreader.
Kabang alam.
Panimute lang po ako, Sir Marlo.
Nakala ko sa Dawson.
Sir Marlo. Pamute lang po, Sir Marlo. Yan.
Sorry, Doc. Sorry po.
No problem. The next C is check for hazard. Siyempre, nandun ako sa pasyente. Alamin ko anong hazard. Nakuryente ba to? Pag hindi ko alamin, makukuryente din ako. Nasa gitna ba ng kalsada? Baka ako mahagip. Katulad ni Siren, nalaman niyo ba, nabalitaan niyo? May isang responder nagresponde. Namatay po siya ngayon, nasa Cotabato po. Kawawa. No? Kawawa siya. Namatay siya, nasa ambulance, nagresponde. Binangga siya ng kotse ng pulis. Patay siya. Grabe, no? So, sa lahat pa ng tao mamatay, mga ganun. Si Siren, ang tawag sa kanya, Sweet. I met her once lang. Kaburol, tapos very young. Sakit sa magulang yan. Gustong-gusto mag-rescue. Kaya nasa DRR siya. Okay. So, kung nasa field naman, kung may hangin, dapat ang hangin na sa'yo para yung aerosol niya, pag lumabas sa bibig ilong niya, palayo sa'yo. Number 5, check for responsiveness. Pag nag-check po kayo ng responsiveness, mamaya ituturo ko. Yung left to left, right to right, tapos trapezius pins. No? Pagtapik, sir, or kuya. Tapos pag walang response, ipins niyo yung trapezius para ma-elicit natin kung meron siyang painful, kung magre-respond sa painful stimulus. Bawal po ang sternal rub. Bawal. 2015, pinagbabawal na po yan ng American Heart. Yung sternal rub, yung ganito, pinagbabawal. Pero marami pa rin gumagawa. Bakit? Kasi alam mo sa ibang bansa, pag nagkapasa ang pasyente, pwede kang kasuhan. Pag nag-sternal rub ka, papasa yan. Then, if the patient is unconscious, call 911 or call for help, mga ganun. Then, bago mag-CPR, cover the patient with mask. Tapos, i-tilt mo sana yung head ng patient away from you kung walang cervical spine involvement. Bakit? Para hindi lilipad ang aerosol papunta sa'yo. Then you can start 1 per minute, straight, kung kaya mo straight to mask, mouth to mouth. Okay? Kasi solo ka lang, nasa field ka. Then, habang nagko-compress, nagkataon, sinuwerte ka naman, merong defibrillator, letter C, connect to the defibrillator and wait for the voice prompt or follow the voice prompt. Nabuhay mo or hindi nabuhay, ongoing CPR, number 10, kasagsagan ng COVID, ginawa ko to. Kaya ginamit ko yung word case evacuation. Ang case evacuation ay isang terminology ng combat medicine. Kapag ang isang sugatang sundalo ay isinakay mo sa isang ambulansya or air medevac helicopter designed for medical evacuation, ang tawag tactical evacuation. Pag sinakay mo sa helicopter na hindi design sa medevac, ang tawag doon case evacuation. Ganon din sa lupa. Isinakay mo sa ambulansya, ang tawag doon tactical evacuation. Isinakay mo sa likod ng pick-up or na hindi sa design na ambulansya, ang tawag case evacuation. So, letter C ulit. Number 10, case evacuation. Bakit? Nung panahon na kasagsagan ng COVID, tandaan niyo ito ako, naka-ethnic. Simula alas 3 hanggang alas 5, wala pong tumulong sa amin. Kasi lahat ng ambulansya ay nakadedicate sa COVID. So ito, bumulagta sa motor, tinulungan namin, tinawag ako alas 3 ng umaga. Isipin mo, may pulis pa yun ha, merong pulis. Pero walang tumulong. Walang ambulance in the heart of Manila. So ang nangyari, nakakuha ng dinala ng pick-up. Nag-commander ng pick-up. Ayan. So ang tawag doon, case evacuation. So that's your tendency of survival. Yan. Ngayon, kasama sa basic life support, hindi pa talaga full-fledged na in-incorporate. Pero mahinay na in-incorporate ang stroke kasi mataas din yung incidence ng stroke. Sinama na yung stroke at sa basic life support, alamin lang natin ano yung mga parameters to know na patient is suffering from stroke. Okay? Ikinumbine ang Cincinnati Pre-Hospital Stroke Scale into an Adjust Cincinnati. Ang Cincinnati Pre-Hospital Stroke Scale ay fast. Ngayon, yung adjusted ay tinawag nating ito B-fast. So number 1, letter B, there is suddenly loss of balance. B, balance. Loss of balance and or brain fog. Sudden, yung parang nakalimutan, hindi alam anong nangyari sa paligid, brain fogging. And or behavioral change, para siyang hindi ma-maintindihan ano yung behavior. So tatlo po yung B. And then eyes, sudden blurring of vision. And or yun ay, ibig sabihin ito lahat, hindi lahat pwedeng mangyari. And or. Tapos, and or facial asymmetry. Yung one side of the face nag-droop. And or arms or leg weakness on one side. And or slurring of speech. So yung T natin, time. Bilisan. Kasi stroke yan. Wala kayong magawa. Para CT scan, malaman natin pag yan ay bara versus sumabog na vessel. Yan po ang emphasis. Hindi pa yan nakalabas sa interim guidelines, pero in the future, isasama na sa BLS si stroke. Inunahan ko na lang kayo. Okay, ito po ay isang real scenario. Although ACLS to. So status epilepticus ng bata, kinuha namin sa Dumaguete, kasagsagan ng COVID, at nabuhay namin siya papunta sa PGH. So ano ang, although ACLS na to, no? Ano ang forma ng nag-BLS? So 4 lang po. Initially pag BLS, kung solo ka lang, compression ka lang, tapos kung may EED ka na maabot, ikaw na yung nagko-compress, ikaw yung mag-EED. Dumating si airway, yan. Dumating isang tao sa BLS, yan yung trio. Nagde-defib, nakapalit ni compression. Tapos si airway, wala siyang kapalit. Airway lang siya. So nag-compress ng 30, bigay ng hangin dalawa, 1 and 2. Kapag dumating na isang tao or meron ka ng cold blue team, ACLS ka na, IV meds na yun. Saan si team leader? Defibrillator. Sa lumang panahon, si team leader ay nasa paanan ng pasyente. Dahil sa interim guidelines of 2022, in-emphasize nila na mawala na tong leader dito para ang 5, 4 na lang. Ang team leader is also the defibrillator guard. Okay? Kapalit ni compression para hindi mapagod kasi yung emphasis ng 2020 American Heart Association is palitan si compressor every 2 minutes. So magpapalitan lang yan sila. So the compressor now is also the team leader. Kaya sa Code Blue, pag nag-standard Code Blue training talaga sa ospital, lahat is capable of team leading. Kasama yan sa Code Blue training, ang team leading. Hindi katulad ng dati, si airway pwede palitan. Ngayon, si airway, fix lang siya. Ang airway is not necessarily 1 man. It can be 2 people. Pero hindi na pwedeng magpalitan. Ipapalit sa iba na magiging IV siya. Kasi yung tinatawag nating closed circuit assembly, kasama tao doon. Pag ipalit-palit ko siya, pinapakalat ko rin si COVID. Kung si COVID naka-confine lang dito na hindi ma-airborne, hindi aerosolized, dyan lang siya. So yung mga aerosolized, pag dumikit sa katawan nila sa gown, tapos lumipat ako, nasagi ko si IV med guy or staff, nahawa, na ano na siya, napahira na siya. Kaya si airway is mandatory, static lang siya, dyan lang siya. Okay. When do we stop CPR, ladies and gentlemen? We stop CPR by remembering stops. Number 1, S, spontaneous return of breathing and circulation. Siyempre, bumalik na yung buhay, huminto ka na. T, transfer to higher level of care. For example, EMT ka. EMTB, dumating si EMT paramedic, huminto ka na kasi take over na. Ngayon, EMT paramedic ka, dinala sa ospital, nag-take over si ER nurse, huminto ka na. Take over na siya. So, yun yung transfer to higher level of care. Oh, operator is exhausted. Mamamatay ka na kasi CPR, huminto ka na. Baka ikaw yung pangalawang mag-arrest. Okay. P, physician's advice. Oh, sa legal medicine, the physician is the captain of the ship. Huwag ka nang kumontra. Unless the physician medyo hindi siya familiar, i-correct mo lang siya in a nice way. Pero physician, kunwari ako, hindi ko naman sinabing magaling ako, pero linya. Pag sinabi kong guys, stop, hindi na ako kontrahin kasi part sa pinag-aralan ko is I have to ascertain between the probable signs of death versus the definitive signs of death. Pinag-aralan ko yun eh. Huwag na kayong kumontra kasi sa legal med, the physician is the captain of the ship. Yeah. And then as scene becomes unsafe. Kunwari, nagsi-CPR ako, tapos sumabog yung oxygen doon sa kabilang room, nasunog, anong gawin ko? O di hinto ang CPR, kalad ka rin yung pasyente palabas, kalad ka, kung hindi mo kaya, nag-iisa ka lang, kalad ka rin mo, yung tinatawag na blanket drug, lagay mo sa blanket, pagdating mo sa hagdan, kalad ka, walang nang pagkit, magalit man yung magalit, pero hindi mo kaya yung pasyente, wala kang katulong, kinaladkan mo yung head part, yung kanyang puwet bumabangga sa stairs, flight of stairs. Bag, pababa. Pagdating sa first floor, paglabas, walang katulong, dinrag mo doon sa parking, tuloy ka CPR doon. Yun. When the scene becomes unsafe. Tandaan nyo ha, stops. Okay. Paano kung na-break ng rib? Makakasuhan ka ba? So meron tayong Article 12 dito sa RPC natin o Revised Penal Code, Paragraph 4. Any person who, nurse and doctor, while performing a lawful act with due care, pero talagang on that moment, talagang nag-snap lang yung buto, causes an injury by mere accident without fault or intention of causing it. Okay? So, the circumstance will exempt you from clinical liability. Kasi, in good faith naman ginawa. Hindi mo naman, unless di ka marunong, ang posisyon ng sole of your palm ay nasa ribs, hindi sa sternum, madadali ka. So meron tayong Article 12, Paragraph 4. Okay, remember, 85 to 90% of arresting patients will show ventricular fibrillation. Yung kirig-kirig na ventricle, hindi pulseless beta. Okay? So, yan po yung si Chief Caliao, nag-cardiac arrest. Nag-fire akong dalawa, nabuhay siya. Hindi ko na alam anong nangyari sa buhay niya ngayon. Hindi naman siya nagparamdam kung buhay o patay pa. Pag buhay siya, nagpasalamat man lang, hindi ko naman inais pasalamat. Kung patay siya, minulto man lang niya ako. Pero, that moment, ang ganda, maraming witness paano siya nabuhay. Okay? So, guys, that ends the lecture. Now, I'm gonna give you like 15 minutes break. 15, yeah, 15, because I will assemble an extra camera and dummies para ituro ko paano mag-rescue breathing, F-wow management, tuturo ko ha. So, sige, magkape muna kayo para hindi kayo maantok. At mag-aayos lang ako na Okay, and you have any question? So you don't have any question. So I will prepare my demo materials. Kung meron kayong tanong, you can post it inside chat or write it in the chat or maybe later kung wala pa kayong ma-device or maisip na tanong. Okay, so 15 minutes.
Hello po, good morning po. For your attendance po, kindly send your names po na mag-a-appear po sa certificates sa meeting group chat po. Mag-send po ako ng example sa group chat po. Also, ilalagay nyo din po yung training po na in-enroll nyo po. Thank you po.
With echo. Number 1, doon tayo sa choking. Sa choking, sensya na, yung mga damis, nahihiwala yung ulo. Tinali nila pa. Sa choking, yung mild obstruction sa severe obstruction. So yung approach mo sa mild obstruction, be on the side of the patient. If it's sitting down lang muna. Nasa side ka, tapos malalim ang obstruction. So, comfort mo siya, sir. Hinga lang, hinay, inhale. Tapos, tapik sa likod, cup. Cup, sir. Sige, cup. Ano? Cup. Huwag na yung cup sunod-sunod. Hinay. Pantayin mo kung nag-color. Tapos, kung may marinig kang sound. Cup. So, mayroong cup na malakas. May cup na pag grabe na obstruction, hindi na malakas. Or no cup. So, ganun ang approach na. Now, if there is severe obstruction, usually the patient is struggling. Side ka pa rin kasi pag nagkaharap kayo, pag hinawakan ka niya, hindi ka makapag-maneuver. So, side ka pa rin. And then, kung kaya niyang tumayo, sir, sige, tayo, sarili na tayo. Para nasa likod ka to prepare for abdominal thrust. Yung paa mo, nasa between sa limbs niya. Na ganun. Para kasi kung ikaka ka lang gano'n, nasa in-between yung paa niya, or pareho kayo na gano'n, bigla siya nawala ng malay, at mabigat sa'yo, nakayakap ka, palintong kayong dalawa. Nangyari na sa akin yan, no? Ang laki pa ng mama, Egyptian doctor. So nasa gitna, para in case na matumba siya, the patient can slide. Atras ka lang, maslide mo siya sa lupa, check for responsiveness. If the patient is unresponsive, call for help, basic life support ka. So pag nag-abdominal thrust ka, simple lang, kunin mo lang yung C-point process. Ayun ang C-point process. 2-finger breath na, and then gawa ka ng ganito. Okay, push towards 45 degrees, papunta sa scapular area na. Okay. So isang nakalamera ko, isang nakaside para makita niyo. So boom, 2, pwedeng 3, 3, tingin. May gumawa nito live. Sumuka talaga ang pasyente. Hindi siya na inano lang yung parang sinubukan lang ang feeling. So nasuka yung pasyente. Nagkataon na around less than 30 minutes kakakain niya. So may pagkain pa sa tiyan na isuka niya. So malakas na puwersa to, lalo na pa it's done properly. Until the patient recovers or until the patient becomes unconscious, then you perform CPR. Pero pagkakaiba CPR dito, sa ibang guidelines, yung Utstein style or sa Netherlands, kunwari from foreign body airway obstruction, nagkaroon siya ng nag-block na, perform CPR. Ang ginagawa nila yung 5 and observe. 1, 2, 3, 4, 5, silip. And 1, 2, 3, 4, 5, silip. Para pag may lumabas, kuha ka agad. Kasi usually, pag lumabas yan, ang tendency, ang pasyente, hihigop ulit kasi walang hangin eh. Hihigop yan, babalik sa loob. So, tulungan mo, lalo na pag pasyente hindi na kaya. Usually, pag gaganon yan, side ka agad, bilis ka agad, tapik, tapos sabay sweep out the obstructing material. So, kuha, hindi yung mga 4 counts pa. Hawak dito, boom, papik, tapos kuha. Sige, hinga lang malalim, hinga. Pag nakapabor na, huminga na, magkilos ng kamay, baba mo, yung 4 counts, 1, 2, 3, and then recovery position. Tingin. Yung iba naman, dahil sa COVID, pabaliktad. 1, 2, 3, palayo. Pareho lang yan, as long as you perform recovery position. Same you do sa bata. So, pag unconscious na siya, wala na po tayong abdominal thrust na yun, hindi na po natin ginagawa. So, chest compression ka na diretso. Tapos, tingnan mo pag may lumalabas, you commit to chest compression. Okay? Pag sa baby naman, same thing. You have to check what blocks the airway. Pag nakita, sweep. Mabilis na sweep. No? And then, pag hindi nakita, don't blind sweep. So, gasping yan. Hindi mo alam. Pwedeng ang pinakamalapit sa totoong buhay, hindi mo talaga alam. Ang pinakamalapit dyan ay the mother tells you, merong na ano dyan sa loob. So, ang gagawin natin, 5x5. Sa totoong buhay, kung sa salitang Bicol, malumuyon, very soft ang baby. So sa dami, pwede mo siyang ibaliktad-baliktad na gano'n parang totoo. Pero hindi po, sa experience ko, sa field, hindi. Talagang hinahinay. Sliding, hawak yan. Tapos, gano'n. Tapos, itong kamay, lalaylay pa. Dito. Tapos, pag mag-backslap ka, matatakot ka pa kasi kailangan ito, nandito sa dibdib, ito hawak. Hindi dito. Masasakal siya. Gano'n, no? Ito ang kanyang chest stop, back stop. Yan. Tapos slap. 1, 2, 3, 4, 5. Hawak dito. Hawak sa kamay. Sa training kasi, ginaganon lang. Hindi, sa totoong buhay, naramdaman ko, hawakan mo pa to. Slide. Slide ganon. Hindi kaya ganon kadali. Tingin. Tapos, gagawing itong try mo, gagawing parang chessboard. At tawag nito, parang cardiac board, sorry. Chessboard, cardiac board. No? Kung saan ka mag-compress, tayo. Silip, 1, 2, 3, 4, 5, silip. Pag may nakita, kuha ka agad. Kuha. Pag wala, slide, scoop, hawak sa kamay kasi lalaylay ang kamay. Paglabas, pero slide ulit, hindi mabilis. Sa totoong buhay, hindi mabilis-bilis ganun, ha? Yan ang totoo dyan. Okay? So, 5 backslap. Pag mag-backslap ka, nandito ang spine niya. So, ang tumatama nasa scapular area. Pataas. Huwag itama sa ulo. Kaya, ano, yan, 1, 2, 3, 4, 5. Ulang nahulog. Slide. Hawak, silip. Pag meron, huwag iganon. Ano lang. Kuha. Kunin mo. Slide palagi. Yan. Pag wala nakita, slide. Yan. 1, 2, 3, 4. May lumabas na object. Tayo. Hawak. Sige, kuha. Ganyan ang style. Because that's what I did. Although the baby, nabuhay ko siya. And stayed in the ICU for 12 days. at 14 days, namatay siya doon sa infection. Sayang. Pero nabuhay siya. Nangitim na yun eh, nabuhay ko. So that's for foreign body airway obstruction for adult, same with child, and then for infant. Now, another thing I want to teach you is the use of AED. Again, ang AED ay pang layman, lay people, hindi pang atin. Pero sige lang, assuming ito yung meron tayo. Kaya ko ini-emphasize, kasi dahil pag nag-aral kayo ng BLS, ang maririnig yung AED, puro AED, baka ang pag-orderin nyo sa ospital ay AED. So, malaking kamalian yun. No? Ang in-order natin ay yung standard na defibrillator na merong AED override. Manual siya ng AED override. Okay, so ganito si AED. Wala lang, tinanggalan ko lang ng baterya. So, kahit anong brand, you have to ask me, meron ako tatlong preference. Merong bago ngayon, German technology made in China. Tawag doon, Mind Ray. Okay siya, ginamit ko sa Turkey, gumana. Mind Ray. Okay. Wala lang sa akin. Mayroon ako Zol. Ang matagal kong kasama sa buhay ay Zol. Ngayon, Zol. So yung Zol ko, ano siya, ruggedized military AED siya, ruggedized, pwede mong pagsak, pwede mong sagasaan. Matagal din akong gumamit ng life pack. So sa Zol and life pack, ang life pack ko wala akong AED, puro manual. I have two life pack. Wala na sa akin ngayon. Meron kumuha, hindi sinauli. Pero nasira na siya. Tagal ng panahon. Yung isa, ginamit ko pa sa Mount Everest. Kaya medyo historical. Iniwan ko sa isang AMT school para magamit na nila sa dry fire. Tapos yung isa, hindi sinauli isa. Pero ano na rin, depleting na rin siya. Kasi yung screen, hindi na naglalabas ng display ng ano. Siyempre, lahat ng bagay mayroong hangganan. Pero maganda may historical value sa atin. Tapos nag-donate sa akin ng Zol AED when I was studying in Australia. So nag-donate sa akin ng Zol. So tapos may nag-donate din sa akin ng Zol AED. Yung Zol manual defib, ano pa yung mga luma, 360. Dalawa kasi available na AED ngayon. By virtue of energy release. 360 monophasic saka 200 biphasic. Pag sinabing 360, ang tawag nito pads, yung iba paddles. Ang paddles yung kamay na merong hawakan. Pads. Pag sinabing, yan ang position. Sternum side to apex side. Pag sinabing monophasic, nag-fire to, sasaluin ito. So, meron siyang parang i-accept niya yung impulse or energy coming from it. Hindi pwedeng hindi niya accept. Or else, the electricity will travel all over the body. Bakit? Kasi 70% of our body is composed of water. I mean, water is 70% of our body, and water is conductor by virtue of the electrolytes present in the water. Kaya, di ba, sa physics, electricity travels in time, in line, in space, in time. Okay? So, fire, tanggap. So, yung pag-fire nito, dadaan siya dito, masasagasaan yung heart, kaya ang heart mapupunta. Okay, that's 360 joules. Ang biphasic ganito, mabilis. 200 joules lang siya, mas maiksi, pero dalawa ang nagpa-fire. Fire tanggap, fire tanggap. Dalawa. Fire dito, tanggapin dito. Cross siya, cross. in a millisecond. Tapos fire dito, tanggap dito. Kaya sa biphasic. Dalawa, fire. Okay? Pero hindi niya kailangan na mataas na energy required, hindi siya na energy release in joules. Kasi nakita nila si 360 electricity pa rin siya, nakaka-injure siya ng heart. Nakaka-cause ng heart. But it's still effective kung wala. No? Kung gumagamit ka ng 360, it can still be okay compared to no defibrillation. Because sabi ko sa inyo kanina, CPR with no defibrillation, mababa ang chances of survival. So, pag ikumpleto ko yung package ng chain of survival, so after compression, high quality CPR is the defibrillation. So sa defibrillation, umakit ako between 70 to 80% na ang chances mabuhay siya in a certain age category. Okay. So that's the difference between a monophasic and biphasic. Okay? So karamihang mga modern AED ngayon ay biphasic. Wala na ako nakitang monophasic. Si Mindray, meron siyang adjuster, ito 360. Which is okay. So depende kasi sobrang kapal siguro ng chest ng pasyente, yung skin, subcutaneous tissue, medyo maganda pag tinaasan mo ng joules. So meron mga ganun, adjuster. Magbabago, nag-evolve kasi yung mga machines, time goes. Ngayon, the AED independent at saka AED override. So I'll start with AED override. Kunwari ito ay manual defibrillator with cardiac monitor. So marami siyang switch. Meron siyang 9, lalo na pinakabago ngayon, 9 parameters. Ano yung 9 parameters? Machine with 9 parameters. So, alam niyo? 9 yata yan. Yeah. Isang machine na siya, kompleto na siya. Number 1. Yung machine mo, pag i-on mo, pwede siyang cardiac monitor. So meron siyang limb leads or limb leads, kung high-tech ka pa, can perform 12 lead ECG. Dalawa na. Yung limb leads, yung kinakabitan lang natin ng DAX, limb leads po yan. Ang mini-measure niya, lead number 1, Roman numeral 1, Roman numeral 2, Roman numeral 3, ABR, ABL, ABF. Pero ang kanyang default is Roman numeral 2. Pag nag-ACLS kayo, i-describe ko bakit Roman numeral 2. Ngayon, so what? 2 na. Cardiac monitor with limb leads, saka 12 ECG. Ano pa? Systolic, diastolic, cardiac rate, mean arterial pressure. 6 na. Ano pa? Pulse oximetry. Ano pa? Defibrillator. 9, hindi pala 9, 11 yata or 13. Defibrillator. Ano pa? Cardioverter, transcutaneous spacer, capnometer, 11 nga. Capnometer. So, isang machine, ang dami nagagawa. Pag nag-airme, di ba kayo, maganda yun. Tapos 11, yung pang 12 niya, meron siyang AED override. Kung high-tech pa, meron siyang filter. Ano yung filter? Pag pinilter ko siya, habang nagsi-CPR ka, nababasa niya ano yung rhythm ng heart. Kasi pag sin-CPR mo, magulo po yun. Ang cardiac monitor, maging magulo. Kasi may electricity ako. Pero maganda yung sa machine na yun. Kaya niyang kunin ano ang intrinsic activity ng heart na yun. Kung BF, naka-BF pa ba siya. So pag pindot mo sa filter, kuhang-kuha yung BF. Hindi niya babasahin yung pag-compress mo. Galing na? Ang meron ganyan so far, nalaman ko ay Zol saka hindi ko alam kung cardiac science meron. There was one time, gumamit akong cardiac science, magaling, maganda rin. Kasi study siya, pwede mong itapon yung defibrillator. Mahilig ako sa study material kasi field kasi ako, hindi ako pwede yung mga gamit niyo sa ospital na masyadong cute. Sa akin, kailangan matibay kasi subject to elements. Na uulanan, pag nag-transport, bagsak, nasa loob ng helicopter, grabe yung floor vibration. So, hindi pwede ako na maganda ang gamit ko na cute. Kailangan ang gamit ko matibay. You know, where I'm coming from, no? Sa ganyang type of work. So may AED override. Pag AED override, mag-AED siya. Magsasalita siya. AED mode. Out. AED mode. Yan. Check responsiveness. Yung manual mo, naging automated na. So, correct, naka-CPR na ako. Open patient's bare chest. O, ito na open, naka-CPR lang natin. Check for pulse. Or call for help. Wala na, tuloy lang. There's no pulse. Start compression. Tit, 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 tit. Sabayan ko na yun. Tit, tit, 2 minutes yun. Tit, 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 tit. Pag after 2 minutes, analyzing. Bitaw. Yan, gano'n lang. Meron ding AED na AED lang. Ngayon sa Pilipinas, ay kinakampay natin na magkaroon ng PAD. So nakikita na natin sa airport. Sa airport pa lang. Public access defibrillation. So kinampay ng Red Cross, ako po yung ginawa nilang isa sa campaigner. So nag-release sila online. So ako yung campaigner, nagsalita ako the importance of defibrillator. So nag-campaign. So ginawa namin sa national headquarters ng Red Cross sa EDSA. So I'm an advocate of a public access defibrillator. Bakit? Sabihin ko ulit, tataas ng between 70 to 80% ang survival ng tao with a defibrillator. Ladies and gentlemen, one of the greatest inventions of man for humanity. Kasi maraming invention ng tao, not for humanity. Atomic bomb, mga gano'n, kasiraan ng tao ang ginawa niya. GMO, genetically modified, mga pagkain. No? So, may mga tao na invento ang tao na hindi pa tao. Going to Mars. I don't like people going to Mars. Punta ka ng Mars. Ang gawin mo sa Mars? You want to go to Mars? You have not even gone to yourself. Sira pa rin ang pagkatao mo. Punta ka sa Mars. Sisirain mo ulit yung Mars. Kasi hindi mo kilala ang sarili mo. Destroyer yung hand. So, ang style doon, don't go to Mars. Go to yourself. Alamin mo ang sarili mo. Ma-realize mo, magkaroon ka ng intrapersonal intelligence. Then mas maging maayos kang tao. Maayos ka para sa kalikasan. Yun lang. So, independent AED, ito 3 switch. Merong AED na lead unit, okay. Meron naman, pag open, mag-on and off ka, on. Unit, okay. Check responsiveness. Depende from the AED. Unit, okay. Apply, patch. Tapos ito, meron siyang pediatric adult mode. Pag pindot mo, pedia mode. Tapos, kabit yung pads. Siya nang bahala sa voice prompt. Tapos may mga drawing. Tapos, pag sinabi niya, shock advice, stand clear. Pipindutin mo itong pula na may lightning. Lahat ng AED, usually kinukulayan nila itong pula or kinukulayan nila ng may ilaw or may kulay na may lightning. Pag pindot mo ito, gaganon ng tao. Shock given. Check responsiveness or shock given. Continue CPR. Bahala siya. Depende anong machine. Okay. Pointers. Don't commit the mistake I committed. 1. Lagi araw-araw dala kong AED. Iniiwan ko sa sasakyan. Yung sasakyan umiinit. So nasisira siya. Sa sobrang init. Sa halos isang taon. Kung meron siyang display, mawawala yung display. Masisira yung LED. So lesson yan. 200,000 yung AED ko. Nasira lang yung LED. Pinalitan ng zone. Other than masisira ang battery sa init. Ang maganda lang sa akin, nung inom ko siya, meron akong bubuhayin tao. Replace battery. Di pahiyang-pahiya ka ngayon. Manual override ko. Yung AED ko may manual override. Kasi pwede siyang gawing cardiac monitor. Yeah. So, that's great. Sobrang lamig naman, grabe sa opisina ninyo, bantayan ninyo. Kasi iniwan nyo, akala okay ang AED. Ang lamig po, kumakain ng battery. By the time i-on mo yung AED, after 6 months, replace battery or wala na. Kasi nobody minds the AED on the wall na sobrang lamig ng aircon, nag-freeze kayo. Ang baterya, kinakain ng lamig. Yan yung tandaan yung error. Third error, hospital. Wala akong hospital, pero may mga doctor, nurses nag-order ng AED. Again, that's wrong. We are not supposed to use this one because this is only for lay people. Tayo ay manual. Okay. Question. Kuha ko. Tanong. Is there such a fully automated and semi-automated? Tama kayo. Nung panahon ko, meron tinatawag na semi-automated. On. Ikaw ng AD. Analyze. Ikaw mag-analyze. Yan yung semi-automated. Hindi katulad ditong lahat natin ngayon. Sila na nag-analyze. Tapos fire. Ngayon, on, saka fire. Ang machine na mag-analyze. Ang tawag doon, fully automated, saka semi-automated. Very good question. Any question? Wala? Okay. Let's go into risky breathing. Dahil dito nagkakamali ang nurses and doctor for a number of times. Ha? Oh, may inis kayo sa akin, pero ito yung totoo. Nagkakamali kayo dito. So I'll put a dummy. Rescue breathing using bug mask. Kasi COVID na tayo ngayon. Okay? Bug mask. Uy, ano to? Bakit mali? So, pinauso siya para pwedeng mabitbit sa araw-araw. So, sa bag ko, meron akong ganito. So, it's a bug mask. Magic. Ang problema lang nito, wala siyang HEPA filter. Lipat ko lang ito isa. Dalawa ang ating camera. Okay, one. Maraming nagbabag mask, ganito ginagawa sa buhay nila. Apex base of the triangle. Ganito lang. Very good. Napaka-very good niya. Ha? Mali yan. Pag nagbagging kayo, kailangan tight seal. COVID man o hindi, tight seal. So, paano natin ginagawa? Letter C and letter E. Letter C and letter E. C, hawak dito sa mask. And E, hawak sa brim ng mandible, yung bone, huwag sa gitna. Huwag dito sa gitna, matutuak ang pasyente. Dito sa gilid. C. So, ang hawak ganyan, ganyan. Tapos, E, hyperextend. Pag i-hyperextend mo, the rigid part of your cartilage in your airway will be pushed down at yung anterior portion of your cervical, which is also rigid, plus the cartilage, iipitin ang esophagus. Kaya hindi ka na, wala nang, sarado na sa esophagus. Kung nagbigay mo ng hangin, hindi na magkakaroon ng gastric insufflation. Hindi pupunta ang hangin sa gastric. Tapos hindi siya mag-bleed ang hangin dito kasi nakasil. So, hyperextend. Okay, and then pump 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 1,000. Huwag masyadong malaking kamay na kailangan mga around 600 cc. Tama lang yung tidal volume ng Filipino configuration ng kanyang lungs. So itong wrist ay nandito sa forehead para kalso, para maiangat ko. Yan, angat. Oh. So 3E and then C. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 2, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 3. O nag-CPR. Pag nag-CPR, nagsi-CPR, diyan ka lang. Pwede mong bitawan, pero ito nag-CPR. By the time na 29, 28, 29, 30, nakaganon na ako, analyzing, gumanon si defibrillator, huwag kong itanggal. Dati iba nagtatanggal, huwag kong itanggal, diyan lang. Non-conductor naman yan. Shock advice, zero po ang oxygen. Kailangan may oxygen line. Ilagyan ko. Oxygen line. Zero ang oxygen. From 50 liters per minute, zero. Tingnan zero, nakikita na. Sigaw siya, walang clear. Clear, clear. Clear. Everybody is clear. Sigaw din ulit ako. Clear. So, shock. Ganoon pa siya. Shock given. Check response. Check for pulse. Ang mag-check ng pulse, ako. On muna ang oxygen, check for pulse. Or pwedeng check for pulse, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 10,000. Pero ang oxygen, kailangan naka-on. On muna oxygen. Okay, no pulse, continue CPR. CPR, 10, 27, 28, 29, 30. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 1, 1, 2, 3, 4, 5, 6, compress. 2, 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 3, 0. Bago pa mag 3, 0, yan. Pag dalawa kami sa airway, isa lang yung nagbabag, pero huwag manggigil na buong bag iba. Yung isa, ang hawak, nandito, dalawa. Dadalawahin niya ang kamay, dalawang C, dalawang E. Pangat. Isang nasa side, nagbabag. Okay lang yun. Okay. Analyzing. Ito, yung isa, ganoon lang, hawak. Hawakan ko, kailangan walang basa. Oxygen. Shock advice. Okay. Sigaw siya yung, one and clear? Zero. Clear, clear? Clear! Everybody's clear? Clear! Shock! Shock given. Check for pulse and responsiveness. 1,000, 2,000. Pag-iwan na oxygen. 5,000, 6,000, 7,000, 8,000, 9,000, 10,000. Continue CPR pa or advanced na. ACLS na tayo, mag-IV na. Pag nag-IV ka na, ACLS na yon. So ready na ako. Kuha na ako ng pag-ACLS. Pwedeng laryngoscope aided intubation or supraglottic intubation. Yan. Okay? Ngayon, kung gusto natin gumamit ng airway adjunct, which is part of the basic program, kasi medyo trauma, or kung gusto mo ng airway, gamitan natin ng pinaka-famous ginagamit natin, oropharyngeal airway, which is Gedel, indifferent sites. I-measure natin from the lobule up to the corner of the mouth. Ito lang. Insert, pataas. Yan. Hindi nakikita kasi puti-puti. O, yan. Lagyan ko ng bar. Ito yung curve shock. Curve shock. Dito ko i-gano'n sa curve shock. Curve. Ang tawag nito air channel. Ang tawag nito bite portion. Ang tawag nitong plate na to is flange. Para hindi masuksok sa... So parang kung ako ang pataas muna, pag nataas 50% twist. So dito, ganun ko lang para makita niya. By the time nasa 50% na ng curve shock, i-twist mo siya. Yan, ganyan lang. And then, you can bump. Kung gusto niyo gamitan ng nasopharyngeal airway, okay din. Pero dalawang measurement. Number 1, ang kanyang external diameter must be kasing laki ng 5th digit niya. Okay. Next, ganun din ang haba. Ito mas mahaba. Diba? Okay? Tapos, ang problema nito, kailangan nyo ng petroleum jelly. So, insert. Pag sa totoong buhay, pag in-insert, ganyan po ha. Pero dahil ito ay dami, ginanon ko lang muna kasi medyo maganit na yung rubber to rubber. Ganyan ang forma niya. Ayan o. So, mas maganda to kasi sa patient na semi-conscious, pwede. Ito, totally unconscious kasi pag semi-conscious ang pasyente nito, iluluwa niya talaga, mag-aaway talaga kayo. But these are two basic adjuncts of different sizes na ginagamit natin. So usually, sa airway kit mo, may BBM ka na, meron ka ng set of kit. Pero pag military kit ka, katulad ng mga dinadala ko, meron ako, para masanay ko yung lahat ng bag ko, dito pa lang may 3 bag ako. 1, 2, and 3. Lahat yan may airway. Hindi pwedeng lipat. Kasi may mga kanya-kanyang karga. So, katulad dito, ang first aid kit ko, ayan. First aid kit ko yan. So, lahat ng bag ko may first aid. So, meron siya airway. Kita mo yung green. Ayan. Ito, chest shield, needle decompression. Malalaman nyo sa ACLS paano ginagamit needle decompression. Burn shield, abdominal, pag lumabas yung bituka mo, abdominal gauze. Tapos iPad, ang sa mata, pag may eye drone. So, ito siya. Tapos kailangan naka-airtight. Hindi dahil ayaw ko siyang masira. Kung hindi, kung nasa tubig ako, na bahain kasi alam niyo sa Pilipinas, 86% ng sakuna ay kadahilanan ng bagyo at pagbaha. So pag airtight siya, tapos kailangan ko ng panglutang sa tubig, lulutang kasama kasi airtight siya, may air spaces siya. So yung bag ko mas lulutang. So, may gamit ako. Hindi ako nagdadala ng stethoscope kasi ang stethoscope ay hindi nakakabuhay ng tao. Yan yung mali naming mga doktor eh. Puro tayo stethoscope, doktor. Daping doon, tawanan kita eh. Nagkaroon ng tension pneumothorax. Paano mo sagitin yung tension pneumothorax? Stethoscope meron. Nasa kotse, stethoscope. Sinasabit, no? Parang status symbol eh. Ako, no way. Hindi ako nagdala stethoscope. Needle decompression, hemostatic dose. Yung hemostatic dose, pag tinama mo sa... By the way, pag nag-first aid kayo, makikita niyo yung pinakabagong training sa first aid tomorrow. May first aid tomorrow after ACLS. Nakikita niyo yung new management of first aid. Kasi yung first aid dito sa Pilipinas, I will not say sorry ha, kasi I'm a man of science, like you. Ang ating first aid dito, magalit na kayo sa akin kung kayo instructor ng kung saan. Antiquated na po yan. Antiquated. Okay? So it's fine if you get mad. Your first aid is a British Museum piece. Pangit no? Kasi ang medical science is dynamic science. Kaya kailangan active. So, yun na. Kaya, ang meron ako ito. Hindi ako nagdadala nito. Tapos yung aking nasopharyngeal airway ay sukat ko. Size ko. That's the issue there. Para gamitin yun sa akin. Ang tawag doon IFAC. Individual First Aid Kit. So wherever I go, meron akong IFAC. Okay? Yeah. So again, pagpasok nito, hindi ganyan. Tatama sa 2 minutes, ganyan ang pasok sa totoong buhay. Pero siya, dahil dami, kaya pinasok ko siyang pag ganun. Pero pag nag-live na kayo, ganyan. Ha? Yan. Okay. Question. What else? Naloxone, Sorry guys. Ito ang non-rebreather mask. Meron siyang mask, two-way valve, nawala na yung valve, tapos reservoir. Tapos ang kailangan para ma-achieve natin ang 90% oxygenation, kailangan ang yung oxygen ay merong 15 liters flow rate. Karamihan sa ospital ninyo, 10 liters, hindi po yan. That's a medical oxygen with a humidifier. Ang emergency oxygen ay walang humidifier, meron siyang 15 liters. Pag nag-arrest ang pasyente, ang hangin na dapat bumubuga sa linya mo ay nasa 50 liters per minute. Yan po yung Otstein style. Ngayon lang kayo nakarinig ng Otstein style. Magbasa kayo ng EMS book, magbasa kayo ng emergency medicine, 15 liters per minute. I am shocked sa Pilipinas, ang ginagamit pa rin ay 10 liters. Nakakatawa na po tayo at hindi po siya maganda kasi violation po yan sa evidence-based medicine. Pag nakunan tayo ng video or nagkukuha kayo ng video, pinost ninyo, akala nyo heroic kayo. Pinagtatawanan ng Pilipino because we are not really a people of science. We end up like people Marites lang. Please, in an emergency, 15 liters per minute. So naka 15 liters per minute ako, bago ako mag-compress, ay nakalagay. Para pag nag-compress ako, yung aerosol matatak. Hindi masalilipad. Ano mo lang, dito lang siya. Okay? Eh meron akong electric fan, tapos meron akong outlet, so meron akong wind corridor. So yung mga microparticulates and aerosolized substances na defeat ko na. Yan ang interim guidelines of 2022. Kaya pag tinanong kayo, ang BLS po namin ay interim guidelines of 2022, tataas ang kilay nila lahat kasi sila hindi nila alam yon. Yan po yung latest ng basic life support guideline. Okay. Now, let's go into addressing basic life. Lagay ko lang dito. Ulo, katawan. Now, so, doon ako sa pinaka-list na lugar na walang gaanong gamit. Pero mayroong gamit pero walang manpower, kulang lahat. So doon ako para mas hakot ko lahat. Ayaw ko magturo na purely AHA kasi sa US, Canada, kompletong gamit. So dito ako sa walang gamit ka. Ano ang style? Okay. So male ward or oncology. Oncology na lang. Social. Walang oncology sa periphery gamit. Ano na lang, step down care. Regular ward, normal ward. So pasyente, may mga ano, ito siya, CKD. So nakitaan siya na mataas ang sodium, ang serum potassium. So sinihintay yung specialist at saka pag-core para dalhin sa Manila. Yan. So meron ng tutulong kasi mababait ang Pilipino tutulong na hindi pa lang dumating yung pansagitay. So while in the ward, andun si 14 years old na anak. Yeah. Tapos ikaw, nag-iisang nurse plus isang orderly or nursing aide or midwife. Tapos isang orderly, tatlo kayo. Sa ward na meron kayong 20 pasyente. Is mga typical 20. Biglang sumigaw, nurse, nurse, nurse. Si tatay walang malay. Si tatay po, si tatay. Itakbuhan lahat. Tumakbo ka. Ang tumakbo, si nurse. So pagdating ni nurse, kita yung pasyente, naka-high back rest, tinapik. Check for responsiveness. Tingnan nyo ha. Sa patakaran ngayon sa COVID, hindi na po dalawang kamay. Kasi pag dalawang kamay, malapit ang airway ko sa airway. Okay? Atras muna ako, may mali ako. Bago ako nag-responde, naka-N95 ako. N95. Tapos, naka-shield. Kasi yun yung tama eh. Yun yung interim guideline. Although nag-step down na ang ating alert level. Wala na. Hindi na siya COVID emergency is not there anymore. Pero meron kang minimum. So, naka-N95 pa rin ako at naka-highway. So itong eyewear ko na to, hindi po ito yung degrado. Nasanay na ako nagsusuot nito. It's a trauma. Para kasing everyday sa akin, merong enkwentro na trauma. Pag nagtalsikan ng dugo, hindi matalsikan mata ko. Sipin mo, matalsikan ako ng HIV, makakuha ko ng HIV. Sa mata lang. No, matalsikan. Okay. So, high back rest. Isipin nyo, naka-identify na lang ako. Topic. So, ang topic, hindi ganito. Nasa right side ako ng pasyente, so right to right. So, mas malayo. Sir, or pangalan niya, Pedro Juan de la Cruz. Mr. de la Cruz, Mr. de la Cruz, Mr. de la Cruz. Mr. de la Cruz, tapos trapezius speech. Non-responsive. Code blue, bed 7. Code blue, bed 7. 4,000, 5,000, 6,000, ibaba, 7,000, 9,000, 10,000. Patient has no pulse. Baba yung bed. Delay number 1. Cardiac board. Insert cardiac board. Delay number 2. Nag-iisa pa lang ako. Wala akong kasama. Nag-iisa pa lang. Saan yun? So, lagay mo na ako dito. Emergency oxygen line. Lagay mo na ako. Tingnan mo yung delay, ha? Ay, nako. Yan. Okay. So, delay number 3. And then start compression. Kili-kili yan. Compressor. Okay, 1. Tuloy-tuloy lang yan. Walang 30s. Tuloy lang. Dumating na yung kasama ko. Okay, dumating na. Okay, sir, stop. Pag stop niya ngayon, palit na bagbalbas. Bagbalbas na siya. Okay, isipin niyo lang, may nakabagbalbas na. Okay, 30s to 2. Tira. 4, 5, 6, 30. 1 and 2 yung kasama ko. Ito nakakonect sa oxygen at 15 liters per minute. Yung kasama ko, nag-abot lang ng AED kasi yung pasyenteng isa may problem din. Sige, binigay sa akin ang AED. Ako na nagkabit. Okay. Hirap bang nahulog pa yung bag ko. Tuloy-tuloy lang. Inon ko yung AED, naka-on. Tuloy-tuloy lang ako. 30, bag. 1 and 2, tuloy-tuloy lang. Si AED, nagkukuman ka niya, check responsiveness, huwag mong sundin. 1 and 2. Tip, 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 tip. Tapos 31 and 2, biglang analyzing, bitaw lahat. Shock advice, stand clear. Shock advice, stand. Okay guys, 1 and clear. 2 you clear? So siya nakaganyan lang. Clear. Everybody's clear, clear. Pindot, gaganon pa siya. Shock given. Check for pulse. Pwedeng ako, pwedeng yung airway. Checking pulse. Asan na yung code blue team? Si cardiology. Nasa kabilang hospital, papunta na raw. Si anesthesiologist, katatapos na ng operasyon sa itaas, sa OR. Papaba na raw. Naku, wala pa. Tuloy-tuloy ka lang. 30 is to 2, 30 is to 2. Analyzing. Ganun. Yan lang yung BLS. There's nothing you can do. What if the patient is, kunwari, nakamorphine, press case sa ER, kung meron kang atomizer, wala pang ganyan sa Pilipinas. Out. Dinadaan pa rin sa IV. Pag dumaan sa IV, hindi na po siya BLS. ACLS na po siya. Saglit lang, may emergency call. Yes, sir. Oh. Sorry Bulacan State University. Meron natin Okay. So ang BLS is a compression shock, compression, shock, compression. Now, in the hospital setting, the patient, assuming nabuhay mo, after 2 shock, katulad nangyari sa akin, wala pa akong gamot. Huwag kang huminto doon. The patient must be brought to CCU. Kasi baka nabuhay siya, pero yung heart niya hindi siya ganun ka-strong. Normal, pero hindi makasipa. So huwag kang maniwala. Baka kailangan pa niya mag-inotropes, mag-chronotropes, or inotropes para mas makapag-pump na oxygen to the brain. Then that's ACLS. Okay? Anything that you will give sa IV ACLS. Lahat tayo dito, basta non-invasive, pag-airway lang ng ganito, BLS. Nagbigay sa ilong, BLS. Pag nag-IV ka na, pumasok ka na sa mundo ng ACLS. Yan ang tinatawag natin BLS as a bridge to ACLS. Okay, pero kakaiba ngayon. By the time nagdatingan si Cold Blue, ang ini-emphasize ngayon sa ACLS, continuous CPR is IV sabay na sa airway. First pass mechanics. Kailangan naka-airway ka agad. Yan na si ACLS. Hindi katulad dati, IV. After 1 or 2 runs again, saka mag-airway. Ngayon hindi. IV ka, airway ka agad. Ang point doon is closed circuit mo para hindi na kumalat si COVID. Yan ang interim guidelines of 2022 for ACLS na. Yan. So, mayan ang matutunan natin mamaya. So, the patient is okay. So, 2 things. In the hospital, ganito pa rin posisyon, hindi natin siya nilalateral kasi kailangan meron tayong airway support. Sa field, nire-recovery position namin. Yan, ganyan, tapos, yan na. Sa field yun. Sa hospital, hindi. Unless, wala kang ICU or CCU or medyo advanced life support, mga critical care sa hospital, magsaside ka para i-ambulance mo, ready for ambulance, transfer to, kunwari, birthing clinic ka lang, or barangay health outpost ka. Yes. Lateral recumbent. And then, bring to the hospital. On a lateral recumbent position. Ngayon, BLS for drowning. Pag BLS for drowning, ang recovery position mabilis. Di ba? Drowning. So there will be 6 questions in drowning. Number 1, what kind of water siya nag-submerge? So, dalawang klaseng drowning. Drowning by submersion and drowning by immersion. Ang drowning by submersion ay nalunod siya sa ilalim ng tubig. Ang immersion is wala siya sa ilalim ng tubig pero binuhusan ng tubig ang mukha niya, nakahiga siya. Kunwari yung torture yun, drowning by immersion. So, question number 1 is, anong tubig siya? So, there are 6 types of water. Number 1 and 2, fresh water, salt water. 3 and 4, warm water, cold water. What is the cool water? When do you say it's cool water? When it is 20 degrees centigrade to 10 degrees centigrade. From 10 degrees centigrade to 1 degree centigrade is cold water. Where do you call it's warm water? When it is 22 to 39 degrees centigrade. So, ganun, evidence-based medicine according to Utstein style. Magulat kayo saan galing ang Utstein style. You search it there. Nakakawa, ang Pilipinas, hindi pa nag-Utstein style. Karamihang countries nag-Utstein style na. Pilipinas wala. No? Grabe. Pero kung paastahin mo sa mga Pilipino, siga-siga. Pero walang standard. Kaya nakakatuwa minsan. Maraming nagtuturo na sabi na, we are the standard. Pag tinanong ko, Utstein style ba yan? Hindi. Ang standard po ngayon ay Utstein style. Pag hindi ka nagturo ng Utstein style, sarap ng buong mundo, out ka. Okay? Yan. Utstein. Yan ang yung language na yan. Malalaman yan bukas sa first aid. Utstein yung ituturo. So, itong drowning Utstein. So, 4 na, no? Fresh water, salt water, warm water, cold water. Next is clear water and dirty water. So, yun po yung unang katanungan. Pangalawang katanungan, gaano katagal ang pasyente na submerged sa ilalim ng tubig? Ano ibig sabihin? Halimbawa, 5 minutes siya nasa ilalim ng tubig. So, question number 2. Number 3, gaano katagal siya na-respond niya? Assuming 5 minutes din bago siya naabutan. So, ilang minuto na walang hangin ang brain? 10 minutes na. Number 4, ano yung skills na tumakbo doon, nag-responde? Kailangan alamin mo. Number 5, very critical. Naka-aspirate ba siya? Nakalanghap ba siya ng gumitos? Yan po, pag pumunta sa korte yan, talo ka dyan. Kailangan ng pasyente hindi maka-aspirate ng gumitos. Kasi ang pasyente, habang sinisipian mo, pag sumuka yan, pag malakas yan, gising na yan. Tatagilid talaga. Tatagilid siya. What if the patient is so weak? Pag suka niya, ganun lang. Ganyan lang siya, hindi makatagilid. Hindi mo siya tinagilid. Patay. May higop niya. So ganito po pag CPR. Tingin sa akin. Tingin. Pag CPR. Para ma-defeat natin ang suka. Okay? Pag suka, tagilid ka agad sabay tapik. Pwede mong gamitin ang damit or yung balikat. Yan. Ganyan, kabilis. Hindi na maghintay na. Ganun sa 1 and 2 and 3 and 4. Wala na. Nalanghap na niya ang suka. Okay? So doon, mabilisan. Pag suka, bilis. Tapik sa likod. Sige. Tapos ito, tandaan nyo. Number 5, sa ang ospital dinala. Kailangan ang pasyente, pag na-drown at nabuhay mo, kahit pa sabihin niya, ay okay na po ako sir, anghel po kita, nabuhay po ako dahil sa uwi na po ako, huwag niyo pong pauwiin. Kailangan obligado idaan sa ospital para maobserbahan of minimum of 3 days. Kasi pwede siyang magkaroon ng secondary drowning sa lumang tugtugin. Ang Utstein hindi gumagamit ng secondary drowning. Ang secondary drowning po, kunwari ang tubig na kanyang nalunod, kung saan siya nalunod ay maalat and or marumi. Merong mga sediments. Magaspang yan. May mga taong very sensitive. So, umuwi sa bahay o nasa ambulansya, nabuhay mo na. Biglang sa pagdating sa ambulansya, kumano, no? Naglaringgos pasok dahil merong trigger. Yung mga dumi na naiwan doon. Ang tawag niyan sa lumang pre-hospital book is secondary drowning. Tinanggal na po yan ngayon. Tinanggal yung dry drowning, wet drowning, secondary drowning, tinanggal na yan. Ngayon, drowning lang. Tapos pag nag-arrest siya, sabihin lang na ARDS, Adult Respiratory Distress Syndrome, due to primary cause which is drowning 2 hours ago. Kunwari, 2 hours ago or 30 minutes ago. Ginagawa ng storyline. Hindi na tayo gumagamit ng secondary drowning. Pero, kung gusto mong gamitin ng secondary drowning, kasi may element of drowning kanina, nabuhay mo siya, secondary drowning, i-close parenthesis mo, non-Utstein style assessment. Non-Utstein style. Pag ako binasa ko, itong taong nagsulat na to, the best to. Another thing, I want you to research Orlowski score. Orlowski. Iiwan ko na yun sa inyo, hindi part ng BLS. Pero baka balang araw, pag nag-emphasize sa drowning, isasama na sa BLS ang Orlowski score. Kaya siguro hindi sinasama sa BLS kasi dinedetect niya, kailangan ma-detect ano ang pH pag kinuha mo siya. So ang Orlowski, ginagamit natin siya sa pediatric drowning. Okay? Pero basahin niyo ng Orlowski scoring. Okay? Para naman high-tech tayo. Pag ang mga Pilipino, nasa larangan ng international standards. Para hindi tayo maliit-maliitin. Tandaan niyo. Okay, so ganun lang po ang basic life support. Ngayon, 3 kami. Isang nagko-compress, isang nag-airway, at isa sa kabila, ang nag-electrical therapy or nag-defibrillator. Ang maximum sa BLS is 3. Under interim guidelines of 2022, minimum personnel requirement. Sino ang team leader? The one who fires. Ako nag-compress. Analyzing. Pag analyzing, takbo na kaagad ako sa kabila, siya takbo dito. Balik na. So ready na ako mag-compress. Shock giver. Shock advice, translate. Siya mag-command. Sana kayo ng team leader. Okay, team leader doon. 1 and clear, 2 year clear, sabi niya Erwin. 0 clear. 3 airways clear, clear. Pinindot niya, defibrillator na skola. Shock giver. Continue CPR. Ako na magsi-CPR. Siya ang team leader. Pam, 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 pam. 30! After 2 minutes, 30. After 2 minutes, analyzing. Pag analyzing, takbo ulit. Ang takbo, hindi pwede sabay. Isa lang. Ang unang aalis ay ang defibrillator side. Kasi ang huwag mong iwanan, ang compression doon. So tatakbo si dito. Pag nasa likod na, takbo na ako doon kasi ako yung magpapaya. Shock. Advice, time clear. Okay, arm na clear, 2 yung clear, sigaw siya 3 ang clear, clear. Pindutin, shock given. Continue CPR. Ako na naman mag-CPR. Bam, 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 bam. Until the patient goes back to spontaneous, there's a spontaneous return of circulation. Or the patient di na mabuhay. You have to remember, people, that there is a heart which is too young to die. Yan yung objective natin, mabuhay natin. But you also have to remember, colleagues, that there is a heart which is too old to live. Let's give it a decent death. Tanggapin natin yan. Sana matanda na, CKD or terminal cancer, it's part of life cycle. Ang tao takot namatay. Bakit? Alam ko karamihan sa inyo. Because you have not lived. Person who has not lived is afraid to die. But you have to remember, kahit sino ka din ngayon, nakatayo ka, kahit pinakamagaling kang doktor, death will find us all. Even if we live in towers built strong and high. So ready ka rin. Okay? But with this program, basic life support program, this is there sa 99% of those, the survivable heart, the heart which is too young to die. BLS program is good. It's not rocket science. It is only by muscle repetitive na pag nag-compress ka, sakto, yung inyong siko ay hindi nakabend. Ganun siya. Ganun, straight, hindi bend. Tapos, hindi jerking, kung hindi, ang katawan ang sumasayaw. Katawan ang sumasayaw, yan. Tapos, hindi siya yung rocking. Kailangan alalay lang. Pinagilid ko lang para makita. So, yan lang. Ang katawan ng, it's like a dance. Ang bilis, ganyan. Ito, sa bilis na to, 120 to. Tapos yung recoil, adequate ang taas, ha? Hindi yung gigigil kang gano'n. Yan ang laro. Yan ang laro. Okay? A good basic life support program is a life skill na kailangan matutunan ng new normal Pilipinas para maka-establish tayo ng resilient culture. So with that, na-tackle natin yung chain of survival for in-hospital. Ano yan? First link. Kasi mag-exam tayo ngayon. May exam tayo ngayon. Yan. Una, ina-ID natin, pinoprofile. Pangalawa, if there is, all emergency services. Pangatlo, okay, good compression, quality CPR. 5. 4. One of the greatest inventions of man, defibrillator, defibrillation. 5. Post-ACLS, or post-cardiac arrest care. And 6, recovery, which is the primary support group, community and family. And balik ulit kung babalik ko sa hospital. Yan. Yan lang, tandaan niyo. And then, compression mechanics, 100 to 120 per minute. Budget counting, straight 200. So, it's just fine. Pag AED can run is 200 sa ideal battery of time. I mean, sa time frame niya, nakakaubos ka ng 5 cycles. Okay, so 100 to 120. So, compression mechanics. Tapos yung rescue breathing, the using of valve mask, na letter C, letter E, very tight. So, bigay ka ng 1 blow per 5 seconds to 10 seconds. Blow, tapos sakto lang na 600 cc. And then, naloxone, by theory, spray lang. Tapos, kung hindi pa nag-reverse, tawag ka sa doktor, sir, can I kunwari 4 milligrams naloxone, then you can jack up to another 4. Or kung Cloxado, which is 8 milligrams, ask medical contact. AED operation, it's not rocket science. You should know your machine. It's the man, the machine, and the mission. Let 3M. The man, the machine, and the mission. Okay, and then the format of the personal response The ideal is minimum 3. The airway, the compression, and the electrical therapies. Aabot tayo ng 4 kapag ACLS. Kasi sa interim guidelines of 2022, limit the personnel at kailangan naka-level 3, level 4 kailangan. Although bumagsak, bumaba na ang ating alert level, pero kung susundin lang natin yung interim guidelines, don't PPE at level 4, level 3 to level 4. Naka-level 4 si airway. Ideally, level 4 lang. Pero ito si airway, ang level 4. Kasi siya yung sasalo pa naman yan. Ang interim guidelines, kailangan meron HEPA filter, ang mga gamit, lalo pag-mask, at maganda kung may air corridor. Pag sinabing air corridor, kahit naka-aircon yan, malamig pa rin. Yung may inlet ka lang, napapasok yung hangin, at may outlet ka, na kung saan napipilter. Hindi mo pinasa yung hangin doon sa nasa ICU ako, pinasa ko sa ward, ang ward nagkaroon na. So, pinipilter ko yan. Kung saan nalabas ang hangin, may filter yan. Para natatrap at namamatay yung bacteria, nasa subject sa ultraviolet, whatever. Okay? So that's the overall program of your basic life support. Right now, we will have may exam ba? Tanongin natin si Ma'am Joy. Tapos pag wala, manood lang tayo ng BLS video while taking your exam. So that ends our demonstration for basic life support. And this is Sergeant Frankenstein. Nilagyan na para hindi mahiwala yung ulo, nahiwalay na yung ulo. Si Sergeant Frankie is my dummy. Okay. And if you have any question, I'll just be around to entertain. Tanong? Ito na wala. So if there's no question, I'll endorse you back to Ma'am Joy for your exam and your BLS video. Okay. Yung BLS video, hindi pa siya updated. Pero andun na yung storyline. But it's not yet the 2022. Baka, ginamit namin pre-COVID pa yung ASHI na yan. Kasi hindi pa nakapa-update yung video. But as soon as we will have the right video. Okay? So don't be confused. The video is just tell you the dynamics of movement and how it's being rolled down or how to respond. Pero yung mga interim guidelines of 2022, hindi pa nakapractice kasi pre-COVID pa ginawa. Okay? Ma'am Joy, endorse ko sa iyo. So wala na silang tanong. Hello, Ma'am Joy. Or anyone from WIPAM.
Hello po, Doc.
Okay, so mag-exam sila?
Yes po, Doc.
Sige. So endorsing to you, but I'll just be listening in case if there are questions that will pop out. Okay? So good luck. No, not luck. I don't believe in luck. Do well in your exam.
Thank you po.
Hello po. I will be playing videos po, and while playing the videos po, you can take your exam na po. Isasend ko po yung link ng exam ng BLS po sa meeting group chat. Yan po. Nasa meeting group chat na po yung exam. You can take your exam na po.
Basic life support, or BLS, is emergency medical care provided by first responders, healthcare providers, and public safety professionals to persons experiencing respiratory or cardiac arrest or an obstructed airway. It requires knowledge and proficiency in cardiopulmonary resuscitation, or CPR, use of automated external defibrillators, or AEDs, and techniques to relieve airway obstruction in patients of every age. This BLS training program is intended for healthcare providers and other public safety professionals working in a wide variety of occupational settings, in and out of hospital, and individuals enrolled in healthcare and public safety career courses. The purpose of this BLS training program is for participants to gain or improve knowledge and skill proficiency in high-quality CPR skills for the adult, child, and infant. This training program will allow you, the BLS provider, to learn and practice skills according to your experience and in the context of your setting, utilizing different practice methods such as video-guided and scenario practices. Cardiac arrest is the loss of the heart's ability to pump blood through the body due to inadequate or absent cardiac function. The most dramatic occurrence, sudden cardiac arrest, or SCA, can happen anywhere with little or no warning.
It was a beautiful, sunny, warm July 31st, and Lynn, my wife, and I had gone grocery shopping.
It was otherwise kind of a typical summer day.
We were unloading the groceries. Lynn and I schlepped some in, and then I went out to get the rest.
We can tell by retracing my steps that I had put some things in the pantry and was headed back out to the car, but I never made it because I went down.
Was only gone about 60 seconds. In that small amount of time, my world changed. I turned over on her back, and her face was turning blue, and I heard these sounds like she was trying to breathe, sound like she was gasping for air. And it's a sound you just don't want to hear your wife have. You just don't want to hear that sound.
Hello? Hi, I need an ambulance right away.
At what address?
I dialed 911 right away, and I put the phone down next to her and proceeded with the chest compressions and the breaths.
It's my wife. She's turning blue. She's turning blue. I gotta give her CPR.
Is she breathing?
No.
Okay, lay her flat on the ground with nothing under her head. Do you know how to do CPR?
Yes, a little bit. Okay, I'm pushing.
When the call came in and we heard the information, it was a cardiac arrest. If I knew that the crew was not here, they were out training at another station. Knowing it was a cardiac arrest and the importance of getting there quickly and starting care, myself and the battalion chief made the decision to respond to that.
Is your door unlocked?
Yes, I'm right.
Many minutes went by while I was administering CPR before I heard sirens outside.
I entered through the front door, and I was able to see CPR being performed in the living room.
I found her laying on the floor.
Quickly encouraged the husband to continue doing CPR and push hard and push fast on the chest.
No, I found her. She was loading groceries from the car into the house. She was helping load them, and then I found her just like this. Please check the pulse. Keep going, push hard.
These last moments of my opportunity to give CPR, and that's how I regarded it, was a great opportunity to actually participate in the rescue. My neighbor, who's a physician's assistant, heard the sirens and she came over to see what was going on.
As I was putting the AED on, the patches, the neighbor identified herself as medically trained.
Yeah, you know CPR? I'm a PA. Hey, go.
I asked her to go ahead and to relieve the husband from doing chest compressions at that point, and had her start performing CPR.
So she hopped in there to take over because I was kind of freaking out. I mean, right now, even thinking about it is really bringing back the memories. It was terrifying. I felt helpless. I mean, it was now all in their hands. I had done all I could do.
Here's an ID search rhythm.
After analyzing the rhythm of the patient, the AED identified that it was a shockable rhythm, and we delivered a 1 shock. At that point, I went ahead and took over CPR compressions, and Annie started giving airway assist. And after giving CPR for about a minute, I noticed Lynn starting to make noises with my chest compressions.
I asked him, do you have a pulse? And he said, yes, we have a pulse. And I tell you, that was a beautiful sound to hear that.
So we stopped doing chest compressions and we continued breathing for her. That's when the crew, the paramedics and the firefighters were coming through the front door, and I was able to then step back and give a report to the lead medic that was coming in and that was gonna do the transport.
And they got my heart started again, loaded me onto the gurney and rushed me to Corvallis Samaritan Regional Medical Center, where they continued to save my life. When I woke up, they had put posters on the wall in front of me. And it was very orienting. It said, Kent called 911, did CPR. He saved your life. You're at Corvallis Good Samaritan Regional Medical Center.
The CPR being performed by the husband was huge. I'm sure it was probably 2 to 3 minutes. And during that time, if CPR wasn't being performed, that's 2 or 3 minutes that she's not receiving blood. A lot of things went right for this call and for Lynn, the chain of survival.
So it was a team effort, a chain, and that includes our dear neighbor, Annie.
Learning CPR, knowing how to do it, and then actually doing it are really important because you can literally save somebody's life.
BLS providers play a key role in the resuscitation effort following cardiac arrest, both out of hospital and in hospital or clinic settings. By training and practicing, BLS providers can help ensure the links in the chain of survival are strong in any setting for every patient. In order to clearly demonstrate high-quality skills, BLS providers in this training program may not always be shown wearing appropriate personal protective equipment. Local medical protocols are emergency medical service treatment guidelines approved by the local EMS medical director. Local protocols outline the permissible medical treatments that may be given by EMS providers outside the hospital to patients experiencing a medical emergency. EMS providers should always follow their local physician-directed medical protocols.
Marcus, you need to come here, move to Eugene, move to University.
Think about dropping out.
Sudden cardiac arrest occurs when the normal electrical impulses in the heart cause it to beat too quickly, inefficiently, or in an unsynchronized manner. When the lower chambers of the heart beat too quickly or quiver, the heart cannot pump blood. These abnormal heart rhythms, or dysrhythmias, are known as pulseless ventricular tachycardia and ventricular fibrillation. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen. A victim of SCA may suddenly collapse.
Grandpa, hey, stay with me. Hey, I need some help. Grandpa, stay with me. Grandpa, don't.
What's going on? Is he okay?
I don't know, he just fell out. I need you to call
Occasionally,
911, please.
SCA victims will experience 10 to 20 seconds of seizure activity when the brain
Hey, I need
stops
some
receiving
help.
oxygen.
Hey, I need some help.
Normal breathing stops. Abnormal gasping may last for several
I have no
minutes.
clue what happened till he just fell down.
Okay. Let's get his back. Can you hear me? Sir, can you hear me? I have one person down in the main lobby who's unresponsive. Start me 911, get an AED. We'll start CPR, he's not breathing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
CPR is the immediate treatment for suspected SCA. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions, an open airway, and rescue breaths. However, CPR alone is not enough. The most effective way to end pulseless ventricular tachycardia and ventricular fibrillation is defibrillation.
Remove clothes from patient's chest.
Using a defibrillator and electropads adhered to the chest. An electrical shock passed through the chest can restore the heart's normal contractions.
Analyzing heart rhythm. Stay clear of patient.
Immediate, high-quality CPR and early defibrillation with an AED can more than double the likelihood for survival. These two elements are parts of the adult chain of survival, a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 adult chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of early recognition of cardiac arrest and prompt activation of EMS, immediate high-quality CPR beginning with chest compressions, early defibrillation with an AED when indicated, effective advanced life support treatment, effective post-cardiac arrest care at a hospital, and recovery. The adult out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest, prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR beginning with chest compressions, prompt defibrillation when indicated, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. The majority of cardiac arrests happen at home or in the workplace. Early recognition of SCA and activation of EMS or an emergency action plan gets help coming right away. Immediate high-quality CPR improves the victim's chance of survival by providing oxygen to the heart and brain. After activating EMS, an untrained layperson should provide chest compression-only CPR, ideally with their phone on speaker mode and with the assistance of an EMS dispatcher. Attaching an AED as soon as it becomes available speeds up the time to defibrillation if indicated. Effective advanced life support treatment with a focus on return of spontaneous circulation, or ROSC, and transport to a hospital for all patients with a chance of survival supports the most favorable outcome. Effective post-cardiac care, including monitoring and the use of medication, helps prevent the return of cardiac arrest and improves the likelihood of long-term survival. Recovery supports the patient's physical and emotional needs that are ongoing after hospital discharge.
BLS providers should follow the adult BLS procedure, a step-by-step guide for responding to a potential adult cardiac arrest. The adult BLS procedure is a process composed of tasks that can be performed in a step-by-step manner by a single BLS provider or performed simultaneously by multiple providers working as a team. There are 3 main elements of the adult BLS procedure: assessment of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. As a single BLS provider, upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. This includes taking standard precautions. In this program, take standard precautions means use appropriate personal protective equipment, or PPE, to protect against possible exposure to infectious agents. Appropriate PPE may include gloves, goggles or face shields, surgical masks, gowns, respirators, CPR masks, and bag mask devices. Experience putting on and taking off PPE, also called donning and doffing, is critical for your safety and to minimize potential delays in emergency treatment. Train and practice according to local medical protocol or your healthcare facility's established PPE procedures. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
Sir, are you okay?
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. After activating, get an AED and your emergency response equipment, or if someone else is available, send them to get it. Simultaneously assess breathing and the carotid pulse. Place 2 or 3 fingers in the groove on the patient's neck, between the trachea and the muscles at the side of the neck. Look at the patient's chest and face for signs of normal breathing. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, snoring, or gurgling sounds are known as agonal breaths. This is not normal breathing. It is a sign of cardiac arrest. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then, take action based on the presence or absence of normal breathing and pulse. If the pulse is not felt and the unresponsive patient is not breathing normally, or only gasping, immediately start CPR, beginning with chest compressions.
1, 2, 3, 4, 5, 6, 7, 8.
If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway.
High-quality CPR is the primary influence on survival from cardiac arrest. High-quality chest compressions are the foundation of high-quality CPR. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. When chest compressions stop, blood flow decreases significantly. When compressions start again, it takes several compressions to restore blood flow. The more times chest compressions are interrupted and the longer the interruption, the less the blood flow to the brain, heart, and other organs. Minimal interruption improves blood flow. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, immediately start CPR, beginning with chest compressions. CPR should be performed where a victim is found as long as it is safe to do so. To deliver adult chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. Place the heel of one hand on the center of the chest, on the lower half of the breastbone. Place the heel of the other hand on top of and parallel to the first. Interlock your fingers if necessary to keep them off the chest. Alternatively, you can place one hand on the center of the chest and use your other hand to grasp your wrist for support. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Push hard and deep, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. Chest compressions are most often performed too shallowly. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position, but do not lose contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Push fast. Compress the chest at a rate of 100 to 120 compressions per minute. CPR feedback devices transmit information on compression rate, depth, and recoil. Providers can significantly improve chest compression quality by adjusting technique based on data from a feedback device. Using a CPR feedback device is shown to improve patient outcomes and is recommended during CPR training and in real-life resuscitation attempts, both in and out of hospital. Fewer and shorter interruptions in chest compressions are associated with better outcomes. Time spent during a resuscitation attempt without chest compression, called hands-off time, should be kept as short as possible. Chest compression fraction, or CCF, is the proportion of time that chest compressions are performed during a cardiac arrest resuscitation effort. Higher CCF percentages are associated with high-quality CPR and greater rates of survival. A CCF of at least 60% is recommended, but higher percentages are desirable and achievable.
Rescue breathing is an artificial ventilation of the lungs. It provides oxygenation of the blood and removal of carbon dioxide. It is an important component for successful resuscitation. Conventional CPR with rescue breathing should be performed by all BLS providers, both in and outside the hospital. To give rescue breaths, there must be an open airway. The airway is the only path for getting air into the lungs. When an unresponsive patient is lying flat on their back, decreased muscle tone and the pull of gravity causes the back of the tongue to obstruct the upper airway. The tongue is connected to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat, relieving the obstruction and opening the airway. Two methods to open the airway are the head tilt chin lift and the jaw thrust. Use the head tilt chin lift maneuver to open the airway of a patient when head or neck injury is not suspected. To open the airway with the head tilt chin lift maneuver, position yourself at the patient's side. Place one hand on their forehead. Place the fingertips of your other hand under the bony part of the lower jaw, near the chin. Apply firm backward pressure on the forehead while lifting the chin upward. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Leave the mouth slightly open. If the BLS provider suspects a spinal injury, open the airway using a jaw thrust without head tilt. To open the airway with a jaw thrust, position yourself at the patient's head. Place one hand on each side of the patient's head. Place your fingertips under the angle of the lower jaw and lift it upwards until the lower teeth are higher than the upper teeth. If the patient's lips close, use your thumbs to push the lower lip open. An open airway is a higher priority than protecting a possible spinal injury. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. Both the head tilt chin lift and jaw thrust maneuvers should be performed correctly and quickly to minimize interruptions in chest compressions.
Rescue breaths are critically important in BLS care, as they provide life-sustaining oxygen and ventilation directly to the patient's lungs. In addition to SCA patients, BLS providers are likely to provide care for victims of respiratory arrest and secondary cardiac arrest, for whom effective rescue breaths are essential. Rescue breaths are given by blowing the BLS provider's exhaled air into the valve of a CPR mask, or by pushing air into the lungs through the airway using a bag mask device. Gasping in SCA is common but is not normal breathing. If the pulse is not felt and the unresponsive patient is not breathing or is gasping, immediately start CPR, beginning with high-quality chest compressions. After 30 compressions, open the airway and give 2 rescue breaths. Perform cycles of 30 chest compressions and 2 rescue breaths. In respiratory arrest, breathing has stopped, but the heart continues to beat. This is a life-threatening medical emergency caused by diseases such as pneumonia or other conditions such as stroke, choking, drowning, and drug or alcohol overdose. If rescue breathing is not provided during respiratory arrest, the patient's heart will stop within minutes. This is secondary cardiac arrest. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 6 seconds or 10 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. Check the pulse about every 2 minutes. If the pulse is not felt and the unresponsive patient is still not breathing, immediately start CPR. Excessive ventilation, too many breaths or breaths that are too large, can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Air in the stomach can also cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the patient's chest rise, but no more than that. Take standard precautions when providing adult rescue breaths. Use a CPR mask or bag mask device in addition to other appropriate PPE. Some CPR masks and bag mask devices allow you to attach a high-efficiency particulate air, or HEPA, filter to provide further protection during CPR. The HEPA filter fits between the valve and mask, in the path of the patient's exhaled gas. HEPA filters can trap airborne virus particles. BLS providers can give rescue breathing using their own exhaled breath and a CPR mask. Room air contains about 21% oxygen. Exhaled air contains between 16 and 17% oxygen. This exhaled oxygen is enough to support life. To use a CPR mask, position yourself at the patient's side. Place the mask flat on the person's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your other hand, lifting the chin, to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with the head tilt chin lift maneuver. Lift the patient's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of the chest, but no more. Stop ventilating as soon as you see the chest rise. Remove your mouth and let the patient exhale. A bag mask is a handheld device used to inflate the lungs. The device consists of a bag attached to a face mask. BLS providers can give rescue breathing using a bag mask and room air. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. To use a bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use the remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise.
An automated external defibrillator, or AED, is a portable computerized device that is simple to operate. It can identify pulseless ventricular tachycardia and ventricular fibrillation and deliver an electric shock to restore the heart's normal contractions. If the electric shock is effective, there will be a return to spontaneous circulation, or ROSC. The heart will be able to pump blood, and the patient will have a pulse that can be felt by the BLS provider. The patient may also start breathing, moving, or reacting in other ways. If you have an AED in your workplace, be familiar with its operation. AED design varies by model and manufacturer, but they all operate in a similar manner. Proper AED operation requires direct contact between the pads and the patient's skin. Any clothing in the way must be removed. This includes swimsuits, bras, and any other clothing covering a patient's chest. If necessary, cut through clothing with the shears that are typically included with a CPR and AED response kit. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice prompts and readies the device for use.
Plug-in pads connector.
Use adult AED pads for patients 8 years or older. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each according to the pictures. Press the pads firmly in place. Avoid placing pads over medication patches or implanted devices. Try to apply the pads within 30 seconds after the AED arrives. When the AED voice prompts you,
do not touch patient.
Clear the patient. Be certain that no one is touching the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If the AED advises a shock, it will prompt you to clear the patient again.
Clear. Press flashing button.
If directed by the AED, deliver a shock.
Shock delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR, the AED will prompt you again to analyze the heart rhythm. Follow the voice prompts.
Do not touch patient.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
James?
Oh, you know, kids.
James?
Busy doing it in
Are you
preschool, yeah.
out here? James? James? James! James! Oh no! No! Somebody help! Somebody help me! James! James! James, honey! James!
What happened?
I don't think he's breathing.
I'll come in.
Call him. All right, help me get him to the ground. All right, James. Come on, James. Gently, gently. All right, gently. Okay, come on.
Hello. Yes.
All right, watch out.
We had a kid drown in the hot tub.
James. James, can you hear me?
Sudden cardiac arrest in children is not typical, but it can and does occur in children of all ages. More often, though, cardiac arrest in a child results from asphyxia, a lack of oxygen caused by respiratory failure or respiratory arrest. When breathing slows or stops, it leads to bradycardia, a slow heart rhythm of fewer than 60 beats per minute. At that rate, the heart is not able to pump enough oxygen-rich blood to the body. The lack of oxygen causes the heart to stop within minutes. Causes of respiratory failure or respiratory arrest and subsequent cardiac arrest include airway obstruction, lung infections or diseases, drowning, choking, and shock resulting from injuries, such as motor vehicle accidents, burns, falls, and child abuse. Prevention is critical in reducing pediatric cardiac arrest deaths. In the out-of-hospital setting, prevention includes the use of essential safety equipment, such as child passenger safety seats and bicycle helmets, and proper supervision. In the hospital, cardiac arrest prevention focuses on early recognition and treatment of at-risk children. In this BLS class, a child is defined as 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. For those with signs of puberty, provide adult BLS. Like the adult chain of survival, the pediatric chain of survival consists of a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 pediatric chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of prevention of causes of cardiac arrest, respiratory failure or respiratory arrest, prompt activation of EMS, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care at a hospital, and recovery. The pediatric out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest. Prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. BLS providers should follow the procedure for pediatric BLS, a step-by-step guide for responding to a potential cardiac arrest. Using this procedure, you can perform child BLS as a single provider and as a member of a team. Like the adult procedure, there are 3 main elements of the pediatric BLS procedure: assessments of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. First, assess scene safety. Upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. This includes taking standard precautions. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
"Are you okay?"
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Simultaneously assess breathing and pulse. Look at the patient's chest and face for signs of normal breathing. Weak, irregular gasping, snorting, snoring, or gurgling is not normal breathing. It is a sign of cardiac arrest. At the same time as assessing breathing, check the child's carotid or femoral pulse. To locate the carotid pulse, use the same technique as you would on an adult. To locate the femoral pulse, place 2 or 3 fingers midway between the hip bone and the pubic bone, just below the crease where the leg joins the torso. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on the presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly reassess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Perfusion is the circulation of oxygenated blood through tissues. The signs of poor perfusion include pale, mottled, or blue lips or skin, decreasing responsiveness, weak pulse, cool extremities, particularly the hands and feet. Poor perfusion is an indication that cardiac arrest is imminent. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. Beginning CPR prior to full cardiac arrest can improve likelihood of survival. If the pulse is not felt and the unresponsive pediatric patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. A witnessed cardiac arrest is one that is seen or heard, or an arrest that occurs when the patient is connected to a heart monitor. If the sudden collapse of a child was witnessed, you may assume that the child has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Activate EMS or your facility's occupational emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in children is most frequently caused by asphyxia, about 2 minutes of CPR is recommended before leaving the child to get an AED and activate EMS. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival.
As in the adult procedure, high-quality chest compressions are the foundation of high-quality CPR. To deliver child chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. For child compressions, place 1 or 2 hands on the center of the chest. For a small child, 1 hand may be enough. For most children, the compression technique is the same as for the adult. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Whether you use 1 or 2 hands, push hard, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position without losing contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruption in chest compressions.
As with an adult, there must be an open airway to give rescue breaths to a child. The two methods to open the airway are the same: head tilt, chin lift, and jaw thrust. Use the head tilt, chin lift maneuver to open the airway of a child when head or neck injury is not suspected. Rescue breaths are extremely important for children because cardiac arrest typically results from asphyxia. If the pulse is definitely felt, but an unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give one breath every 2 to 3 seconds, or 20 to 30 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Excessive ventilation, too many breaths, or breaths that are too large can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Take standard precautions when providing child rescue breaths. Use a pediatric CPR mask or bag mask device in addition to other appropriate PPE. Use a child-sized mask as you would for an adult. Position yourself at the patient's side. Place the mask flat on the child's face, with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Tilt the head and lift the chin to open the airway. Lift the child's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. Pediatric bag mask devices are available in child and infant sizes. Select a child-sized bag mask. To use a pediatric bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise. Check the pulse every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR.
Most AEDs are designed for both adult and pediatric use. The energy level of the shock for pediatric use is reduced from the standard adult energy setting. The shock is reduced by an electronic device called an attenuator, which frequently comes with pre-connected pediatric pads. The attenuator may also be built into the AED and activated using a button, key, or another type of switching mechanism. Pediatric pads are recommended for children below 8 years of age. If the child pads are not available, use the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Do not apply child pads to patients 8 years of age and older because the energy level of the shock will be too low. Turn on the AED and bare the patient's chest.
Remove all clothing from patient's.
If there is a button, key, or another type of mechanism for switching to child use, activate it.
Child mode.
Peel the pads from the backing sheet one at a time and place each according to the pictures. Some pads require a front and back position. Others require a left-right position. Press the pads firmly in place. Do not allow them to touch each other. When the AED voice prompts you,
Do not touch patient.
clear the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If directed by the AED,
Everyone clear.
be certain that no one is touching the patient.
Press flashing button.
Deliver a shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR,
Do not touch patient.
the AED will prompt you again to analyze the heart rhythm.
Analyzing heart rhythm.
Follow the voice prompts.
Press flashing button. Shock delivered.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
In BLS, an infant is defined as younger than 1 year of age, excluding newly born infants. Like the child BLS procedure, there are 3 main elements of the infant BLS procedure: assessment of the scene and patient, actions based on the presence or absence of normal breathing and pulse, and use of an AED. First, assess scene safety. This includes taking standard precautions. If the scene is safe, assess responsiveness. Gently tap the victim and ask loudly.
Are you okay?
If the infant is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. If you don't have a mobile phone nearby, bring the infant with you to activate. Simultaneously assess breathing and pulse. Check the infant's brachial pulse. Place 2 or 3 fingers on the inside of the upper arm, midway between the elbow and shoulder. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly assess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. If the sudden collapse of an infant was witnessed, you may assume that the infant has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Quickly return to the patient, use an AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in infants is most frequently caused by asphyxia, 2 minutes of CPR is recommended before activating EMS or your facility's emergency action plan if you haven't done so already. As with the adult and child, there must be an open airway to give rescue breaths to an infant. The 2 methods to open the airway are the same: head tilt chin lift and jaw thrust. Use the head tilt chin lift maneuver to open the airway of an infant when head or neck injury is not suspected. Keep an infant's head in a neutral sniffing position. Tilting the head beyond a neutral position that results in hyperflexion or hyperextension may block the airway. Rescue breaths are extremely important for infants because infant cardiac arrest typically results from asphyxia. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Air in the stomach can cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see chest rise. Take standard precautions when providing infant rescue breaths. Use an infant CPR mask or bag mask device in addition to other appropriate PPE. Use an infant-sized pocket mask in the same manner as you would for an adult or child. Position yourself at the patient's side. Place the mask flat on the infant's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Tilt the head and lift the chin to open the airway. Maintain a neutral sniffing position. Lift the infant's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. To use an infant bag mask device as a single provider, select an infant-sized bag mask device. Position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger of one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Maintain a neutral sniffing position. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Check the pulse about every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, or there is no pulse, start high-quality CPR. There may be a rare or extraordinary circumstance when a barrier device is not available, and a BLS provider is willing to provide artificial ventilation without a barrier. For infants, the preferred technique is mouth-to-mouth and nose rescue breathing. To give mouth-to-mouth and nose rescue breathing to an infant, open the airway with a head tilt chin lift. Take a regular-sized breath and place your mouth over the infant's mouth and nose, creating an airtight seal. Give 1 breath over 1 second. Give enough air to make the chest visibly rise, but no more than that. If the chest does not rise, repeat the head tilt chin lift, make a better seal, and try again. It may be necessary to move the infant's head through a range of positions to provide effective rescue breathing. If you have difficulty making an effective seal over the mouth and nose, try using the mouth-to-mouth technique.
As in the adult and child procedure, high-quality chest compressions are the foundation of high-quality infant CPR. To deliver infant chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. For infant compressions, use one of 3 hand position techniques. The 2-finger, 2-thumb encircling hands, or the heel of one hand. For the two-finger technique, place two fingertips in the center of the infant's chest, just below the nipple line on the lower half of the breastbone. Do not press the tip of the breastbone. Use both fingers to compress the chest. For the two-thumb encircling technique, place the pads of both thumbs side by side in the center of the infant's chest, on the lower half of the breastbone. Your thumbs may overlap on very small infants. With the fingers of both hands, encircle the infant's chest and support the back. Use both thumbs to compress the chest. For the heel of one hand technique, place the heel of one hand on the center of the chest, on the lower half of the breastbone. Position your shoulder directly above your hand and straighten your arm to lock your elbow. Use the heel of one hand to compress the chest. This technique may be useful for larger infants, or when the BLS provider has difficulty compressing to the appropriate depth using fingers or thumbs. Whichever technique you use, push hard, straight down, compress the chest approximately 1 1/2 inches or 4 centimeters. This depth should be at least 1/3 of the diameter of the infant's chest. At the end of each compression, allow complete chest recoil. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruptions. Pediatric pads are recommended when choosing AED pads for an infant. If pediatric pads are not available, choose the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Turn on the AED and bare the patient's chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Peel the pads from the backing sheet one at a time and place each according to the pictures. The front and back pad position is common for infants. Press the pads firmly in place. Make sure the pads do not overlap or touch each other.
Not touch patient. Analyzing
When the
heart
AED
rhythm.
voice prompts you, make sure no one is touching the patient.
Everyone clear.
If
Press
directed by the
flashing
AED,
button.
deliver a shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions.
Choking, also known as foreign body airway obstruction, can occur when a solid object, such as a piece of food or a small object, becomes stuck in the upper airway. The person cannot breathe. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop out the obstruction. Chest compressions can also create enough pressure to expel a foreign body airway obstruction.
I'm exhausted.
To provide the appropriate care, you must be able to recognize the difference between a mild and a severe airway obstruction. With a mild obstruction, the patient can speak and cough. They may wheeze between coughs. A mild obstruction is typically cleared naturally by the patient through forceful coughing.
Cough it out. Come on.
If the person can inhale and exhale, encourage the patient to continue coughing. Watch for signs of the airway obstruction becoming severe.
That was scary.
Morning, Chrissy. How are you feeling?
Much better,
I need to get another set of your vital signs.
When a severe airway obstruction occurs, the patient cannot get air in or out of the lungs.
Are you choking?
This is a life-threatening medical emergency. If the foreign body is not removed, the patient will quickly become unresponsive and suffer a secondary cardiac arrest within minutes. Signs of a severe airway obstruction include the inability to speak, a weak cough, or no cough at all. The patient may make a high-pitched noise when trying to inhale or make no sound at all. They may hold their hands to the throat.
Try and get your breath.
If the patient is an adult or child, ask, "Are you choking?" If the person nods yes or is unable to speak or cough, act quickly. If you are not alone, have someone use a mobile device to call 911 to activate EMS or activate your facility's emergency action plan. Stand behind the patient. If needed, kneel behind a child. Reach around and locate the navel. Make a fist with the other hand and place it thumb side against the abdomen, just above the navel and below the ribs. Grasp your fist with the other hand. Quickly thrust inward and upward into the abdomen. Repeat. Each thrust needs to be given with the intent of dislodging and expelling the object. Continue until the patient can breathe normally or becomes unresponsive. If the object is expelled and there is good air exchange, encourage the patient to be seen by a healthcare professional. Infrequent but serious complications from abdominal thrusts can occur. If the patient becomes unresponsive, carefully lower the patient to the ground. Begin CPR starting with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the patient's mouth wide. If you see an object, remove it with your fingers. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If an infant appears to be choking but is responsive, watch for signs of the obstruction becoming severe. If there is good air exchange with a mild airway obstruction, the infant is coughing forcefully, has a strong cry, and can inhale and exhale, stand ready to help if things get worse. With a severe airway obstruction, the infant may cough weakly, be unable to cry, or unable to make any sound at all. There may be a high-pitched noise when the patient tries to inhale. If the infant is responsive and you are not alone, have someone call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Kneel or sit with the infant in your lap. Hold the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Rest your forearm on your lap or thigh to support the infant. Using the heel of the other hand, give up to 5 back slaps between the shoulder blades. Give each back slap forcefully with the intent of dislodging and expelling the object. Sandwich the patient between your forearms and turn the infant over, using the palm of one hand to support the face and the palm of the other hand to support the back of the head. Place 2 fingers on the breastbone, just below the nipple line, and give up to 5 chest thrusts. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the sequence of back slaps and chest thrusts until the object is expelled and the infant can breathe or becomes unresponsive. If the patient becomes unresponsive, place the infant on a firm, flat surface. Begin CPR with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the mouth wide. If you see an object, carefully remove it with your fingers. Don't stick your finger blindly in an infant's throat and attempt to sweep out an object. This can cause injury or push the object further down the throat, worsening the obstruction. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If the patient is pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the patient. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with the other hand and thrust straight backward. Try to not put pressure on the ribs. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the chest thrusts until the object is expelled and the patient can breathe or becomes unresponsive.
Hello po, good afternoon po. You can take your lunch na po. See you ulit po again at 1 o'clock p.m. po for ACLS lecture po. Thank you po.
Hello, Ma'am Joy.
Sa mga hindi po nag-avail nung ACLS, pwede naman po kayo mag-attend if want nyo po makinig sa lecture po ni Doc. And pwede naman po kayo mag-upgrade anytime if you want po. Just message your coordinators po. Thank you po. Kung BLS lang po yung in-enroll nyo po, if want nyo po makinig ng ACLS, pwede naman po.
So I will share my slide. So welcome to Advanced Cardiovascular Life Support with the interim guidelines of 2022. For those who did not take BLS kanina, dahil may BLS na sila, tapos diretso sa ACLS. So I'm Dr. Ted Esguerra, and I specialize in operational medicine or field medicine. I'm not the guy with the white lab gown, the white blazer or what. So I'm more in the field. So I'm trained on combat medicine, expedition and wilderness medicine, and I'm also a trained aviation medical examiner, being a flight surgeon before when I served. And right now, I'm the aeromedical director of the INAIC Air Care. So it's a air medevac outfit. So today, from basic life support, we bridge it towards performing more invasive intervention. And the right terminology is advanced cardiovascular, hindi cardiac. Kasi karamihang problema ay vascular. So advanced cardiovascular life support. We have to identify what's ACLS. Again, go back to the link of survival. And we have to learn the agonizing ECG. Kasi medyo graveyard yan ng ilang mga practitioners. No? And then, of course, we will go into drugs and into the stations of ACLS like advanced airway, defibrillation, cardioversion, tapos sasama ko yung transcutaneous spacing. Then how we can perform megacode. So actually ito sila lahat, hanggang bukas kasama yan. Yan po yung magiging magiging rundown. ACLS is an intervention wherein you will employ algorithms or clinical algorithms in treating cardiac arrest, starting from BLS and bridging towards ACLS, in doing the initial approach in stroke. No? So pag pumasok na yan sa mga ICU, pag meron ng sustained critical care, hindi na yan ACLS. Ang ACLS is yung acute, yung tipong nasa edge ng buhay or nag-aagaw buhay. So other than cardiac arrest and stroke, we also deal with myocardial infarction and hyperkalemia, and other reversible cardiovascular emergencies. So ang tinitingnan natin is mainly we look at the algorithm on how to do that, like tachyarrhythmia, bradyarrhythmia, cardiac arrest. And it is also addressing to the emergencies, no, yung life and death, like of course the respiratory arrest or cardiac arrest or both. No? So it's an interplay of CPR, of shock, of drugs, CPR, shock, drugs, or CPR, drugs, if the rhythm turns out to be non-shockable, kung arresting. Sa mga non-arresting naman, tinitingnan natin paano ma-reverse ang tachyarrhythmia sa bradyarrhythmia. And the ones who will perform this are trained personnel in doing ACLS. So sa hospital, tinatawag natin silang yun yung mga code blue. So pag na-identify kung yan ba ay can result into some sort of an emergency, so inactivate natin yung code blue. Okay? So sino magiging part ng code blue? Siyempre, doctors, sa mga specialty na tugma doon, and paramedics, nurses. So the scope is, well, I will not be discussing so much about the protocol. Pwede nyo makita yan sa internet. So doon tayo sa ECG reading, sa drugs, ACLS drugs, advanced airway management. So bigyan ko kayo ng dalawang style, the laryngoscope aided sa the non-laryngoscope aided. And then we have the IV, intravenous, but I will not discuss intravenous. Ibide-demo ko lang yung intraosseous kasi siya yung hindi nyo nakikita. No, you don't see that every day. Sa akin medyo home court ko yung intraosseous kasi pag gabi, hindi ko makikita yung veins. O dito ako sa IO. Then defibrillation versus cardioversion, tapos capnography or capnometry, then transcutaneous spacing, and then how we can perform megacode. Dadaanan natin lecture yung ACS and CVA. Yung PALS sa NRP ay ibang course yun. PALS for pedia and NRP for neonate. I will also teach you how to settle hypothermia because it's part of the reversible age. So ACLS is the cornerstone of all advanced life support courses. Pag magaling ka sa advanced cardiovascular, maning-mani na yung, hindi naman maning-mani, pero meron ka ng 60% nakuha mo na yung advanced life support. Kasi lahat na yan, hihinto din yan sa cardiac arrest. So pag magaling ka sa ACLS, may 60% na lamang ka na. When you take ATLS, PHTLS, PALS, NRP, MOET, no? So what are the 10 core ACLS cases? So one is respiratory emergency. Parang kanina, anong gagawin natin kapag may respiratory emergency? So ini-intubate natin yan, and then we can give some few drugs. No? Then the 4 types of cardiac arrest, yung ventricular fibrillation, BTAC, tapos PIA, pulseless electrical activity, sa asystole. Then 4 types of pre-arrest emergencies. Pwedeng brady or tachycardia yan, no? Tapos stroke. So ito yung batteries of things that you will learn, no? Once you take ACLS. Going back to the chain of survival, which is the backbone of all the courses in basic life support sa advanced cardiovascular life support. So doon tayo sa in-hospital. Alamin, no, ano ang i-recognize at i-prevent yung mga potential na pwedeng mag-cause ng cardiac arrest, no? So pag may pasyente ka, tinitingnan natin if the patient, like meron siyang modifiable indicators, no? Katulad ng mataas ang cholesterol. So minomodify natin, pwedeng magbigay tayo ng statins, pwedeng magbigay tayo ng fibrates, no? Mataas ang presyon, mataas ang sugar, smoking. So ito yung mga, how do we recognize so that we can prevent the occurrence of the cardiac arrest. Then in case mayroong cardiac arrest, alam mo paano mag-activate kung pre-hospital or mag-activate kapag inside the hospital, like a cold blue activation, tapos perform high quality CPR, then defibrillation, tapos employ the ACLS and the post cardiac arrest care. Then of course, pag nakauwi ng pasyente, paano yung ma-explain sa family ano yung kanyang mga maintenance na gamot. Now, before we start ACLS, kailangan alam natin to. Pag nagbasa kasi kayo ng libro, magugulat kayo sa bawat mini-mention doon. Meron silang nilalagay na COR or Class of Recommendation. For example, sige, tapusin ko lang to Class of Recommendation. Tapos, noong 2019, nagdagdag na sila ng LOE, Level of Evidence. So, lahat ng approach or intervention ay nasa evidence-based medicine. Hindi pwedeng parang COVID, ivermectin, treatment ka agad sa COVID. Walang ganon. Kasi I was so sad na even doctors ay nagkakampanya sa ivermectin. 2 things. Hindi tayo magaling na researching population as doctors. Tayo ay kumukuha lang ng gamot sa labas. US, European. No? Kulang tayo ng research facility. Kung hindi nyo naintindihan yan, deep dive some more. Palabas na kayo, makita niyo kulang na kulang tayo sa resources para magkaroon ng mga experiments and researches. Mahina tayo dyan. Hindi kultura natin. So, nangungupya lang tayo anong meron sa abroad, nakapag-aral ka sa abroad, or nadidiscuss sa'yo ng isang medrep, tapos pinakitaan ka ng mga EBM, evidence-based, mga meta-analysis. Doon tayo naniniwala. Nung nagka-COVID tayo, out of nowhere, wala naman sa study na may ivermectin. Biglang ang ivermectin. At kinampanya, the funny guy is the congressman, parang doktor, nagsasalita sa ivermectin. Tapos yung mga doctors naman, sumasang-ayon. Tandaan natin, Hindi kailangan ng matinding eskwelahan para maintindihan niyo ang pharmacology. Lahat ay nag-aral. Ang isang gamot, maraming pinagdadaanan yan. Kumuha ng pharmacokinetics saka pharmacodynamics. Kinukuha mo yung molecules, paano mag-act sa katawan. And it takes years. 10 years, 20 years, and even as long as 30 years. Not out of nowhere, gamot na kaagad siya. Kasi dadaan ka ng meta-analysis. When I will remove meta-analysis in the practice of medicine, magmarites na lang tayo lahat. Masakit na? Pero we are people of science. Kung sinabing magaling ako. Pero pag tinanggal mo na ang siyensya sa larangan ng practice ng medicine, wala na talaga tayo sa ayos. So ulitin ko, sana hindi tayo magkamali sa susunod na episode ng kabanata ng buhay natin ngayong new normal. Kailangan dadaan tayo sa ganito. May classes of recommendation sa levels of evidence. Bago tayo gagawa ng isang bagay, kasi EBM na ngayon, evidence-based medicine, dadaan mo na sa classes of recommendation sa levels of evidence. That's why I'm telling you this, because yung libro na mabibili ninyo, if you want to buy the book, because I have the book, I just did not bring, I think it's downstairs. Nang binasa ko yun, ito yung pag nag-mention ka ng isang intervention, kunwari CPR. Pag CPR, if the CPR is first mentioned in the book, lilitaw ka agad yung class of recommendation. Class 1 siya. Ibig sabihin, benefit is 3 times greater than the rest. Okay? So, mga tipong ganun. So, ano yung class 1? Yan po yung kailangan maibigay siya. Meron tayong mga tinatawag ng comparative sa effectiveness niya na nakasaad doon na ito ay kailangan ibigay. Okay? Recommended siya. Suggested phrases for writing recommendation. So, this, pag nakasclassify ka class 1, recommended. Katulad ng compression. Pagbigay ng oxygen sa arresting patient is still class 1. Yan. No? Ano yung class 2A? Suggested na ano pa rin siya, reasonable na ibigay sa pasyente. Can be useful. So class 2A siya, moderate siya, benefit is 2 times greater than risk. Ano siya dito? Defibrillation is class 2A. Epinephrine is I think class 2A, class 2A epinephrine. So bawat mention na bagay-bagay, meron siyang COR. Tapos hanapin mo rin kasi magkakaroon din siya ng anong level of evidence. Kunwari, pag sinabing level A, high quality evidence yun, no? Na meron siyang randomized na trial, no? Tapos pag level B, R, randomized siya, no? Moderate quality evidence, binibigay pa rin natin to. Pag level B and R, halos okay pa rin. Pag level C, LD, limited data, medyo dito nag-aalanganin. Medyo kulang pa tayo. Tapos yung iba naman, institution na, pwede silang magsalita, mag-recommend, katulad ng level C, EO, expert opinion. So pag nakakita ka ng gamot, kunwari, nasunog ang muka, lagyan ko ng honey. Wala pang nirelease silang study according to level of evidence. So kung si Dr. Paul Auerbach na wilderness doctor, sinasabi lang niya na level C, expert opinion. So level C, it does not mean it's wrong. Nagkataon lang na hindi pa nila nabigyan ng randomized kasi ongoing study. So pwede pa natin siyang ilagay na kunwari class of recommendation. Kung naaral na, pwedeng class 2A, no? Kasi plant product siya, it might cause some reaction, assuming. Pag limited data ka pa, pwedeng level B and R, no? Or level C, LD. Or meron ng ebidensya, pero kulang pa, non-randomized ka sa level B and R. So this is a backing to the classes of recommendation. I hope you understand kung saan huhugutin ni ILCOR sa ni American Heart Association ang kanilang manual on advanced cardiovascular lifestyle. So yung mga doctors behind the research, so ito yung tinatawag na applying class of recommendation and LOEs to clinical strategies, interventions, treatments, and diagnostic testing in patient care. So 2019. Before 2019, wala pang LOE. Ang makikita mo lang is classes. Nung prior to 2012, makakita ka pa ng class indeterminate. Ngayon, ito na yung bago. Class 1, Class 2A, Class 2B, Class 3, and then may Class 3 na strong, absolutely not allowed. Okay? So, yan . So I will not discuss the abbreviation. So ito yung mga normal sa ginawa natin, luma. Ito na yung luma pa. Ito yung bago 2020. Ito na yung 2020. Ito yung luma na atin kasama itong luma dito. So ito yung 2020. So sa 2020, yung kaninang didiscuss sa basic life support, sa interim guidelines, nakitaan natin na na-emphasize itong yellow. Don't PPE, limit personnel doon sa action site mo or doon sa code site, code blue site. Tapos consider resuscitation appropriateness. Ibig sabihin, pag si airway wala pa doon, huwag tayong magpuno ng ibang tao na hindi siya kailangan. Okay. Tapos, when you start CPR, limit aerosolization. No? So, anong ibig sabihin nito? Pag nag-ISO yung ospital ninyo, tinitingnan po paano kayo mag-address sa cardiac arrest. So, kailangan merong ventilation. PPV, positive pressure ventilation, may inlet, may outlet. Gagawa kayo ng wind corridor. And then, kailangan ang inyong airway kit na advance ay nasa gilid na ready to be given anytime or introduced anytime. Okay. So ngayon, nag-perform ako. Ang emphasis ng 2020 plus 2022 interim guideline, isinabak nila dito. So kung titingnan mo tong aking slide, ito yung pinaka-latest. Ngayon, habang nagsiyarak ko, pag natapos dapat ang ideal no, sa setup sa ospital, within 2 to 3 minutes na natapos to, sabihin natin maximum 4 to 5 minutes, dapat ang pasyente, i-intubate mo na. Pahintuin ang chest compression, intubate ka agad. Pag na-intubate delay, dalawa lang yan. It's either balik ka ulit, bagging, tapos tuloy, drug, shock, tapos prepare for intubation ulit. Kung wala kang supraglottic. Pero kasi pag nagkamali ka, 1, supraglottic. Unlike sa inyong hospital, kailangan, ewan ko kung anong patakaran nyo, 2 failed endotracheal, ET, intubation, bago pa mag-supraglottic. Hindi ko papakialaman kasi inyong protocol yun. So, after the 2-minute run dito sa itaas, meron ulit akong 2 minutes. So, intubate ko na ang pasyente, tapos at the same time, meron na akong intravenous or intraosseous access. Then I can drive my epinephrine 1 mg per ml. So, tuloy-tuloy siya until titingnan ko kung shockable ang rhythm, then I will shock. Pag shock, tuloy ang CPR, bigay ulit ng epinephrine or pwedeng magbigay ka ng other drugs like amiodarone. The first 3 drugs na makikita mo na na-mention dito is epinephrine 1 mg per ml, amiodarone 300, initial dose, ang second dose mo is 150, and then you have the lidocaine which is 1 to 1.5 mg per kilogram. So kaya ang loading dose ng 100 mg. So yan yung ating drugs. Ang ginagamit natin na defibrillation, karamihan ngayon, kung susundin ko yung standard, is 200 joules na po. No? Hindi na po tayo gumagamit dahil according sa evidence-based medicine, ang 360 ay nakakasakit po sa puso. Nakakasakit, tama ba? Bisaya kasi ako. Nakaka-injure kahit paano dito kasi mas mataas ang kanyang energy release. So ang ginagamit na natin is the biphasic 200. Tapos, ano yung advanced airway natin? I'll leave the protocol to you. Ang ini-establish natin is yung closed circuit disconnection, and then at the same time, yung ating intubation stop natin ay meron siyang first pass success. Ano ibig sabihin? Kailangan pag nag-intubate ay hindi palpak. Pero talagang minalas ka sa araw na yun, pumalpak ka, then take a rerun. Or diretso ka na sa supraglottic airway. At ideally, dapat ang pasyente pag na-intubate na, kinakapnometer natin. Kasi whatever happens, ang pinagbabasihan natin, if the cell is still viable, ay capnometry. I will discuss it pagdating para maintindihan nyo. Meron kasi akong capnometry dito na nakakalat na. So, may capnometer ako ito. So, kinakabit ito, magdi-display siya rito. Pero ano po ito tawag ito, gumagana. Meron ako doon sira na, yun ang mahal, 90,000. Ito mas mura na to, 17,000. So yung 90, grabe no, mahal, nasira. Nagamit ko, since gumagamit ako ng capnometer since 2009. Tapos nasira siya 2013. Nung after pumunta ako sa South America, South America, na siguro nabugbog na miss yun, na tuluan ng tubig, kaya nasira yung kanyang circuit. Sayang, mahal na mahal pa naman yun. Okay, what else na emphasize ko rito? Then we look at the reversible H&Ts. So there are 5 to 6 reversible H&Ts. Na yun ang pinagkukunan ng essence ng ACLS. Kung bakit may ACLS, i-reverse natin yun. So anong ibig sabihin ng H&Ts? Meron kang sa H pa lang, yung hypovolemia, merong hypoxia, hydrogen ion or yung acidosis, meron kang hypokalemia, pang-4, hyperkalemia, pang-5, then meron kang hypothermia, pang-6. Okay? So 6 yan. Hindi pwedeng si hypo sa kasi hyper pag-isahin ko kasi una, magkaiba treatment modality. Then sa T naman, merong tension pneumothorax, tamponade cardiac. Yung cardiac tamponade, inuna lang yung tamponade to satisfy the T. Tamponade, tapos tablets, no, overdose ng mga drug, toxin, ito yung mga toxinology sa toxicology, no, has something to do with poison, tension, thrombosis pulmonary, thrombosis coronary, tapos trauma. So yung toxin sa tablets, pinag-isa na lang natin yan. Tapos yung trauma, pag tinamaan ka sa spine, tapos nagbibigay tayo ng gamot na neuropeptide para bumalik ulit yun, parang sa stroke or sa ano na meron na na-discuss namin with my counterpart sa Austria na ang galing, ini-inject mo lang yung neuropeptides tapos nag-heal mabilis yung brain. Galing na, no? Hindi ko lang na-transfer sa slides pa yan. So ayan, pinalaki lang siya. Ayan po ang mangyayari. Pinalaki lang. Okay, so ang una, BLS pa, ito BLS. By the time na meron akong IO at isinabay ko pa na magkaroon ako ng intubation, pumasok na ako sa advanced life support. So sa advanced life support, tuloy-tuloy pa rin ang CPR. Kung shockable siya, nagbigay ako ng shock. I gave epinephrine again. Tapos hinook ko sa tamper para hands-free ako. Tamper lang siya. Then after 2 minutes, shockable rhythm. Tapos bigay ako ng amiodarone or lidocaine. Pwedeng third dose. Depende sa ano niya. Kung non-shockable naman, epinephrine lang din. Tapos under sa mechanical compression device, shockable, no. Treat reversible causes. Tapos shockable, no pa rin. Puro ka lang epinephrine. Dito, epinephrine ka lang. So ito, nabanggit ko na kanina sa BLS. Ito yung interim guidelines na na-emphasize. Ang interim guidelines, wala namang pinagbabago. Except kailangan naka-HEPA filter, no? Tapos, yung pag nag-intubate ka, sorry, i-basic ko muna para sa mga taong hindi naka-BLS. Pinakauna, doon talaga, level 4, level 3. It might not apply to you right now kasi bumaba na ang ating alert level. Ibig sabihin, hindi na siya alarming. Okay? So, bumaba na. Ngayon, doon pa rin tayo kasi sabi ko sa inyo, pag gumawa kasi ako lahat ng literature na nang ginamit sa medisina, pag nag-release yan, kunwari 2020, it does not mean 2020 yan. Pwedeng 2018 pa lang yan. Yung mga meta-analysis or kung sa gamot, yung mga studies niya, ginawa yan 2020. So naka-atras, kaya late yan. Pag sumalang yan sa 2020, 2018, kaya yung 2020 ACLS book na ganito kakapal, ni isang COVID, wala siyang na-mention. Magtaka kayo, bakit walang COVID 2020? Because ginawa yan 2018. At pinakamalawis 2019. Nang ni-wrap up na nila, yun na. 2020 kasi, lagi pag nag-release ka ng book, ang i-mention mo is the releasing date. Okay, the releasing date is 2020. Yan, ganyan po ang mechanics pag nag-libro. So natutunan ko yan kasi I'm an author of 3 books. Meron po akong, author pa ako ng mga preparedness books. No? Kaya naintindihan ko. Ginawa ko siya 2 years before, pero nang nirelease siya 2019, 2017 ko pa ginawa. Nirelease siya 2019, mga. And then next is the limit of personnel, no? Tapos consider using mechanical CPR devices. Yung mga yung yung naka-hydraulics na ano. Tapos powered by oxygen, yung tamper, para intrinsic siya, hindi siya electric, hindi siya electronic. Vampire yan, vampire. Ibig sabihin, grabe kumain ng oxygen. So pag nag-tamper ka, dapat malaking tangke na oxygen nagbibigay ng ano, power sa kanya para hindi siya mag-cause ng mga apoy. So hinikayat na gumagamit tayo ng tamper. Yun po, wala ako. Baka si Zol, kung mag-donate siya, I'm okay. Tapos communicate COVID-19 status to any new provider. Pero although hindi na so much applicable that today, even for the fact that COVID is still there. But it is not as alarming as it was before. Ngayon, ang priority natin is oxygenation and ventilation na kung saan hindi kakalat yung aerosol. So, gumagamit lahat ng HEPA filter. So, sa dulo po ng ating bag valve mask, may kinakabit po doon yung yung in-exhale ng pasyente, lalabas doon, sasaloy ng HEPA filter. Kaya kung bibili kayo ng BVM or BMV, BVM is bag valve mask. In other countries, it's called bag mask valve, BMV. Pareho lang yun. Sa Pilipinas, gumagamit ng word na AmbuBag. Ang AmbuBag is a brand, no? Hindi siya yung generic. Ang generic, BVM ang tawag. So, kailangan may HEPA filter. Tapos, kailangan may first pass success tayo, intubate early. Tapos, yung taga-intubate or intubator, mas magaling dapat with highest chance of first pass success. Tapos, pag nag-intubate ka, kailangan walang chest compression. At ang ginagamit ay yung video laryngoscopy. Yan. So ako po, meron po akong video laryngoscopy since 2004 na hindi pa siya uso sa Pilipinas kasi I came from abroad. So ginagamit ko. Tapos nasira na rin malauna. Plastic lang siya, hard plastic na Macintosh. So meron din tayong tinatawag na alternate for endotracheal tube, which is your supraglottic airway, and it's gonna be part of my lecture. Ngayong buong hapon, more on didactics tayo. Para bukas, demo on code blue na lang and other stations of advanced cardiovascular life support. Okay. What else with the ano? So marami po dito mga interim guidelines, naka-post yan. Oh. Basahin nyo na lang yan. Hindi ko na isa-isa. So ito po yung luma. Ito yung luma natin. Ikumpara mo sa bago. Yeah. At ito yung mas luma para makita niyo lang saan nag-evolve ang ACLs. And it's still applicable except marami ng applicable pa siya unless except for some deep dive on intubation, on the speed of compression. Tapos dati naalala ko pa, ang epinephrine na binibigay ay dapat 1:10,000. At hindi 1:1,000. Ginagamit namin yung 1:1,000 dilution kapag anaphylactic siya. Ngayon, hindi na. Epinephrine, isang epinephrine na lang lahat. So, ano ang ginagawa natin kapag mayroong cardiac arrest in the first 2-minute run? So, siyempre, CPR quality ka, no? 100 to 120, minimize interruption in compression. Itong 120, push hard, push fast, with complete chest recoil, ito na yung bago. Kasi dati, hiwalay si chest recoil. Adequate chest recoil. Ngayon, sinama na sa rule number 1. Push fast, push hard, at least 100 to 120 per minute and allow chest recoil. Pangalawa, minimize interruption in compression. Pangatlo, avoid excessive ventilation. Pangapat, rotate mandatory compressor every 2 minutes. So bawat paghinto ng 5 cycles or 2 minutes, pag sumigaw na si automated external defibrillator na analyzing, yun na yun. palitan kayo. Okay? Then, kung walang advanced airway, 30:2 ang ratio. Pero pag may advanced airway, hindi na siya synchronized. Tuloy-tuloy lang si compression all throughout, tapos yung pagbigay ng respiration ay every 5 minutes or 6 minutes. Isang blow every 5 to 6 seconds, sorry. Tapos kailangan makahook ang capnometry. Kailangan maka-maintain ng at least 12 to 20 habang nag-start CPR. Kasi pag less than 10, ibig sabihin may problem lalo na sa CPR quality or sa airway siguro. Drug therapy is epinephrine, amiodarone, saka lidocaine. So yan, nandiyan ang dosage. Tapos ang advanced airway na ini-institute natin kasabay na sa pagbigay ng oxygen ay merong standing protocol. Sanay tayo endotracheal tube. So ano ba ang internal protocol niyan? Pag hindi na-insert yung tube, so pwede ba supraglottic, parang tipong gano'n. So pag merong return of spontaneous circulation, paano natin suportahan ng mga inotropics or inotropes? Shock energy, biphasic ang ating ginagamit ng 200, pero pag wala, 360 monophasic. Okay, and these are the reversible causes. So ito yung lumang approach. Yan. So lumang approach, pero pareho pa rin, except hindi na-emphasize ang loading of PP. Ngayon, lapit ko lang electric fan, sobrang kainit. Anong mangyari kapag hindi arresting rhythm? At ang nakita nating rhythm ay tachycardia. So how do ACLS, what's the algorithm for that? So pumasok ang pasyente sa ER kasi nagpapalpitate, pwedeng drug-induced or what? Or a chronic problem already, maybe a coffee drinker for so many years at bumigay na yung heart. And then, hinok mo. Ang mangyayari dito, hinok mo sa oxygen, at cardiac monitor, tapos ang lumabas kunwari atrial flutter with rapid ventricular response, no? Sirit-sirit ang tibok ng puso. Aalamin natin muna, kasi bibigyan natin ng gamot eh. Alamin muna natin kung siya ba ay merong hypotension. Kasi kung hypotensive na ang pasyente, namumutla na siya, meron siyang altered mental status pa, huwag na natin patagalin. Pwede natin siya i-cardiovert. That's the point doon. May signs of shock, mababa ang BP na below 90 degrees centigrade, and then merong ischemic chest discomfort according sa kanya or sa relative. So these are indicators, no? Kaya ang gagawin, kailangan kandidato for synchronized cardioversion. Then, and or to. Una, hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and or may acute heart failure. So kung nakitaan mo, halimbawa may dalawa, may yes, no? Prepare mo sa synchronized cardioversion. So ang ginagawa ko dyan, ako nagmimidazolam ako. Sinisedate ko, tapos pero may initial gamot ako. So depende naman. Kung yung kanyang rapid ventricular response ay narrow QRS naman, I can start 6 mg adenosine habang piniprepare sa cardioversion. So ganyan. Pero pag sa tingin natin wala tong hypotension or alternate status, signs of shock, tingnan natin ano ang forma ng QRS complex. So pag sinabing QRS complex, ito ay ang mga waveforms na nagsama-sama. Si letter Q, si R, si S. Pag nagsama-sama silang tatlo, ang tawag doon complex. Ngayon, kung wide QRS at naka-IV na ako, nakita ko sa pwede pa rin mag-adenosine. Kung naka-adenosine ako kanina, pwede na ako mag-jack up ito 12 mg. Pwede rin consider any antiarrhythmic infusion like lidocaine or amiodarone. Pag dito naman hindi naman sa wide QRS, you can still continue with adenosine. Pag walang adenosine, katulad ko, kunwari ang patient is PSVT. So, calci blocker ako. Calcium channel blocker. When you can have beta blocker, basta ang BP hindi naman bagsak. And of course, refer it to the cardiologist. So, mamaya makikita natin, pagdating natin sa ECG, paano natin basahin yan. Mainit yung laptop ko. Inaano ko sa... Yung mga gamot, no? Sa synchronized cardioversion, may mga joules tayo na saktong dosage. Pag narrow regular, you can cardiovert it from 50 to 100 joules. Pag narrow irregular naman, like atrial fibrillation with rapid ventricular response, you can fire at 120 to 200. Okay? So sabay basic yan. Tapos pag wide pero regular, 100 joules at starting. Pero pag wide irregular, hindi na po yan kaya ng cardiovert. Dinidiretso na po natin sa defibrillation. Now, if you want to have kunwari, merong PSVT, supraventricular tachycardia, meron tayong tinatawag na chemical cardioversion, gamitan mo ng gamot. So, ang starting natin is adenosine. 6 mg. Tapos, pag nag-flash ka ito, didemo ko bukas. Kasi pag nagkamali kayo dito sa adenosine, kamahal na gamot, pinatay niyo lang yung adenosine. I'm gonna explain why tomorrow sa demo. Meron din ibang mga antiarrhythmic infusion, no? For stable wide QRS, like procainamide. Although seldom nyo na lang gamitin to, nasa sa ER by the time na procainamide kayo, na ang pasyente sa ICU. Although meron ako, ang procainamide, napakalaking amber na lagayan yun. So, binibigay natin at 20 to 50 mg per minute hanggang ang arrhythmia ay suppressed. There is also like a maintenance infusion of 1 to 4 mg per minute. Amiodarone naman, ang preparation niya, mapipili natin dito sa market is 150. In cardiac arrest 300. Oh, may tanong. Yes po. So, once mag-start ka ng adenosine, 6 mg. Okay? Then, 12 mg. Tama po. So, parang pag nabigay ako adenosine ngayon, 6. Ituturo ko siya kasi maraming nagkakamali sa adenosine na hindi siya naging effective kasi madali siyang patayin ng red blood cells. Kaya medyo mabilis ka magbigay. So, 6, 12, 12. Okay? Ganyan po. Kung hindi kaya, tapos nag-unstable na, pwede ka na mag-cardiovert. Or kung kaya pa, medyo okay naman ang BP, pwede ka mag-beta blocker. Ang amiodarone, ang first dose mo 150 over 10 minutes. Lalo na kapag ang tumama dito, no, ay sabihin natin wide complex. okay si amiodarone. Sotalol, 100 milligram over 5 minutes. Okay lang siya, basta huwag lang naka-dive masyado yung blood pressure. What if meron tayong bradycardia or mababa pagtibok ng puso? Pumasok sa ospital, hilong talilong siya, so ino-oxygenate natin, hook sa cardiac monitor para makita anong rhythm. You can already start IV, mandatory. Tapos yung ating monitor is capable of 12 lead ECG. No, kung meron tayong ganon, maayos. Pag wala, nakatulang tayo. Ano yung Roman numeral. Eh, makikita natin anong forma niya. Makita natin may bradyarrhythmia siya. Alamin ulit natin, meron bang hypotension and or merong altered mental status and or signs of shock, no? And or ischemic chest discomfort and acute heart failure. May isa or dalawa siya, kailangan maano natin, mabigyan ng loading dose ng atropine. So, pwede na magbigay ng atropine 1 mg every 3 to 5 minutes ang interval. Pero ang problema lang dito, ang kanyang maximum dose is 3 atropine lang. Hindi ka na pwede mag-exceed na naibigay mo sa katawan. Pag ineffective, usually kasi makita mo 2 atropine lang. Pwede ka mag dopamine, no? So ang dopamine medyo kakaiba. Nung unang panahon sa amin is 3 escalating dose pa yun siya. Mataas-taas, no? From 1 mg tapos naging 3 mg, mga tipong dati na makaluma. Pero sa bradyarrhythmia, atropine ka, pag hindi umubra, pwede ka mag-dopamine. Again, nung lumang panahon, meron kaming 1 to 5, which is the renal dose, 5 to 10, which is the cardiac dose, and then 10 to 20, which is the vasopressor dose. Ngayon, hindi na, tinatitrate na lang natin, depende kung ano yung gusto natin ma-achieve na result sa pasyente. Ganyan po ang dopamine. You can also infuse epinephrine. Isang beses ko lang na-try, hindi ako komportable. Dopamine guy pa rin. Transcutaneous spacing is kailangan. Pero kailangan mayroong clearance sa clinic. Hindi siya, kailangan lang, transcutaneous spacing kailangan. Kung wala na ibang choice, lalo na sa amin sa field kasi nagawa ko yun transcutaneous space. Kasi wala akong transvenous So, yun yung bagal pagtibok ng puso. Ewan ko, nakwento ko po ito kanina. Hindi ko lang kung nakwento kanina ng umaga sa Bls. German national siya, yun. Transcutaneous space po siya. Kasi ang kanyang heart rate is more than 30, less than 40. Hindi na paakit ng atropine. Umakit konti. Pero succeeding atropine saka dopamine, sumablay siya. Na persa ako mag-transcutaneous space. What if we have return of spontaneous circulation or ROSC? Anong mangyayari? Tuloy-tuloy pa rin natin yung ating FiO2 or yung oxygen saturation at magtatama ng 92 to 98. Maganda ang ating oxygenation and ventilation. Kung hindi mo pa, kung nag-reverse ang pasyente, during nag-fire ka, hindi ka nakapag-advance airway. Pero dahil hindi mo pinauwi, no? Sorry, yung parang sa field, no? Pag na-resuscitate na siya sa field, hindi mo pwede pauwi, no? Pag nakitaan mo pang mababa pa rin yung BP pero may pulso na, mag-inotropes ka na talaga. So, particularly if BP is 90, systolic is less than 90, pwede ka mag-fluid challenge, 200 ml. Tapos vasopressor infusion, hanapin si H and T's, baka lumitaw doon bago pa mag cardiac arrest ulit tao. Dali natin sa laboratory, cardiac cath lab. Tingnan natin kung anong nag-cause noong bakit ganun ang pasyente, tapos bakit mahina pa rin. So inaalam natin, tingnan, STEMI pala to, anong pwedeng idagdag na drugs, en route to ICU or CCU. So what are the pointers? Sa ROSC, bantayan natin, baka magka-tension yung thorax kapag na-hyperventilate. So avoid excessive ventilation. Tapos yung laruin mo lang yung pet ko na ang pasyente ay naglalabas ng carbon dioxide by 35 to 40 millimeters of mercury, makikita yan sa capnometer. And then IV bolus, 1 to 2 liters, normal saline or LR. Kapag although wala pang gumagawa nito, at ito yung gusto kong gawin sana, yung tinatawag na induced hypothermia. So ang pasyente, para mo siyang pinatay a little bit. No? Tapos magbigay ka ng 4 degrees centigrade fluid. Yan po yung tinatawag na hypothermia. Lalo na sa stroke, effective daw to. Again, infusion of epinephrine is 2 to 10 microgram per minute. Infusion of dopamine, si dopamine talaga nauuna nito, is 5 to 20 microgram per kilogram per minute. So, halos unahin ko muna ay si dopamine. No, after for example, cardiac arrest, tapos nabuhay ko na, tapos ang BP ko 80 pa rin, so pwede ako mag-dopa. Mababa heart rate ko, pero buhay na yung tao. Ayan. Stroke, nabanggit ko na kanina yan. Ano ang pag-manage ng stroke? Okay, simula pa yan sa pre-hospital care. Grabe kasi ang ng pre-hospital care, yung involvement niya. So doon pa lang, chinek na natin sa glucometer, tinawagan na yung triage of stroke center of that hospital in alertan. So naka-radyo or telephony, parating kami, we are 10 minutes out. So nagpe-perform na siya ng initial action, assessment and action. Naka-hook sa auto, tapos nag-Cincinnati pre-hospital stroke care. Tinignan ko yung glucose level niya sa glucometer. Okay? And then inform stroke center na may dadalhin ka. So, baba ako sa ER. Tingnan niyo ako yung cursor. Ideal, no? Within 10 minutes, nasa ER ka raw. Naku, parang hindi obras Pilipinas to. Nakatuwa, no? Saglit, may tanong. Parang sandwich pag binibigay. Hindi tayo when we give medicines right now, hindi tayo nagbibigay ng initial run, no? Yung kung may initial run ka, kunwari inferior wall MI, tapos bagsak, may hypotension, huwag ka magbigay ng morphine kasi kasama sa morphine, although i-discuss ko kami. Pwede ka mag-fluid challenge. So walang mga initial dosing, no, na 10 cc plus, hindi tayo nagkaganon kasi waste of time. I-discuss ko lang pagdating sa fluid, paano natin ginagawa, lalo na sa adenosine, para hindi ako ma-off track. I'll answer that, no problem. So dito muna ako sa stroke. Hindi to uubra sa Pilipinas, pero susundin ko lang si AHA. Okay, so ito po yan. Lahat ng stroke kailangan ma-CT scan. Pero bago mag-CT scan, ito muna mangyari. Within 10 minutes, dapat nasa ER. Naku, nakakatawa, no? Parang hindi uubra. Patay tayo rito. Parang hindi. So, sige lang, kunwari, guys, kunwari. Boom! Nasa ER. Sa ER, gagawin yun, ABC, na continuous oxygen, IV access kung hindi ka naka-access, tapos kuha ulit ng glucose. No? RBS siya, tapos 12 lead ECG. Ginawa to lahat for another 10 minutes. So 20 na. Ngayon, ganun ba ka-aktibo ang ER? Hindi katulad dati sa pinagtrabahoan ko. Meron kaming, alam niyo yung glucometer, right? Everyone knows glucometer. Meron kaming tinatawag na diagnostic assembly na para siyang glucometer, pero kaya niyang i-check ang electrolytes lahat. Ang ganda, ang galing. Mahal nga lang. Bibilhin mo siya, sinubukan kong bumili yung luma na. So many years ago, pinipresyohan ako ng 12,000 US dollars. Sana ko kukuha ng 12,000 US dollars. Diyos mio. Pero ang ganda. Di ba sayo, kukuha mo na ng blood sample, tapos dalhin sa laboratory, maghintay pa tayo kung ano ang electrolytes. Pero yun hindi. Drop lang ng blood. Ginagamit yun sa expedition medicine. Drop lang. Pero medyo marami yung drop mo. Pag drop doon, ang una kasi ililinis mo pa. Drop ka, linis. Tapos second drop, i-absorb ng parang maliit na pipette, kakainin ng machine. Meron ka ng electrolytes, meron kang BUN, Treya, Kanda, RBS. Wow! Yun nga lang, 12,000 US dollars. Hindi pa brand new yun. Binibili ko luma, refurbished. 12,000 US dollars, where will I get the bloody? Pero tuwang-tuwa ako ha. Yan, galing no? Ganyan na po ang medicine ngayon. So, bantayan natin dito, sa stroke pa lang tayo, bantayan natin, bago maka-CT scan, ilang minutes na nawala. After 45 minutes, tapos na lahat yan, isi-CT scan ko na anong mangyayari. Doon ko na malalaman kung merong no hemorrhage saka may hemorrhage. So dito muna ako sa madali, sa no hemorrhage. Kasi pag may hemorrhage yan, medyo masalim po. Acute ischemic stroke, so candidate for fibrinolytic therapy. So, tingnan natin, may checklist tayo for fibrinolytic exclusions. We have to re-perform neurologic exam. So dito, meron na tayong piggybacking with neurologist. So candidate pa siya? Yes, candidate. Then, i-ano natin. Pwede na natin bigyan ng RTPA kung anong pwede na. So, kailan nangyari to? Within 1 hour. At within 3 hours, na-execute na lahat to. Grabe. That's the ideal. Pero pag hemorrhage, susundin mo yung stroke or hemorrhage pathway, medyo makomplikado to. Since ACLS tayo, hindi tayo nag-deep dive into that. Hindi na nila ni-rundown lahat. Tapos, more monitoring pa gagawin natin. Now we go into ischemia. Ito yung tinatawag nating coronary thrombosis. No? So sa hospital, sa ambulance pa lang, ginawa na ang MONA. Ano ang MONA? Wala dito sa Pilipinas ha. Nako, mga ambulansya sa Pilipinas, hindi man lang advanced cardiovascular life support grade. Kung meron, privately owned. Bihira lang yung ACLS grade. Diretso ako magsalita, no? I know that. Sa ikot ko sa Pilipinas, hindi ko talaga nakitaan na meron tayong ACLS. Hindi kaya i-maintain. Lalo na kapag may mga prohibited na gamot the likes of morphine. So sa ambulansya pa lang, pwede nang bigyan ng morphine, naka-oxygen siya of course, naka-nitroglycerin, sublingual or spray, at saka aspirin na 3 to 5 mg. Mamaya titingnan ko anong ginagawa ko pag merong MI. Kasi hindi ko naman masusunod ang AHA eh. Niloloko ko sarili ko. So nilaro ko lang according sa Philippine template. So mamaya ipapakita. Pagdating sa ER, naku, less than 10 minutes, parang hindi yata pwede mangyari sa Pilipinas yan. I-perform ulit lahat, i-check, physical exam, 12-lead ECG, or pwedeng bypass to cath lab. So depende yan sa usapan. Ngayon, titingnan natin, meron ba akong STEMI o ST elevation MI? Tatanong natin. Kasi ang habulin natin dito is PCI. Okay? Para ma-reperfuse. So tanungin natin siya. Simula ba sumakit? Less than 12 hours? Pag less than 12 hours, ang reperfusion goals ko, yung tinatawag na door-to-needle fibrinolysis, ay kailangan ma-achieve. So dito natin, pini-PCI ang pasyente. Pwedeng balloon tayo, mag-stent tayo, whatever. Okay? So less than. Pag more than 12 hours, magpe-perform pa tayo ng iba. Like, harapin pa natin yung trop-I. Okay, then candidate siya for high nitroglycerin, yung low molecular weight, heparin, depende sa ano ang gusto ng cardiologist. So hindi na ako mag-deep dive dito. Kapag more than 12 hours, i-categorize ko siya like the patient is having non-ST elevation MI or an unstable angina. Okay, so yan. Tapos meron itong low intermediate risk, nag-chest pain siya pero wala kang makita. Walang ano, no? Makikita mo, although may development, high-risk features, no? Kunwari, diabetic or merong kidney, like a kidney disease. So, mas marami pang extensive, no, na maneuvers ang ginagawa. So, all the rundowns are here. Kaya ang isang doktor, pangarap niya, STEMI kasi medyo mas madali laruin ang STEMI kesa sa non-STEMI. So, ano ang guidelines ng 2020? So, ayan, no, CPR, and then as we go into ACLS, ito po yung, hindi lang nakita yung instructor na puti po yan, nurse from California. So, ginawa po ako, ito, ito si Tessa, may isa pa, isang doktor. Tatlo kami ang sinecertify for instructor ng ACLS directly under American Heart. So many years ago. So makikita niyo ayan. Although nakapato si nurse, merong airway, ganda ng mga gamit lang. Ito namang nasa paligid, ito yung mga tinitrain na namin ng ACLS. Pero sila, ACLS lang, parang sila yung student namin on how we will conduct the narrative or the curriculum. So, tinuturuan kami paano siya i-deliver. Sayang yung school na yun, wala na. Namatay na yung may-ari. So, let's go now into and then ang emphasis sa endotracheal tube plus capnometry. So, saka ko na i-discuss tong capnometry. Pagdating ko sa airway, may capnometry. Saka ko na i-discuss. Anong ibig sabihin yan? So, ayan si capnometer. Yung pinakita ko sa inyo, yan, yellow. Okay, yellow yan. Ang itong sa akin, blue. Pero mas cheaper brand to. Cheaper brand itong blue. Yung yellow na yan, 90,000 yan. Nasira sa akin. Ngayon, dahil ginagamitan natin ng tamper, mechanical CPR devices, according to 2022 interim guidelines, para hindi lang darating araw, papalitan na ng AI, artificial intelligence, ito pa lang, para hindi mapagod ng tao, meron siyang tamper, uninterrupted chest compression. Tama yung rate and depth and are not limited by human performance variability. So, depende. Kung medyo hindi ka matangkad, mahirapan ka mag-CPR. Or pag babae ka sa long range, mas mahirapan kaysa sa counterpart na muscular na lalaki. Kaya pag nilagay mo sa tamper, ito yung kanilang emphasis. So ito yung mga sample ng tampers. Yan. Ito yung sa Lucas. Ito yung Autopulse. Kalimutan ko anong brand nito. So, maraming naggumagawa niya ngayon. No? Di ko na siya, di ko na yan siya. So, may taga-compress na sa dibdib. Yan. Alam ko, karamihan sa inyo, hindi pa gumagamit ng ganyan. Then isa pang panibago ngayon pero hindi pa halos sumikat sa pre-hospital care is the extracorporeal membrane oxygenation. So ang trabaho nito, binabypass niya, ino-oxygen sa machine para ibalik sa katawan, kaya ang heart ay binaypass niya. Kasi yung heart, in question siya, kunwari merong tama. So binabypass while they're correcting the heart. So, pang in-hospital, pero nakakita na ako, ginagamit siya sa pre-hospital care. Katulad dito, nangyari sa, I think this is in Paris, nag-ECMO sila dito sa field. Galing, no? Nag-ECMO sa field, sa subway. So, yan ang ECMO, yan yung machine. At ito ay ginagamit na. Meron ding artificial blood, lalo na sa trauma, sa blood loss, yung erythromer, na meron siyang capability in carrying oxygen. Kasi ang kaya ng oxygen ay yung transfused whole blood, no? Or blood products, or PAC RBC. Ngayon, in the absence of that, ang maganda nito, hindi katulad sa mga blood, may hangganan, nabubulok yung blood. Ito, powder lang siya. Pag ihalo mo, itong calusite, pag ihalo mo, sa diluent niya, magiging parang blood siya. Ito kay nagagamit na. Ang brand name is calusite, or it's an erythromer, dried bio-inspired artificial red blood cells to treat life-threatening blood loss. Ang maganda dito, hindi siya basta-basta nasisira kasi powders. So ayan ha, meron na tayong erythromer at saka yung sidrone. So hindi ko babasahin na yan ha, yung mga artificial blood as erythromer. So benefits of powdered synthetic blood, ayan, sa combat medicine, ayan siya. So yun lang yung mga main advances ng ACLS, yung neuropeptide for stroke. But this is where we want to emphasize an understanding kung bakit may ACLS, because of the reversible HSPs. Halimbawa, hypovolemia, manifested by rapid heart rate, narrow QRS complex, o the fluid resuscitation, kung hypovolemia, because of loss of blood products, o the blood transfusion. Pag hypoxia, airway management. Pag hydrogen ion, pwede tayong gumamit ng, dati luma is sodium bicarb, pero according to, airway management lang, good oxygenation para ma-reverse natin yung airway management, okay, and oxygen para ma-reverse natin yung acidosis. Hypoglycemia naman, bigay tayo ng D50-50 or ambidextrose. Pag hypokalemia, we can give magnesium or kalium-durol. Hyperkalemia, medyo maraming gamot dito. Calcium gluconate or calcium chloride. So dito medyo daming mga gamot kayo employ. Sodium bicarb, insulin glucose, hemodialysis, keto, thiacellate. And then hypothermia is, ang tuturo ko lang is passive external rewarming. Tension pneumothorax, i-demo ko lang paano tayo mag-chest compression, cardiac tamponade, idudamit ko rin paano mag-intervene. Toxins, depende sa available na antivenom or antidote. Thrombosis, fibrinolytics, embolectomy. Kapag thrombosis coronary, fibrinolytics saka PCI. So we'll start with hypoxia. So ang objective natin ay kailangan mataas ang FiO2. So initially magbibigay tayo ng NRM kapag mababa, NRM non-return mass at 15 liters per minute, no? Talagang mababa and impending disaster like cardiac arrest. Pulmonary arrest. Hypovolemia, so depende sa fluid, Blood for blood, interstitial loss, kailangan gamitan natin ng NSS. Yan. So, depende. Hydrogen ion, ginagamitan natin ng array, no? Pero yung iba, gumagamit ng sodium bicarb. So, depende yun sa Now, these are all slides. Okay, wala na to. There na to. Okay, guys. Now, I will go into ECG kasi mas importante ECG kasi pambungad lang yun eh. So, dito sa ECG, yung mga pathological ECG lang, ang ituturo ko, kasi di naman kayo maging cardiologist, unless mayroong cardiologist nakikinig sa akin dito, tulungan nyo na lang ako. So let's start natin ECG. Luma na itong slide ko pero hindi naman nagluluma pagbasa ng ECG. Nagbabago yung machine pero yung style niya. Okay. So we will know ECG, but we will first look at the heart. By the way, any questions sa ano kanina? Okay, the heart is an organ of 3 features. Mechanical organ, muscle siya. No? Na-load na ba? Hindi pa. Na-upload? Hindi pa pala na-upload. Sorry. Okay, okay. Ayan na po. So, si heart ay mechanical organ kasi muscle. Tapos, chemical organ kasi nagre-react sa mga chemicals, nagre-react sa epinephrine or adrenaline. And dito sa konteksto natin, upang sa gayon ay makita natin kung kumusta si heart, ay doon sa kanyang electrical feature na makikita sa ECG. So, siya ay merong conductor. Siya ay merong generator. Tinatawag natin na sinoatrial node. Magpa-fire. Pag-fire niya, tatawid siya. Kita niyo yung cursor, tatawid. Wala lang kasi hindi niyo nakita tulay dito. Tatlo to. Ang tawag internodal tracts. Tatlo. Papangalanan ko makinig kayo, baka lumabas sa exam. May internodal tracts. In between SA node and AB node, may internodal tracts. Ang tawag nun, internodal tract of Bachmann. Pangalawa, internodal tract of Torel. Tapos internodal tract of Wenckebach. Bachmann, Torel, and Wenckebach. Tapos meron pa siyang isang wire papunta doon sa left. Para pag nag-fire si SA node, hindi lang nag-contract si right atrium, nag-contract din si left atrium. Yan. Tapos tatawid sa internodal tracts, ang kanyang normal speed ay 0.12 to 0.20 of a second. Hindi 1 second, less than 0.12 to 0.20 of a second. Grabe kabilis. To allow filling of blood, para mapuno ng blood, si ventricle. Yan. Allows filling. Pag-fire niya, boom! Sunod, blub, para pag bug na may papasok na blood, pump ulit siya. Pagdating kay AV node, bundle of sa 4kg system, magpapump si ventricles left and right. Ngayon, tatanggalin ko si SA node, sisipa siya ng 60 to 100. Alam mo si heart, pag tanggalin ko yan sa dibdib nyo, magbibit yan. Hanggang maubos na siya, hanggang wala na. Okay, ganun po. Hindi katulad itong muscle ko, itong flexor. Tanggalin ko to, wala lang siya. Hindi siya nagko-contract. Bakit? Si cardiac cells kasi meron siyang katangian na self-excited, cardiac muscle, self-excitatory mechanics. So lalo na si SA node, may rate na 60 to 100. Si AB node is 40 to 60, katulad ni bundle of his, 40 to 60. Tapos si 4kg system, 20 to 40. Assuming si 4kg system na lang naiwan sa'yo, mabubuhay ka sa 20 to 40 kasi hindi siya hinto sa 20 to 40. Ina-accelerate niya yan. Kaya pag nakita kayo ng mga wide ventricular contractions, wide QRS, wala nang ibang pinanggaling heart rate. Ventricular contraction lang yan. Baka si Purkinje fibers na lang gumagana. Lalong bumilis, kunwari nasa 70, pero hindi niya normal 70, ang tawag sa kanya is accelerated beat. Ngayon, ano ang pwedeng makita ng ECG? Makakita siya ng heart rate, regular versus irregular rhythm, time interval, tapos abnormal conduction pathways. Sa ibang mga mata, pwede niyang makita ang hypertrophy. Pero hindi ko in-encourage sa lecture ko ngayon. So lalo na sa mga sanay na clinical eye, pwede sila makita hypertrophy. So your ECG is simply a machine that gives us the graphic representation of the electrical activity of the heart. So hindi katulad ngayon sa inyo na naka-digitalize na lahat. Sa amin noon, as in single strip lang yan, mano-mano. No, mano-mano kami. Hinto. Lalo na pag single lead lang, hinto, pause, tapos gumagano lang, tanggalin ko, tapos lipat sa next, tapos run ulit. Tapos stop, mga naka-4 na beat na ako, stop, standby lang, nakaganon siya, tanggalin ko ulit yung nagsasak na ball na merong contact. So nililipat ko doon sa V-leads or sa chest leads. Ngayon, wala, latag lang lahat, and then the machine will just run it for you up to the point na gumagawa na kasi ng interpretation. Okay guys, dito, titingnan natin. Dito tayo medyo mabubugog kasi ito yung basics ng ECG. So pansinin natin, merong squares. Okay? So allow me to use the word big square ito. Big square. Yeah, big square. Sa loob ng big square, merong small squares ito siya. So let me use the word small squares or small boxes. Baka magkamali ko, sasabihin ko big box, kapareho lang sa big square. Pag sinabi kong small box, ibig sabihin small square. Horizontally, itong big box or big square ay merong 0.20 of a second run travel. Kasi kailangan ng ECG tumatakbos eh. So dadaanan ng stylus ang isang big square within 0.20 of a second. So ganyan ang calibration ng ECG. Ngayon, dito ako sa small square. Pansinin niyo itong small squares. Merong 5. So itong 5 na to, kailangan meron siyang 0.04 of a second. Kasi ito po itong horizontal na to by segundo. Ang pataas po, ang mini-measure niyan is the electrical output in millimeters. In voltage, sorry. Pwede ring mm. So dito tayo sa horizontal, which is measured in seconds. So ang big square is 0.20 of a second. Para maabot ko yung 1 segundo na pitik, kailangan meron akong 5 big square. So bawat 1 segundo, ang dinaanan ng ECG ay 5 big square. Intindihan? Parang hirap na narapan kayo. Tumatakbo, isipin nyo ito, yung strip na yung tumatakbo. Yung big square na yan, ang kinakain lang niya is 0.20 of a second. Para makaabot ako ng 1 second, kailangan may 5 big square ako horizontally. So 0.20 times 5 is 1. So 1 second. So dahil focus lang tayo sa 1 big square, 0.20 of a second. Doon pa tayo sa small squares, 0.04 of a second. 0.04 times 5 is 0.20. So huwag mo nang bilangin na 25 small squares yan sa isang big square. Saka na yan. I'm not interested in 25. I'm interested, ano yung pulse on the first 0.20 to 0.40, mga ganun. So ano yung magiging run ng ECG. Ngayon, titingin tayo dito sa ECG display. Okay. Okay, dito na ako sa left. Ito yung tinatawag na baseline. Itong guhit na to, baseline niya na. Yan, yan, yung linya na yan. So, dyan tayo kumukuha saan nagte-take off ang waveform. So, ito pag contract ni atria, na-create si P. Nag-contract si atria kasi hindi naman gano'ng kalaki si atria, nag-create si P. Pag-create ni P, magkaroon ulit siya ng baseline. Ang tawag ng baseline na yan is segment. Okay, segment. One waveform plus one segment is called an interval. So, bakit PR? Okay, PR intervals. Okay, next muna. Yan. Then another waveform, papaba. Biglang may tumaas, sobrang taas at papaba ulit. Balik ulit sa baseline. Yung Q na yan, sa real ECG, hindi mo yan makikita. Pero sa academics, kunwari may Q. Yung R, masyadong mataas kasi ventricle na yan, masyadong muscular. So yung influence niya mas matindi. Then balik sa S. And then another elevation is called the T, or the repolarization of the heart. Wala sa activity. Now let's go into analyzing it. P wave plus the segment is called an interval. May sukat lang siya. Ang sukat niya is 0.12 to 0.20. How many small squares? Around 3 to 5.
So 5 square.
3 to, 3, 1, 2, 3. So 3 times 0.4 is 0.12. Tapos 5 times 0.04 is 20. So 12 to 20 of a second. Yan. Pag lumampas ka dyan, kung lumampas ka sa 20, magkakaroon ka ng first degree heart block. Now let's go into QRS. Si QRS, dapat tatlong small squares lang. So dapat hindi siya lalampas ng 0.12. Saan ka kumuha ng 0.12? Di ba sabi ko sa inyo, ang small square ay 0.04. Tatlong 0.04 is 0.12. Okay, so dyan lang muna ako, huwag na natin pakilaman si P. So, P wave plus P waveform plus segment is called an interval. Combination of one waveform Q, waveform R, waveform S is called complex or QRS complex. So yan lang ha. Next slide. P wave. So si SA node, nag-fire siya. Nag-fire si SA node. So ayan. Merong electrical impulse which is called the P. Then, pag-fire ang blood in a slow motion, pumunta sa ventricle, ang kanyang travel time starts from 0.12 to 0.20 of a second. Ang tawag dyan is PR interval. Then, merong Q wave R sa S, ang tawag QRS complex, na dapat hindi lalabas sa 3 small square. Pag lumabas sa 3 small square, ang tawag sa kanya is wide QRS. Pag within the 3 small square is minimum, yun yung normal QRS complex or the narrow QRS. So wide QRS versus narrow QRS. And then we have the depolarization, the T wave, which is the repolarization. Wala siyang associated activity. So let's start. Sa heart rate, kuha ka lang ng 6 second lead. Paano ka makakuha ng 6 second lead? Hanap ka ng marker, road marker, tingnan niyo aking cursor.
Yan nga, oo.
Cursor ko, broad mark. Tapos ito, mga hindi broad mark, another broad mark. Another hindi, tapos ito kasi hindi makita dito sa dulo. Kunwari mo may another mark. So ngayon, itong mark na to is the 3 second. May another mark doon 6 second. So broader mark is a 3 second gap. Interval. Pero dodoblehin natin para mag 6 second. Titingnan natin yung ECG dumaan dyan, bibilangin lang natin yung R. Divided by 10. One, 2, 3, 4, 5, 6, 7, 8. So 8 times 10 is 80. Ganun lang tayo. Hindi na tayo magdi-division method. So dito, ilan ang heart rate? Okay, so 6 second. Ayan si broad mark. Broad mark, 3 seconds. Broad mark, 6 seconds. Bilangin ko 1, 2, 3, 4, 5, 6, 7, 8. So 100 beats per minute siya. Ganyan lang ha. Then we go into the rhythm. When we go into the rhythm, dalawa lang yan. It's the regular rhythm and the irregular rhythm. And then the irregular rhythm. At saka yung regularly irregular rhythm. So doon muna tayo sa regular or irregular. So parang ito, heart rate siya. Ano ang rate? Kunwari 100. Pag sinabi mong regular rhythm, titingnan mo lang itong dulo na to. Itong dulo ng R plus another dulo ng R, i-measure mo kung pareho sila equidistant. Pag equidistant sila, tawag doon regular rhythm. Regular rhythm, sorry. Pero lumayo itong isa konti, tapos balik na naman sa normal. Lumayo yung isa konti, ang tawag niya irregular rhythm. Balik tayo sa P-wave. Yung ECG mo may P-wave? Or sobrang dami ng P-wave? Or P-waves occurring regularly? Or yung P-waves are smooth, rounded, and upright in appearance? No? So titingnan natin. Now we go into PRI. Kapag yung P-wave plus yung segment, which is PR interval, lumampas sa 5 small squares, ang tawag doon first degree heart block. So PRI, tinitingnan din natin. No? QRS complex should be within 0.12 of a second. Pag lumampas dyan, ang tawag white complex. O, tingin dito, anong rhythm to? Walang sumasagot? O ano yan? Ang tawag ko dyan, artifact. Ibig sabihin, merong ground yung ECG mo. Mapapansin mo, regular pa rin yung QRS niya. Except ito kasi ano to eh. Supposedly, repolarization yan. Ang common cause, nagkikilos ang pasyente, loose or defective electrodes, improper grounding. Katulad sa amin, pag nag-ECG kami nung lumang panahon, kinakabit pa namin sa bakal na bitana yung ground ng ECG para wala siyang artifact. So pag sinabing bradycardia, dapat 60 beats per minute below. Pag tachycardia, more than 100 to 150. Pero pag ang rhythm, pag sa sinus, di sinus node siya, merong SA node. So ang tawag sa kanya is normal sinus rhythm. Kailangan mention mo. Kasi nasa sinus galing ang kanyang stimulator. Pero pag hindi nasa sinus, sa atrial na, so that's another story. So hindi na siya sa SA node but somewhere along the walls of atria. Pag ventricular na, wala na ang atria. Wala na lahat. Sa ventricle na nagsisimula ang stimuli. There are 4 normal sinus rhythms. The 4 sinus rhythm. Normal sinus rhythm, sinus arrhythmia, sinus bradycardia, sinus tachycardia. So anong gagawin natin dito? Una, itatanong muna natin, what's the rate? Titingnan natin, 6 second lead. Anong rate niya? 1, 2, 3, 4, 5, 6, 7, 8. Di 80 beats per minute. Okay? Ano ang rhythm? Sa isang tingin pa lang, equidistant ang R wave, so that's a regular rhythm. Is there presence of P wave? Tingnan natin, yes. Sinus. Okay. The QRS is narrow or wide. So makikita sa isang tingin narrow. So it's called the normal sinus rhythm. Hindi ko chinek yung PR interval kasi kitang-kita ko rito. Pero pwede mo rin samahan. Okay, within. Nasa ano siya? Nasa around 3. Nasa around 3. So that's around 0.12 of a second. So normal. Dito tayo sa sinus arrhythmia. Ito pa rin, pero pwedeng lumapit siya, no? Tapos equidistant na lahat, lumapit. So it's not alarming. Ang tawag sa kanya, irregular rhythm, normal sinus rhythm, sinus arrhythmia. Kasi when you check the rate, assuming the rate is 80, the rhythm is, nakikita mo, merong mga parang premature. Pero sakto pa rin. Lahat ng rhythm mo ay narrow complex. Sakto siya. May nauuna lang siya. Or nag-beat na malayo. So both are, basta hindi lang siya frequent. Common among teenagers. So, ito siya. Next is sinus bradycardia. What's the rate? 40. Then, rhythm, equidistant with each other, that's regular rhythm. Presence of P wave, yes, the sinus rhythm. PR interval, okay lang. QRS, okay lang. So the whole of this is sinus pa rin kasi merong P wave. Sinus bradycardia. On the other note, meron pa rin akong P wave, PQRST, PQRST. So that's more than 100. What's the rhythm? Sa isang tingin pa lang, equidistant with each other. So, regular rhythm. PR interval. Okay, tama lang. So, ano siya? Is there like PR interval? Ano pa bang mga next tanong? QRS, narrow. So, it's called a sinus tachycardia. Now, natapos na yun, lukso na tayo sa atrial rhythm. Ito yung rhythm na kung saan ang SA node ay hindi na nakafire. Wala na. Okay guys, 14:30, I'll give you a break. 7 minutes. Alam ko medyo nabigla kayo. Mag-coffee kayo para medyo mag-absorb. Lakad-lakad muna kayo kasi medyo mabigat ang ECG. I'll give you like 7 minutes to drink your coffee. No? Kasi medyo mahirap din talaga ang ECG. Lalo na pag hindi ka sanay. Okay, see you after 7 minutes. Okay, let's go back. So, dito tayo sa atrial rhythm. No? So, wala na si SA noon. Ang pinagkukunan para sa contraction sa heart ay magsisimula na kay ano. Sa anything sa atria, sa walls, internodal tract. So, ang tawag sa kanila ay atrial dysrhythmia. Hindi siya life-threatening. Pero you have to maintain something. Like for example, kung may atrial fibrillation ka, kailangan meron kang pangpalusaw o pangpatunaw sa dugo. No? Pwede ka mag-aspirin, yung makaluma. No? Sorry. Kanina pa ako nagsasalita, wala pala akong, nakamute pala ako. Sorry. Balik ako dito. Let's go now to atrial dysrhythmia. Generally, it's not life-threatening. Bantayan lang natin para hindi tayo magkaroon ng emboli katulad ng atrial fibrillation. There are 3 types of atrial dysrhythmia or atrial rhythm. Atrial flutter, atrial fibrillation, saka SVT or paroxysmal supraventricular tachycardia. So, atrial flutter, tingnan natin sa 6-second lead. 1, 2, 3. So, ilan ang ating rate? 1, 2, 3, 4, 5, 6, 7, 8. 80. Is the rhythm regular? So, the rhythm is equidistant to each other. Beautiful. Is there like a P wave? So, wala na pong P wave. Hindi natin malaman. Pero ito, potential mga P waves yan, no? Wala na akong PR interval. Ang maganda nito, ang QRS narrow. Okay? At itong mga P waves niya, it looks like a sawtooth, ngipin ng lagari. So it's called a sawtooth appearance. It is very typical of a flutter. With this, ang tawag nito 3:1, merong 4 which is 4:1. So is the patient okay? Is the patient in emergency? So hindi po. Meron na siyang konting maintenance. Kung gusto niyo bigyan ng clopy, di fine. So yan ha. Yan si flutter. Then we go into fibrillation. 6-second lead ulit. 1, 2, 3, 4, 5, 6, 7, 8, 9. That's 90. The rhythm. Can somebody tell me the rhythm? Paki-chat. Anong klaseng rhythm to? Ito, magtatanong na ako. Kasi baka nagsasalita ako, natutulog na kayo dyan sa kabila. Anong rhythm? Pasulat naman. Rhythm, what's the rhythm? What?
Regular.
Oh, sino pa may... Allah. Irregular lang.
Irregular.
Oh, okay. Ano pa? May ibang sagot pa ba?
Normal po yung yung QRS po niya.
Okay, narrow. Hindi tayo magsabing normal ha. Sabihin lang natin narrow QRS. Okay, sige.
Normal wave.
May nagsagot. Okay, sige. Sagutin ko na. Walang nakakuha ng sagot. Ang tawag sa rhythm na yan ay irregular rhythm. So, ang nakakapagbigay lang ay si atrial fibrillation. Irregularly na irregular. Bakit? Tingnan nyo. Kati kasi ng mata ko, guys. Inis ako. Tingnan yung distansya dito. Maiksi, biglang mahaba, sobrang haba, mahaba, sobrang mahaba, mahaba, medyo mahaba, mahaba. May hindi mo alam anong pattern. Kaya ang tawag sa kanya irregular rhythm. Okay? Asan ang P-wave? Hindi mo na alam kung nasaan. Ang dami nagpapad galing sa wall, sa internodal tract. We don't know where. Siyempre, walang PR interval. QRS is narrow. Again, the patient will still okay except na kailangan magkaroon siya ng maintenance na pwedeng clopy or aspirin. Kung makaluma, di aspirin. Then we have SBT. This is quite a dangerous rhythm kasi pag pinabayaan mo yan, mapapagod si heart. Parang pagmamahal. Pag naaabuso, no? So Q rate is no less than 150. So from 150 to 250, yan siya. Equidistant to each other, so rhythm is regular. Is there P wave? Wala na. QRS narrow. Sirit-sirit itong kailangan natin pabagalin yan. Kasi pag hindi natin pabagalin yan, magkakaproblema tayo. Therefore, what do we do? So, usually pag nakakita tayo ng ganitong rhythm, ang ginagawa natin ay kina-carotid massage. Pero bago mag-carotid massage, pinapakinggan sa stethoscope. Yung stethoscope natin, kung tama yung stethoscope. Tingnan nyo ha. The old school is itong step, ginagamitan ng bell. Yung bell, ipaparinig natin dito. Ang maririnig mo, mabilis lang, ganun. Pero pag may marinig ka, pag lipat ko sa kabila, ganun siya, tapos dito magkaiba, yung merong singaw, yung parang may singaw siyang ganun, no? Hindi ko lang mabilisan eh. Pwedeng mag-suspect kayo na meron siyang aneurysm. Huwag niyong i-massage kasi pag sumabog yan, Diyos mio, mahirap yan. Maganda kung may ultrasound. Bukas, may sarili kasi akong ultrasound eh. Portable. So, dalhin ko. Kunwari, gamitin natin sa phone. Ngayon, pag pinakinggan mo, kunwari, clear lahat, tapos minassage mo, makikita mo babagal yan. That is diagnostic na ang pasyente ay mayroong atrial tachycardia or supraventricular tachycardia. Yan ang magandang binibigyan ng adenosine. Kung wala kang adenosine, pwede natin bigyan ng calcium channel blocker. No? So maganda yan. Ito, may na-treat ako pasyente, although namatay na siya ngayon, pero sa ibang dahilan. Lagi akong sinusundan ng SBT. Suki ako ng SBT. Mga pasyente ko, SBT, marami kong naging SBT na na-reverse ko hanggang cardioversion. So yan. Now, let's go into ventricular rhythm. So wala na si SA node, wala na rin doon sa junctional AV node, doon na siya sa ventricle kumukuha ng pace, no? So it can be PVC, it can be a BTAC monomorphic, it can be a BTAC polymorphic, or another term ng BTAC polymorphic is torsa de pois. Pero bisayain ko, torsades de pointes. Oh, yun, para mas madali. Then we have a ventricular fibrillation, no, VF, and then asystole sa pulseless electrical activity. So I'll start with PVC. Usually, meron kang NSR, pero merong extrasystole ito. So yan, extrasystole ito. Although merong ST segment depression, huwag na natin muna pa siya. Meron siyang extrasystole. Yan, no? So yan yung PVC mo. Pag BTAC naman, quite complex. Okay? Usually it looks like regular rhythm. So more than 150 to 250. So medyo kailangan i-correct natin. Ang pasyente dito may pulso pa yan. Almost regular rhythm, tapos ang forma nila iisa. So monomorphic ventricular tachycardia po ito. Mono is isa, morphic is form. Isang forma. Then, syempre walang PR interval, tapos ang QRS niya is more than 3 na yan. So it's called a wide QRS complex. So kailangan natin i-reverse yan kasi pag magiging pulseless ventricular tachycardia yan. Arresting na yan. Now, torsa de pois, torsades, sige, bisayain ko, torsades de pointes, is a tachycardia, ventricular tachycardia, pero pa iba-iba forma. Okay, tingnan natin dito. Maliit, biglang lumaki, lumiit. Yan. Minsan nakala mo ventricular fibrillation course. Ito yung typical. This is, you can see this with patients having hypomagnesemia, mababa ang magnesium. Then you have the ventricular fibrillation, dalawang klase. Ito, pag nag-ventricular fibrillation ka, baksak na yung pasyente dito. So ito yung fine, ito yung coarse. nag-fibrillate na yung heart, wala na, hindi na nakasipa ng bagsak. And then we have the asystole. Pero itong asystole, very funny. Sa totoong buhay po, hindi ka po makita ng asystole ganyan. Parang tinanggal mo lang yung lead. Pero siguro para sa presentation, makagawa ng asystole, ginawa na lang ganyan. No? Hindi siguro nakahanap ng asystole na kaso. Pero sa asystole, mayroon pa talagang konting-konti, pero flatline siya may konti. Siguro mamaya makakita tayo ng isang totoong asystole. So ito ay natanggal na lead. Kasi pag tinanggal mo yung lead, flatline lang yan, hindi yan mag-erratic. Ang nag-erratic na artifact, ang tawag doon artifact, ay yung mga sira na mga leads. Ito. Pero guys, remember, pag sa lead, sa cardiac monitor nyo nakita kayo ng flatline at lead number 2, pindutin nyo yung lead, LEAD, nakapindot. Pag pindot nyo, lilipat sa lead number 3, flatline pa rin. Pag pindot nyo, naka-paddle sign, flatline pa rin. Kung wala. Pag pindot nyo, babalik sa 1 flatline. Balik kayo sa 2 flatline. Saka kayo magsabi, patient is having asystole, start CPR. Pero mabilis yan 3, paddle sign, 1, 2, puro flatline lahat yun, start CPR. Huwag kayo mag-start ng na nanood lang kayo sa isang flatline, baka sira yung isang linya doon. So you have to ascertain na talagang asystole yan. Pulseless electrical activity ay any heartbeat. Usually, para siyang third-degree heart block. Pero walang pulso. Pero nakakita kami electrical activity. Kaya tawag sa kanya is pulseless electrical activity. Merong electrical activity na pero wala ka makuha ang pulso. So arresting pa rin siya. You have to treat it like asystole. Now let's go into heart block. There are 4 kinds of heart block. First degree, second degree type 1, Mobitz 1, at saka second degree Mobitz 2. And then the complete heart block. So si first degree heart block, tingnan ulit natin. Sa 6-second lead, makikita mo broad mark, broad mark, broad mark. Bibilangin ko ang rate 1, 2, 3, 4, 5, 6, 7. That's 70. The rate type is what? So isang tingin pa lang, alam ko regular. Yeah. Is there P wave? Yes. QRS narrow. PR interval, lampas ng 5. 1, 2, 3, 4, 5, 6, 7. So lampas ng 5. So 7 siya. Kasi di ba ang normal na PR interval is 3 to 5 small squares. Therefore, ladies and gentlemen, this is the first degree heart block. Is the patient in serious condition? No. No problema. He can still play football. Then let's go into second degree AV block. Tingnan natin. Dito kasi tayo makakita ng regularly, irregular rhythm. Kasi kanina, irregularly, irregular. Dito, regularly, irregular. Bakit? 1, 2, sa 3 seconds lead, 6 second lead, 1, 2, 3, 4, 5, 6, 60. Rhythm, tingnan mo, equidistant. Pagdating dito, humaba. Equidistant, pagdating dito, humaba. Humaba siya. Equidistant, pagdating dito, humaba. Equidistant, pagdating humaba. Oh, bakit kaya? Kaya ang tawag niyan, regularly, irregular. So, tingnan natin ngayon si P-wave. P-wave, uy, meron. P-wave, uy, meron. P-wave, uy, meron. P-wave, pero walang QRS. P-wave, 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 walang QRS. Tingnan ko ulit si QRS, narrow, okay. Tingnan ko si PR interval. Tingnan ko nito. Oops, normal. Pagdating nito, humaba. Pagdating nito, sobrang haba. Pagdating nito, wala. Yan. So the explanation is a rhythm which has a gradual lengthening of your PR interval until there is a concomitant atrial contraction without ventricular response or a drop. Okay? No? So merong QRS na hindi conducted. Okay? So yan po si first degree. Sa second degree type 2. Ang patient okay dito? Yes, ladies and gentlemen, okay. Let's go into second degree AV block. Type 1 pa rin. Tingnan nyo ha. Ala, biglang mahaba, biglang mahaba, biglang mahaba. Ito naman, PR interval, okay. PR interval, humaba. P, wala, drop. PR, dito, medyo humaba siya. P, drop. Yan. kanina, ang tawag dito is 3, 1, 2, 3:1. Wala. Dito naman, 2:1. 1, 2:1. 1, 2:1. Okay? Dito tayo sa ibaba. Oh, ito mas maganda. Equidistant siya, except na humaba dito. Paano nangyari yan? PQRST, 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 P-NaN. So ito ay 4:1. Again, the patient, wala siyang problema dito. Bantayan lang natin, i-monitor, wag lang mag-progress na ibang klaseng heart block. Okay? The story here is the gradual lengthening of your PR interval until it reaches a contraction of atria with no response from the ventricle. Yan. Sundan pa ha, sundan. Then let's go into the third degree heart block. The third degree heart block, second degree type 2. The second degree type 2 is not so good. Bakit? Meron akong P, equidistant si P, okay. Equidistant si P walang QRS, P merong QRS, P merong QRS, P merong QRS, P wala. So delikado po 'yan kasi kailan lang trip magkaroon ng QRS, doon lang nagpa-fire, grabe memory. Doon lang nagko-contract si ventricle, QRS. Hindi naman pwedeng ganon. So delikado 'yan. Itong mga ganitong pasyente pinipace na po. Kasi candidate na 'yan. Okay? But not all second degree type 2 pinipace kasi merong mga P meron, P wala, P meron, P wala. Ino-observe lang yun siya. Minsan, tinitingnan natin kung uubra siya sa chemical intervention. P meron, P wala, P meron, P wala, P meron. Yan, no? Then the third degree, automatic, pinipaste natin. Bakit? Tingnan nyo si P, ito si P nandito, si P, hala. Si P, kanya-kanya, si QRS, kanya-kanya rin. Parang bansang Pilipinas, hindi nagkaisa. Merong pro-China, merong anti-China. Very unlucky country. Very poor country because hindi nagkaisa ang Pilipino. Magkaiba ang utak. I don't know why. No amount of how many presidents, hindi talaga tayo pwede magkaisa. Simula ng Espanyol, may kakampi sa Espanyol. May kakalaban sa Espanyol. May kakampi sa Amerikano, may kakalaban sa Amerikano. May kakampi sa Hapon, may kakalaban sa Hapon. Ngayon, may kakampi ang China, may aaway sa China. Kailan kaya magkaisa ang bansang Pilipinas? Therefore, the Philippines is suffering from a complete heart block. Nagkanya-kanya ang mga taong bayan. Iyan yung nasa picture nyo ngayon. Okay, ayan pa. Oh. Si P nandito sa loob ng QRS. P, ayan o. P, QRS, kanya rin. Kanya-kanya sila. Kailangan very keen ka lang tingnan. Kasi medyo nakakalito to. Ito rin. O, ito yung maganda. O. Si P, kitang-kita si P ha. Tingnan yung cursor ko. Si P na nasa QRS. P nasa QRS. P, ayan. Si QRS, wide QRS, ayan. Kanya-kanya siya. And then, pag nakakita kayo ng rhythm na ganito, merong guhit, meron po siyang transcutaneous phase. Meron siyang implant phase. Okay, naka-implant sa kanyang phase. Okay? So, tingnan natin to. In the absence of P wave, walang P wave, irregular return, tapos merong PBC, atrial fibrillation with PBC. Ito, NSR, madali lang, no? Ito, bradycardia. Isang tingin lang. I don't think this is ventricular fibrillation. I don't think so. This is a bridge towards ventricular fibrillation. Parang ano pa lang to? Parang taki. Taki na papuntang ventricular fibrillation. Ito, third degree heart block, yes. Yan ang asystole, guys. Yan ang totoong asystole. Tingnan niyo. That is the real asystole. Yan sinasabi ko. Okay? So ngayon, magbibigay ako ng exam at sasagutin niyo lang sa chat. Doon po kayo i-grade sa chat kung papasa o hindi. Meron po tayong magmo-monitor. Mag-participate kayo. Sana masagot niyo within 10 seconds para yun yung pagbabasihan na okay kayo sa ECG. Okay, ready? Walang tanong, no? Sa chat ang sagot para ma-monitor ang name sa chat. Okay, number 1. Answer, number 1. 1,000, 2,000. 10 seconds, sagot. Sige, gawin ko na lang 15 seconds. Naawa naman ako. Anong klaseng AB block, Sherilyn? Kompletohin na to. First ba? Second? Third? Pag sumagot, kompleto ha. Second degree. Sa second degree po, Norhaya, dalawang klase po. Type 1, type 2. Okay, cut. O konti lang sumagot. Hindi ko alam anong nangyari sa iba. Okay, sige. Tingnan natin. Anong sagot? Okay. So, ngayon, ang sagot, ang tamang sagot po ay walang nakakuha sa inyo. Okay. So, ang tamang sagot dyan ay second degree type 2. PQRST, P wala. PQRST, P wala. Oh, yun, kaka-example ko lang kanina. Okay, yan. Sige. Next. Next. Oh, ito. Kadali lang yan. Okay, stop. Yung walang mag-participate, sablay kayo sa ECG, nasa inyo rin yun. Okay, the answer is third degree heart block or AB block. Very good. Marami medyo nakasagot. Next. Ayun, madali lang yun. Nadadaan sa isang tingin. Walang nakasagot ni isa. 10,000, 11,000, 12,000, 13,000, 14,000, 15,000. Okay, cut. Oh, marami rin sumagot ah. Wow. Good. Okay, sige. Minomonitor ni WIPAM. Very good. Atrial fibrillation. Galing. Next. 7. $11,000, $12,000, $13,000, $15,000. Okay, cut. Hindi ko alam kung RSR, rapid. NSR siguro yan, si Marie. Okay, ito po ay 2, 3, 4, 5, 6, 7. NSR. Tama, NSR. Next slide. Ito. 2 points. 2 points pag nakakuha dyan. Panoring mabuti. Medyo kakaiba yan. 11,000, 12,000, 13,000, 14,000, 15. Okay, luck. The right answer is artifact. Very good. 2 points. Artifact yan, hindi yan torsan. Kita niyo, may equidistant na dulo. Oh. So, sira yung ECG dyan. Very good. 2 points. Next slide. Ito, bonus yan. 3,000, 4,000, 5,000, 6,000. Okay. Clock. Close. Close, close, close. Yan ay atrial flutter. Next. 14. $10,000, 11,000, 12,000, 13,000, 14,000, 15,000. Okay, close. Okay. Ang pacemaker ay hindi FP happy. Okay, sige. Pacemaker, basta may pacemaker. Sige, ano ko na lang. Okay, pacemaker, pacer. Next. 17, ano yan? 1,000, 2,000, 3,000, 4,000, 5,000, 7,000, 8,000, 9,000, 10,000. Walang nakasagot. Okay, close. Sorry, walang nakasagot. It's not BTAC. Paano naging BTAC yan? That is third degree AB block. Yan o. Third degree yan. Sige. Habol, nakahabol. Okay, sige. Close na, close. Next. Wag yan. Yan. Yan, yung totoo. $11,000, 12,000, 13,000, 14,000, 15,000 close. Kompletohin na. Close na. BTAC yan pero polymorphic or torsadipua. Okay. Bahala na si ano. Next. 24. Ano ang 24? Kuha ka agad. May nakuha ka agad. 7,000, 8,000, 9,000, 10,000. Yes, ano yan? Okay, close, close. Yan po ay SBT or PSBT. Next. Wag yan. Naku, madali yan. Mahirap. Oh, yan. Ano yan? Kahit isang sagot lang. Yan. 13,000, 14,000, 15,000. Okay. Okay na, close. Sorry. Okay. PVC po yan. No? Premature ventricular contraction. Next slide. Ano yan? 1, 2. Medyo mahirap yan ha, pero tingnan nyo lang yung pattern. Makukuha nyo rin. Ano naging NSR yan? Ma'am Marie, saan po kayong, are you doctor or what, Ma'am Marie? Nurse, doctor? Kaya pala eh. Ano po specialty niyo? Wow. Very good. Galing. So, kuha po ni Ma'am Marie, 3rd degree AB block po yan. Next. Wag yan. Oh, ito. Dalawang sagot niyan. Ito at saka ito. Ano to? Ito. Tingnan niyo cursor ko ha. Yan, yung guhit na yan. Ito, ano yan, at saka yan. Dalawang sagot. So, it's like 38, 39. 1,000, 2,000, 3,000, 4,000. Pacemaker. Ano yung pacemaker? Okay, 15,000 close. This is ventricular fibrillation. Ito po ay defibrillation. Boom! Biglang, hindi ko alam kung nag-NSR na to or bumalik ulit sa BM. We don't know. So yan po, ventricular fib, force, tapos nag-defibrillate. Sayang. Hindi na ko nga. O ito, 40. $12,000, $13,000, $14,000, $15,000, close. So that's atrial fibrillation, guys. Kita mo pa lang. AFib, okay. Sige, may humabol. Okay lang yung humabol. Huwag yan. Hypervoltage yan. Hypervoltage. Ayoko yan. Okay. Huwag nyo na itong pansinin ha. Tingnan nyo ha. Huwag nyo pansinin yan. Pero kung may nakapansin yan, kung anong tawag yan, it's fine. Ito lang na rhythm na to. Ito lang. Minus yan. Okay, go. 1,000, 2,000, 3,000, 4,000. $13,000, $14,000, $15,000, close. Okay, iba po yung ano, parang, sige. Iba po yung junctional. Ito kasi, kung makikita mo, irregular yan. Masyadong maliit lang. But this is atrial fibrillation. Okay, atrial fibrillation. Ang junctional rhythm, pareho lang siya. Wala siyang P-wave. Junctional tapos narrow QRS. Okay. Yan. Masyadong pangit. ST elevation. O sige ito, bonus. Ano yan? $12,000, $13,000, $14,000, $15,000. Close. Okay, close na. So, sinus, bradycardia. Okay, next. Ito. Ito. Okay, kitang-kita. 48. 1,000, 2,000, 3,000, 4,000. Okay, close. Grabe, hindi yan bitak. Bakit bitak ng bitak kayo? Hindi yan bitak. Ano naging bitak yan? Okay. This is a second degree type 1. Tingnan nyo. PQRST. Lumayo si P, malayo na. Merong P, walang QRS. PQRST, lumayo si PQRST, P, dito walang QRS. Therefore, it's a second degree type 1. Sayang, magandang written. Ito. $11,000, $12,000, $13,000, $14,000, $15,000. Close. Very good. Third degree AV block. Galing, galing. Ito. Last slide. Okay, may humabol. Sige. Last slide. 1,000, 2,000. Yan lang ha. $10,000, $11,000, $12,000, $13,000, $14,000, $15,000. Okay. Close. Well, close, 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 close. Sa 6-second lead, hindi emphasis ang 6-second lead. Pero kita natin, sinus brady. But there is another thing. Tinagot yung sinus brady, I'll give you a point. Pero 2 points to. This is a first degree AV block. Tingnan nyo, malayo si P. PR interval masyadong mahaba. Yan. So, 2 points supposedly. Anyway, bahala na si Ma'am Joy. Mag-check sa sagot nyo. Now, we will go to another lecture which is IV muna tayo. Fluid. Hindi lahat sa fluid ano ko kasi hindi naman standard lecture ng ACLS to. Pero gusto ko lang daanan para may idea lang tayo, no, on what to do. Bakit nagbigay tayo ng, lalo na sa blood, why it's so required. So my next lecture is fluid para bukas, pag medyo may ilang natapos tayo, bukas hindi na karamihan demo na lang tayo. Okay. Share. Oh, ba't wala? Ayaw. Share screen. Share. Oh. Yan. Okay. So, welcome to the Fluid and Electrolyte lecture battery. I'm not gonna discuss something about pag nasa medical school years, nasa physio, and partly biochem. Now, we are 2/3 of water, 2/3 made up of water, like Mother Earth. And by ratio and proportion, mas mataas ang newborn kasi development years niya yan. No? Kaya pag nawala ang tubig sa mga bata, sa newborn, mas drama. Pag may 20% loss ka, according to the book, fatal yun. For example, sa katawan ko, which is 5 liters, pag nawalan ako ng 1 liter, medyo grabe na yung physiological drama doon. Mas grabe ang emphasis sa mga infants because grabe sila mag-ano ng tubig. Pangalawa, yung fluid shift in infants, no? Pag meron kang rapid fluid volume deficit, grabe yung drama sa kanila. Because first and foremost, hindi pa mature ang kanilang kidney at kailangan yung tubig like they need much oxygen because of higher metabolic rate dahil nga growing. Sabi nga ni Sigmund Freud, behind the baby daw is a creature which is so wild. What he means actually is everything that's happening inside, wild, like higher metabolic rate, things are running in the brain because it's growing. No? It's experimenting with the noise, the lights being shown in the environment. So inside is there are wild things happening inside the brain. So we have the intracellular fluid compartment, which is dominated by our one of the cation na very dominant is your potassium, no? And we have the extracellular na nahiwa into intravascular, interstitial, saka transcellular. And the cation that is dominant is sodium. Our intravascular component, ang higaan ng blood is plasma, made up of protein para sa oncotic value niya or pressure, no? Para sa absorbing capability niya. And if there's variation there, then the heart is also affected. For example, like if there's so much blood corpuscles, no? So hirap-hirap mag-pump. Magkakaroon ako ng hypertension. Masyadong, let me use the word in layman, masyadong hindi diluted, masyadong thick. And of course, the opposite, no? Then the interstitial, which is a backup fluid reservoir, is the space between the cell and the intravascular intravascular area. So ito yung diyan nagdadaanan lahat. For example, diyan dumadaan yung naghahatid ng sugar, insulin, coming from the islets, beta cells in the islets of Langerhans. Grabe yung memory ko. My golly. You know, when we climbed Mount Everest, much of my brain cells, they died. Na-COVID pa ako, naapektuhan yung brain ko. Grabe. When I had COVID, I was first batch, 2020. Nagkamatayan yung ibang mga colleagues ko na doctor. And sinuwerte naman, buhay ako. Meron pa sigurong plano ako sa mundo. But I accepted that I'm gonna die. I accepted it. Pero nabuhay pa ako. Pero maraming nawala sa akin. Sinira niya lungs ko, sinira niya liver ko, sinira niya brain ko. Minsan nagja-jam yung brain ko. Minsan nagtuturo ako. Pag sunod-sunod, July, grabe, busy ako. July, lukso-lukso. Ang pahinga ko lang, eroplano, taxi, doon tutulog. So magtuturo ako sa Ormoc, salita ko Bisaya. Turo ako sa Bacolod, pinipilit ko magsalita Ilonggo. Sa Bicol, di mag-Bicol. Minsan naghahalo yung Bicol ko sa Ilonggo, nalilito sila. Ano pinagsasabi nito? Probably my brain is dying. I mean, lots of brain cells died. Not only sa high altitude. Kaya nung time na when I was recovering, medyo na mabilis ako nag-recover kasi someone offered hyperbaric. Medyo nawawala yung mga rogue pains ko, mga pain na hindi ko maintindihan. Grabe si COVID. So, nawala naman. Pero tamad lang talaga ako magpa-treat. Hindi ako makasustain sa hyperbaric kasi medyo malayo, manlaluyong. At it affected me so much. Mas na-depress ako na I was used to a life na medyo malakas ako. Kasi siyempre, I'm a high altitude mountain climber. Kailangan malakas yung mga Vmax mo, as in, yung shape mo, yung margin mo mataas. Para pag nasa high altitude kasi, prone ka magkaroon ng hypertension. So doon, normal pa rin ako. Ibig sabihin kasi dito sobrang baba. Yung 90 systolic or 80 systolic ko, normal yun. Kung sa inyo, hypotension. Pero pagdating doon, maabot pa kung 130, 140. Kaya nang umakyat kami ng Everest, we started 56. Nahulog na lang 9 na lang kami. Because of attitude and aptitude and evaluation. Nahulog 9. Kasama doon, malalakas dito sa sea level, pero pagdating sa altitude, nawendang. No? So, ganyan po ang history, brief history. So, the high altitude is not for everyone. Transcellular, yan yung mga nasa in between the joints para meron kang parang shock absorber. Pero pag medyo imbalance din, hindi maganda yung internal milieu niya, mataas ang uric acid mo. Pag malamig na crystallize siya, kaya nananakit yung joints. Ito yung isang, sa West Wincom to, na kung saan tinamaan ng bala ang balikat, tapos nirescue namin sa Basilan. Yan. Now we have some what we call this the movement of particles and water in between what we call this areas, no, partitioned by selectively permeable membrane. So I start with the water potential, which is osmosis. So it's the movement of water doon sa area na medyo low solute concentration at pupunta sa area na high solute concentration. No, ibig sabihin, so dalawang area to, dito may 3 salt, doon sa kabila may 5 salt. Yung 5 tubig na magkabilaan pareho, ang mangyayari na lang, dito magiging 3 tubig na lang, tapos itong 5 magiging 7. Kasi meron siyang mas maraming salt, yung kanyang solute concentration mataas. On the other hand, ang diffusion is the movement of particles from an area of higher concentration to an area of lower concentration, passing through a semi or a permeable membrane to the solute. So ito naman ang tinatawag na solute potential. Kung kanina water potential, ito solute potential. No? Ito yung basics. Basic na hindi kailangan may energy requirement. Passive process lang to, nangyayari sa ating katawan day in, day out. Katulad ng oxygen, ini-inhale nyo ngayon. Pag inhale nyo doon sa alveolus, kusa siyang lilipat doon sa capillaries. Kasi ang capillary ay mababa ang oxygen. So lilipat siya. Ang tawag doon, passive diffusion. Tapos yung carbon dioxide naman, lilipat sa alveolus, sa intraalveolar space. Kasi sa intercapillary, mataas siya, mamigrate siya doon. That's diffusion. Without you thinking about it, and there is no energy expenditure. And the good thing about diffusion and osmosis, they can occur together until they will attain a certain level of, merong equilibrium. Pantay lang. So, walang tulakan. Tama lang. Ang may tulakan na itutulak niya talaga ay yung mga active process na nangangailangan ng active transport. So, isa dito ay sodium-potassium pump. Ladies and gentlemen, yan ang totoong forever. Si sodium and potassium. Pag wala si potassium, wendang si sodium. Pag kulang si sodium, wala sodium, wendang si potassium. Ang totoong nagmamahalan ay hindi yung isinulat ni Shakespeare na si Romeo and Juliet. Ang totoong nagmamahalan na kailangan nila ang isa't isa is si sodium potassium. Yan ang totoong forever. Sa mundo, tatlo lang po ang totoong forever. Tatlo lang. Sodium potassium, the mother's love, and death. Kamatayan. Death will find us all. Yan. Kahit saan ka pupunta, abutin ka talaga. So, yan ha. So, mga nagmamahalan at may minamahal ngayon, hanggat hindi siya si sodium at ikaw si potassium, wala kayong forever. Biro lang. Okay. So, more sodium ions move out of the cell, more water is pulled into the cell. Yan. Ganyan. Then we have the insulin glucose regulation. Pag kumain ka marami, ma-stimulate si pancreas to release insulin. Kasi yung may sasakyan po ang glucose. Porsche, it's either Porsche or Lamborghini or Ferrari. So sasakay siya galing sa intravascular papunta sa cell. Without the Lamborghini or the Ferrari, si sugar nandun lang sa intravascular. Lilipat lang si sugar without Lamborghini and Ferrari kapag nasa state of exercise. Kaya mga doctors nire-require nila. Ito, magaling si ma'am dito, meron tayong endocrinologist. I hope you correct me if I'm wrong dito, mama. So, kailangan niya yun. Saka, sakto rin yung sasakyan. Meron siyang garahe. Ika nga, merong mga receptors na mga kagagarahe siya. Kasi kung hindi rin matanggap receptor, hindi rin may lilipat. May saktong garahe din siya. No? So, ito, pag lumipat si glucose kasama si insulin, may sumasabay din. Sumasabay si potassium. Kaya pag medyo sirit-sirit rin pagbigay mo ng glucose sa insulin, mag-hypokalemia ka rin. No? So, this is how things work. Kaya when you wake up in the morning, no, parang ang dami mo pwedeng pasalamatan with all the wonderful regulations happening inside your body without you thinking. For the last 70 years, minsan hindi mo naisip na, wow, my body is acting so well. Na-maintain yung equilibrium sa loob. No? And thanks to the lungs, thanks to the kidney, thanks to the liver, of course. No? Then, osmolality, okay. Measured by serum and urine, no? Yung lapot. So, it's not, I will not discuss so much on this because this is not part of ACLS. Okay, mga diabetes insipidus, no? Mga symptoms of inappropriate, hindi na. Dito lang ako. So, sa fluid replacement, sa ACLS, sabi ko kanina, yung H na hypovolemia, replace blood with blood. So, ito sa Pilipinas, may problema tayo. Hindi tayo basta nakakuha ng O negative. Hindi ka when I was working sa abroad. Meron kami mga O negative. So, nasa helicopter namin yun. Usually, magbibit-bit ako ng 2 bags. Kasama si succinylcholine para kailangan ko mag-RSI. Kasama yung antivenin kasi may mga, alam mo sa Africa at saka sa Middle East, may mga ahas doon eh. No? Mga ahas na super venomous talaga. Huwag lang ako tamaan ng sidewinder kasi wala talaga akong black mamba. Ang black mamba wala talaga akong antivenin. No? So, yun, pag tinamaan ka, goodbye my teacher ka na kaagad. So, yan, no? Dito wala akong ONEG. Ang ONEG kasi hindi na kailangan ako mag-blood typing eh. Then replace plasma with colloid. Then you have to resusc with colloid. I will discuss why. Tapos replace ECF depletion with saline and rehydrate with dextrose. Kasi tatlo na naman talaga pagkain ng cell eh. The tubig, the glucose, and the oxygen. Para magkaroon ng sa Krebs cycle doon sa mitochondria para mabuhay. So si oxygen, mag-carboxylation siya, mag-attach sa carbon, so magkaroon ng carbon dioxide. Yun yung kanyang byproduct. Si glucose, energy siya, ma-measure sa calorie, energy siya. Si tubig pa rin. Diyan ka magtaka, bakit H2O pumasok, H2O lumabas? Binabalik siya, bakit? Kasi paglabas ng H2O, iba na yung H2O na magiging role niya. Kasama na siya para maglinis ng kailangang ilinis sa katawan. Mapupunta sa ihi na isasama. Unless kung ikaw ay kulang ang inom mo ng tubig, tapos uutos ngayon si vasopressin, lalabas si vasopressin, para meron kang para mag-act sa water, no? Para ako ngayon, parang inuuhaw ako. Kasi nagdadry yung lips ko. Para doon sa distal convoluted tubules, mag-reabsorb ulit. Correct nyo lang ako kung tama ako. Kasi so many years ago pa si Ganong sa Gasigayton eh. Nakalimutan. I met Ganong personally. Yeah, I met him personally. So, wow. So, ma-reabsorb siya. I love physio talaga sa kaana. Love ko. Kahit ako, palpak akong estudyante noon. Kasi ayaw ko naman maging doktor. Gusto ko maging piloto. Gusto ko maging musikero. Gusto na magulang ko doktor. Sablay. Pero sige na lang. Tumutugtog para naman ako ngayon. Pero pang mga special occasion. Pero kung sinuportahan ako na magulang ko ng artist ako, siguro asensado ako kasi hindi nga ako artist, nanalo ang kanta ko, nabigyan ako ng presidential award. Hindi ako I cannot read notes, I just make songs. Environmental songs, tapos nabigyan ako ng Outstanding Artist Award ni Ramos. Kung sinuportahan nila ako, maayos sana, no? Yung doktor, hindi ko naman gusto, napilitan na lang ako. But the rest is history. So, in all things that's happening inside the body, ang objective niya is homeostasis para may optimum work mode mo while you walk on earth. So meron kang equilibrium, physiological equilibrium. Now, what in ACLS kasi baka mag-interface to with ATLS. Dito ko sa hypovolemia nagko-concern. Pag pinakilaman ko yung fluid, isa dyan hypovolemia, tapos isa dyan hyperkalemia, hypokalemia, sa torsad. Kaya ko sinama to kasi makikita natin paano tayo magbigay ng fluid. Okay, so I will not discuss the hypertonic, isotonic, hypotonic. So ang solution available in the market ay tatlo. Water and glucose, yung tinatawag nating mga D5 water, D10, tapos crystalloids, the likes of 0.9 NSS, colloids, the likes of extra, yung ginagamit ko is plasma sterile, sterile, hindi na ako gumagamit ng dextran kasi disgrasyahan ako dalawa. Hindi naman disgrasya. Nagkaroon ako ng anaphylactic shock on 2 cases. Buti nahabol ko ng wala nga akong meron lang ako epi epi 1:1000 saka difen. Wala akong steroid. No? So nahabol. Nadala pa sa ospital Zambales. Nahabol naman. Anaphylactic siya. Then whole blood or blood products. Can be packed RBC, whole blood, platelet aggregates, depende. Ngayon, yung kaninang lecture ko, yung meron na po tayo mga artificial blood na can carry oxygen. It acts like blood, mas mahaba ang lifespan kaysa sa blood. Shelf life. So shortcutting ko yan, no? So whole blood pa rin, O negative ang binibigay. So ngayon, kasi yung mga ambulansya sa Pilipinas, wala pa. May mga ref, nagkakarga talaga ng whole blood. So isipin mo, nagtrabaho ako. So I work, medyo marami pa ako sa DRC, Democratic Republic of Congo, sa border ng sa Khyber Pass ng Pakistan, Afghanistan. Kaya sanay ako sa ganitong trabaho, no? Kaya dito, minsan nagtuturo ako nung nasa serbisyo pa ako, nagtuturo ako ng combat medicine. Hanggang ngayon, kahit wala na, pag nire-request, nagtuturo pa rin ako. Kasi isa sa specialty ko to, yung field med lang ng combat medicine. So dito tayo ngayon, anong mangyayari pag binigay natin itong mga crystalloids, colloids, etc. So tingnan nyo ang cursor ko ha, ito ay loob ng cell. Diba? Sabi ko sa inyo, particularly the muscle cells, dyan po punong-puno ng tubig. 70% ng tubig karamihan nasa muscle cell. Bakit kaya? Siyempre muscle kailangan sa pag-move araw-araw. Tapos meron akong mga 9 liters dito, assuming lang to. Assuming lang. 9 liters of in the interstitial and then 3 liters in the blood. Okay. Ngayon, mag-introduce ako ng 2 liters of blood. Anong mangyari? Di 5 liters of blood, simple mathematics. Walang nangyari. Blood siya eh. Pero ang binigay ko, colloid. Nako, ito ngayon. Ang 3 liters, magiging 5 liters, pero dahil si colloid ay mataas ang protein content niya, i-abs, kukunin niya ang tubig. Galing sa cell at galing sa interstitial. Kaya mag-jack up pa siya into 7. Kaya sabi ko sa inyo, when you resuscitate, kasi bagsak ng BP, 60 palpatory siya, maganda si colloid. Pero magbantay-bantay ka rin. Baka on the side track, na katulad nangyari sa akin, nag-anaphylactic siya. Then I gave 2 liters of saline, very common. Naging 5 liters, pero si saline ang maganda, hindi niya ibibigay lahat sa interstitial. May iwan. So from 3 liters, may 4.5 liters ako, nakakapagtaas yan ng BP. Kaya ngayon, sa response kit ko, sa IV ko, IOIV kit ko, may IOIV kit ko. Meron pa rin ako saline. Although 500 lang dinadala ko kasi siyempre, naalala ko noon guys, so tingnan niyo ang bag ko. So dinadala ko, ganito lang. Kasi meron pa akong response pack na ang laman ay mga gamit ko sa ko, damit or what. Pero ito, medical to lahat. May airway, may, bakit ganito lang, 500cc lang. Kasi mabigat na siya eh. Eh kung kunwari nagpapatrol ka, may bala ka pa, meron ka maraming, kawawa ang medic kasi mabigat ang dala. Kaya ito, puro medical lang, advanced airway, may Hello Kitty pa, Hello Kitty. Advanced airway, meron mga hemostatics, IV fluid, saka may splints. Yan po yung laman nito. Plus Hello Kitty. Favorite ko yung Hello Kitty. Then, pag nagbigay ako ng dextrose, nako si dextrose kasi ano siya, diretso kagad siya sa cells. Kasi nire-rehydrate niya si cell. Okay? So, ganyan lang ang usapan dyan. And then, so shortcutting ko dito sa kukunting ilang electrolytes kapag mayroong kulang o sobra. So, pag meron akong hyponatremia, pag hyponatremia ka, magma-muscle cramps ka. Dito ako sa potassium, which 3.5 to 5.5 milliequivalent per liter. Pag kulang ako, magbigay ako ng mga supplement or magnesium. Samahan ko ng magnesium. Kasi pag hindi, nako, tatamaan si cardiac rhythm ko, pwede rin ako mag-arrest habang pababa ng pababa siya. Ganon din kay hyperkalemia. Si hyperkalemia, maraming mga pwedeng ibigay na gamot. I-emphasize ko mamaya. Usually, makikita mo, tall 10 T waves. No? Nakakita talaga ako ganito, hyper-K. No? Kasi meron siyang, nang tinransfer namin siya, meron siyang, kailangan kasi ma-dialysis, hindi ma-perform siya sa tinransfer namin. Sirit-sirit yung kanyang kaya kitang-kita ko yung T-wave sa monitor ko. ECG. So, magbigay ako ng 10% calcium gluconate, sodium bicarb. Depende. Ito ngayon guys, depende. Meron akong armada, sarili ko, pero depende gaano kataas. If you think it's wrong, correct me later, but I'll show you. I'll show it once I will tell you the drugs na ginagamit. Sodium bicarb, hinalo ko kasi yung American Heart, tapos hinalo ko na lang dito, nagtatanong ako sa ibang IM. Kasi syempre, hindi naman lahat ng American Heart masusunod dito dahil hindi naman tayo high-tech katulad ng ibang bands. So ito po yung iilan sa ginagamit ng dito ni hypercare. Ano pa bang pwede? Dito ako sa magnesium. Kapag kulang ako, hypomagnesium, binibigyan ko po ng Magsol. No? Usually mga around 1 Magsol IM or IV, mga 1 gram to 2 grams. Ang problema ko sa Pilipinas, di ko talaga maintindihan dito sa Pilipinas. Dito ko nakakita ng sodium bicarb, ganito kalaki. Isipin mo sa drug kit ko, yung mga ampules, no, nakabalandra, ang laking kinakain ng sodium bicarb. Tapos mabilis pa mabiak. Pag nayug-yug, bumagsak yung kit ko. Isa rin si Magsol. Si Maglosol, 250 milligrams, plastic. Para maka-attain ako ng 1 gram, 4 ang kakainin ko. Pag 2 grams, 8. Ilagyan ko ng 8 Magsol, di wala na akong lugar para sa aking mga ibang ampule. Hindi tayo makagawa ng, ewan ko, meron pang epinephrine na naiinis ako. Pag pini ako, lalo na may ninja, durog lahat. Wala. Hindi katulad sa ibang bansa. Tomorrow, I'll show you mga ginagamit namin sa ibang bansa, yung Abojet. Pagtanggal, suksok mo lang yung plunger nanonood na yung gamot. Diretso na. Pag calcium gluconate 10, lidocaine 100, gano'n na, diretso. Amiodarone 300, hindi 150. Meron ako 150, meron ako 300. Procainamide, gano'n din. Gano'n din kalaki yung aking, although hindi na sikat ngayon si sodium bicarb, hindi katulad dati. Pag may arrest, sodium bicarb. sa maraming liko si sodium bicarbonate. Ngayon, hindi na. I'll show you again once we reach pharmacology. Okay, hypermagnesemia. So, dyan lang, I will cut it here. Then, ilipat ko lang sa, marami kasi hindi nakakaintindi ng oxygen. Para makita nyo, paano tayo nagbibigay ng oxygen. Guys, ano lang to ha? Babad lang tayo konti. Matapos na to para tomorrow medyo mas gusto ko meron kayong glimpse talaga on what, how to attend to ACLS na medyo wide. Kasi virtual lang kasi tayo, ang hirap. Dapat kasi ang ACLS, dapat face-to-face talaga, pero ayoko hindi nauso naman dahil sa pandemic. Ayoko ma-wave na hindi niyo maintindihan, kaya mas marami akong inclusive. Kung para niyo mag-ACLS kayo sa iba, hindi nila i-discuss kung oxygenation. So sa oxygen, para lang sa kaalaman niyo, medyo hindi kasi niyo to field. Meron pong sizes ang oxygen, tapos kino-quantify, kino-compute po namin yan. Kung ilan ang maubos namin pag naka-load sa helicopter. So para alam niyo lang na hindi kami katulad ng hospital na every Tom, Dick, and Harry is there and the cavalry is there. Hindi. Lalo na pag medivac ako, minsan to the point na nag-iisa lang ako. I am the nurse, the doctor, and the nursing assistant, and the medtech, all in me. Yan lang ang mangyayari sa buhay ko. No? Yan, kahirap. No? So, ayan ang mga sizes ng oxygen. Tapos kung ilang oras, alimbawa, 3 liters per minute ka. Sa size E, ilang oras? 3.11, no? Yeah. Oxygen is colorless and odorless. Tapos ang kinukonsume na natin is 21% according to Dalton's law. No? So the partial pressure of oxygen plus the partial pressure of nitrogen plus the partial pressure of helium, hydrogen, other gas, inert gases. The total is 100%, which in 760 millimeters of mercury sea level. When you go down at 33 feet, then you will experience like 1 atmosphere, may changes there. When you go up following the Boyle's law in physics, then there's like some sort of what we call the physiological altitude of 8,200 feet above sea level. May nagbabago sa katawan. So there is an interplay of the Earth's magnet, my body, and the oxygen, which I call it the volume and the pressure, minus the influence of temperature, because if there's an influence of temperature, then I'll be following the Charles law. So lahat ng nangyari sa katawan ko, subject ako sa Mother Earth that gives the gravity. So habang pataas ako, kunwari umakyat ako ng Everest Base Camp, which is 18,000 feet above sea level, medyo mamamatay na ako doon pag hindi ako acclimatize. Kasi 21% pa siya, pero malayo na yung molecules. Assuming sa sea level, ang hinihigo po molecules ay 5, pag nasa 18,000, 3 na lang. So magbabago, pagsiswell yung brain ko. Pero sa suma total, 21 pa rin. Nagkalayo na lang sa isa't isa. Tingnan nyo, ang Earth ay spherical. Parang habang pataas ka, palayo-palayo yung molecules. Habang kalapit ka sa gravity, mas naipon sila lahat. Ganyan. Ganon din ang oxygen kasi weight niya, no? Nasa 8 siya hanggang 16. Doon sa table mo, no? Sa atomic weight niya. May mabigat siya. Pag mayroong combustion, nagkaroon ng production of smoke, which is the byproduct of fire, mas magaan siya kaysa sa oxygen. Kaya pag tinuruan kayo mag-survive sa smoke, pinapagapan kayo para ma-enjoy niyo yung kanyang atomic weight na mas mabigat kaysa sa smoke. So, nailalang po pa yung oxygen, yung smoke papunta sa itaas. Kaya ganoon, hindi dahil pinapagapang lang kayo. Dahil yun ay may konteksto ng siyensya. So binibigay natin yung green tank ninyo 100. Magtataka kayo, 121 lang naman kailangan ng tao. Bakit kailangan 100? Baka kasi magkaroon ng toxicity. Hindi. Unless naka-intubate ka for a long time, mataas yung toxicity dito. Kunwari cardiac arrest ka. Para lang ma-wave natin yung loss, bigyan mo na kita ng high tension, high percentage. No? Taasin ko yung FiO2 ko, yung inspired oxygen mo. Para mabawi ko kaagad yung loss. Diba? Sabi ko kanina, pinakita ko ng BLS, pinakita ko, in this X number of minutes, namamatay na brain cells mo. Yan. So, paano tayo magbigay kapag may respiratory failure, AMI, cardiac failure, shock, and other things na nako-compromise yung oxygenation sa katawan? then your medical oxygen must be written legibly by the doctor because it's a drug. Okay? And kailangan mapamiliarize tayo sa gamit. Ito po yung tinatawag na medical oxygen, may humidifier. Pag walang humidifier, ang ito naka-embed dyan, tapos diretso lang dito ang tawag doon emergency oxygen. Usually, ang iyong release flow adjuster mo, umabot ng 15 liters per minute. Itong may humidifier, 10. Hindi ka pwedeng umabot ng 15 or else ang tubig mo, luluwa na yan, kasama yung brrr, magbula-bula siya, lalabas na yan doon. So, how do we give the oxygen, yung mga adjuncts niya? So, sa 15 liters per minute and low. So, depende sa in-between, yung mga adjuncts. So, administration natin, nasal cannula, simple mask, non-rebreather mask, yan lang, no? So, nasal cannula tayo, you're familiar, ang max niya talaga is 44% lang. Isipin mo, 100% tapos 44 lang yung enjoy mo. Kasi habang nag-i-inhale ka, nabibreathe mo rin yung oxygen sa surrounding. There's nothing wrong with that kasi may tama lang din siya, lalo na pag MI, kaya naman siya eh. No? So 24 to 44, pero hanggang 6 liters lang ang max mo or else defeated na siya. Kahit pa i-10 ko yan, 44% pa rin. Ha? Gusto kong linawin sa inyo, hindi yung, sige, 10 ko yung nasal prong. Hindi. Hanggang 44 ka lang. So ginagamit natin siya sa mga non-acute situations, mild hypoxic situations, no? Yung katulad yan. So, adult and child ang ating configuration. So, yan ang nasal cannula, 24 sa 1 liter per minute. Pag nagbigay tayo ng 3 liters per minute, may 32 hanggang 36, so 3 to 4 liters per minute. Pag 6 liters, mabilis na mag-dry yung nasal mucosa mo, 44%. Okay. So, hindi ko na sabihin yung mga disadvantage. Dito na ako sa face mask. Pag gumamit ako ng Hudson mask, yung Hudson, no? Simple face mask, hanggang 40% lang. Pwede ako umabot ng 10 liters per minute. Okay, 40% lang ang kaya nito. Okay, ginagamit natin sa type 1 respiratory failure. So yan po si Hudson or si simple face mask. Then we go into somewhat not common in the Philippines, pero pag ginagamit ito sa COPD, yung meron tayong mga color jets, umaabot hanggang 60%. So, pag binili mo siya, set siya. Pag balahan mo ng white, kailangan ang oxygen, yung release factor mo is up to 4 liters. It's gonna deliver 24. Kapag binalahan mo ng green, 15 liters, which is 60%. So, ito si green. So, yan po yung tinatawag nating mga, sa Venturi Mas, yung mga flow jets. No? Flow jets. Hindi ko alam anong tawag sa inyo yan. They're called, coded jet. Coded jet, no? Or flow jet adapters. Okay. Sa emergency, ang ginamit natin is NRB or NRM, pareho lang yan. It can deliver 85 to 90%. Basta meron kang 15 liters. Hindi mo pwedeng ibigay ito. Ang ginagamit mo ngayon ay nasal cannula na hanggang, medical oxygen na ang kanyang flow rate is umaabot lang ng 10. Niloloko mo sarili mo. In times of emergency, non-rebreather mask at 15 liters per minute. Okay? So, ang forma ni non-rebreather mask ay ito. Meron siyang valve. No? Pag nag-exhale, labas sa valve. Ito kasi, walang valve. Inhale, meron pang siyang nakukuha na atmospheric oxygen. Kaya medyo mababa lang ang kanyang percentage sa partial rebreather. So, para alam niyo lang, yung non-rebreather mask, merong uso na din ngayon. Pwede kang mag-non-rebreather mask, plus meron ka pang nilagay na nasal cannula, double yun, walang problema. Ginagamit na rin siya ngayon sa emergency. Ito lang yung very classical way. Okay? So, that's all sa airway ko. I will remove the airway. Palitan natin. I'll go into oxygen. I may airway sa oxygen pala, sorry. So dito ako sa therapeutic electricity. 4 o'clock. Sige. Therapeutic electricity. Tapusin ko lang to. Hindi naman lahat dito sa therapeutic electricity i-discuss ko. Okay lang guys ha? Para bukas medyo mag-aana tayo. Share screen, therapeutic electricity. So, dito natin makikita si defibrillator versus cardioversion. Okay. Nakita niyo slides ko? Are we still okay? Hey, 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 are you okay? Hello? Okay kayo. Okay lang ba kayo?
Yes, sir.
Yes, Doc.
Kailan po, Doc?
Let's go into electrical therapy. Kasi maraming, particularly doctors, hindi alam ang machine sa ospital. Importante, alam natin, hindi lang ang may alam ay ang biomedical engineer, hindi lang alam ay ang medtech or nurse. Dapat tayo mga doktor alam kasi sa the whole show ng mangyayari sa ospital, sa legal medicine, hindi katanggap-tanggap yan. Pag tinanong ka ng korte sa lawyer, Dr. Esguera, do you know, kasi kunwari namatay yung pasyente, do you know the machine that you are operating? Yes. Do you know how to operate it? How many joules? Tapos titingin ako sa nurse ko kasi hindi ko alam. Patay ka doon. Goodbye ka doon. So, kailangan alam mo. So yan po yung masakit sa legal med. Bakit kailangan? Ang captain of the ship ay alam niya ang operational schematic sa hospital. Hindi lang yung alam niya ang interventional medicine, kundi alam niya ang tools of the trade. What is the difference between using Macintosh versus Miller blades? Anong klaseng, kailan ko gagamitin si dopamine versus si dobutamine versus si nor-E sa anong sitwasyon? Marunong ba ako gumamit ng mga syringe pumps, syringe drivers versus IV pumps? Kailangan alam natin yon. Hindi pwedeng hindi. Kasi tayo yung captain of the ship. So ngayon, tayo mag-roll. Ayan. So understand the purpose and action of defib. Tapos defib versus cardioversion. No? Kailan siya maging cardioversion, kailan siya maging defib. So makikita natin, CPR alone can double the chances of survival. But when you use defibrillator plus the quality, from 6% umakyat ng 74%. My golly, ang tindi. Research has shown that deploying a defibrillator within 3 to 5 minutes, simula na nag-collapse siya, can produce survival rate up to 70%. Kaya pinauso natin ang PAD, Public Access Defibrillator. Punta ka sa Terminal 3, nandoon. Sa Terminal 2, nandoon. Pero hindi ko alam kung ini-inspect kasi nalalamigan. Baka pag i-on ko yun, baka hindi na umandar. Na-drain tayo sa lamig. I don't know. Sana may nakikinig sila ngayon sa atin dito para may konsensya sila na silip-silipin din nila yung defibrillator. So, who gets defibrillated? Okay. Nako, ano to? This is already like a coarse ventricular fibrillation. Hindi na siya naghalo pa konti. Demarcation when BTAC pero papunta na tong BF. Dito, fine BF. Ito asystole, of course, it does not get defibrillated. So ito guys, lead 1, lead 2, yung Roman numeral 1, okay, BTAC, 2, BTAC. By the way, 2, tumingin kayo sa akin. Hindi ko na-discuss to. Tingin sa akin, tingin. Hindi mo nang tumingin sa slide, tanggalin ko slide, tumingin sa akin. Gawin ko itong si capnometry ko, gawin ko siyang heart. Ito aking toothpaste camera. So nasa side, ito front, ito sa side. So si heart ko, nasa may left side ko si heart. So dito, may heart yan. So ito left, ha? Baka baliktaran tayo. Pero isipin nyo, tingnan nyo ako, left, nasa left ko. So sundin nyo lang yung left ko. Ito po ay 0. Kung maglagay ako ng camera dito, naka-form kay 0. Nandito po si lead 1, Roman numeral 1. Pagbaba nito, mga around 35, hindi 45, around 35, andyan si lead 2. Dalawang numero 11, yung Roman numeral. So camera nakatingin pa rin sa side lateral. So 0, dito. Pag nandito sa kabila, lead 3. Okay? Limlit siya. Pag nandito nakatingin, AVL, Augmented Vector Lead Left. Pag dito nakatingin, Augmented Vector Right. Pag dito nakatingin, AVF Foot. Okay? So ulitin ko, 1, 2, AVF, 3, AVL, AVR. Kuha. Ang pinaka-influential or the default lead is 2. Bakit? Kasi nandoon ang pinakamalaking muscle na punta sa kanya, which is the left ventricle. Kaya sa lahat ng monitor, laging naka-default lead si 2. Intindihan? Kaya pag nanood ka sa cardiac monitor, ang ginagawa nating default lead is always 2. Kaya mapansin natin dito, sa ating slide, ayan si 2. Default 2. Okay. So si lead 1, limb lead 1, limb lead 2, limb lead 3, augmenter vector right, augmenter vector left, augmenter vector foot. Ngayon, dito na ako sa chest lead. So si chest lead naman, nandito sa harap ko, dito sa right side konti. Then si lead 2, dito sa left side sa sternum. Lead 3, dito. Lead 4, lead 5, hanggang sa lateral, ang 5 and 6 lateral. So si 1 and 2 tumitingin sa septum, si 3 and 4 tumitingin sa anterior, si 5 and 6 tumitingin sa lateral. Okay, so ayan. Ngayon, kung tinignan natin itong lahat, rhythm script 2, so I have here a monomorphic beta, kunwari pulseless beta, not kunwari, pulseless beta. Tsugog, yan na, arresting heart, ang pasyente, biglang nag-shock ako. Boom! Ito shock. Boom! Bumalik. Meron pala siyang transcutaneous spacer. Medyo nag-change rhythm siya pero hindi pa ako convinced kasi walang capture. Merong fire, walang capture. Merong fire, walang capture. Merong fire, walang capture. Ito may capture. Ito may capture. So I think the patient needs to have a adjusted patient or a replacement patient. Mahal yan. So yan po ganyan. So defibrillation. So if there's one great invention of man in the positive manner, it's defibrillation. Okay, so defibrillation ay hindi jump start. So parang it's way of you overwhelm the chaotic electrical activity of the heart na nandoon. So i-overwhelm mo lang para tingnan niyo kamay ko, nagkikirig-kirig siya nga, biglang nagbigay ako ng external source of energy. Gumanon, tingnan niyo heart ko. Boom! Nag-contract siya. Nawala, nawinda. Ano yun? Ano yun? Biglang malay mo, pwedeng magbalik sa normal. Yan. In-overwhelm mo siya. Okay? So, binibigay natin siya sa arresting heart. No? Na kung saan ay wala ng tibok ng puso na tama. Pulseless ventricular tachycardia or a ventricular fibrillation. So, sa TV nakikita natin no, na meron pang school noon na flatline dinipit, kahiya-hiya yung school na yun. Tinanggal nila sa TV kasi nakakaya. Tapos yung palabas na jump start anything, no? That's not jump start. Tapos pag nag-defib ka, patient don't jump around like frogs when you defibrillate them. Totoo po yun. Kasi dati, no, ito tapos na to. Sabihin niyo, sira ulo akong instructor. Na, meron ko mga ACLS noon sa mga estudyante ko sa wilderness medicine. May 10 joules yan sila sa akin. Kamay nila talagang dinidipid ko. Hindi naman sila lumulok pero 10 joules lang. Pero masakit yun. Boom! Parang initiation namin, gauntlet run. Kasi nung ako ay nag-training, sira ulo dito, mga American medic, ginanon din ako 10 joules. Alokso ko sa kuryente, talagang ano. So parang nadala ko lang yung culture. That was before when I was still crazy. No? So dinefib ko sila manual. Na they don't play with defibrillator because it's a dangerous machine. So, yun naman yun. So they are not weapons, no? Na gamitin mo para lumipad yung tao. So it's dalawa ang binibigay natin. It's either we use the paddles or we use the pads. No? Pero nawala na ang paddle. Pero ngayon binabalik na ulit ang paddle kasi meron siyang around 25-pound paddle pressure na naka-apekto sa impedance. Siyempre pag malaki yung taba ko or yung sub-Q, pag ang paddles diniin mo, mas mapalapit sa heart. Simple mechanics, hindi siya rocket science. So ako mas gusto ko talaga paddle kaysa sa pads. Mas nadidiin ko. Pero ang problema lang kasi sa paddle, kailangan lagi kang nasa left side ng pasyente. Wala kang forma kasi para ang bigat. Kasi ang hirap mong iganon doon sa apex. Dadaan to, baka masangit pa sa Tagalog. Para bumaybay pa sa tiyan ko, hindi siya madiin. Makuryente ka pa. Kaya kailangan lagi kang nasa left side kung nagpapaddle. So it's either sternal apex position or anterior posterior position pagbata. So ayan po. So ito naman yung pads lang. Yan lang pads. So kailangan, ang ginagamit natin ngayon is 200 joules. Pero pag pediatric, 2 joules per kilogram or 1 joule per pound. Okay, so I'm not gonna read so much on defibrillation kasi it's not, sabihin natin, hindi naman siya yung masyadong mahirap intindihin. Dalawa lang nag-aaway is the hybrid, like the manual, or the hybrid na meron siyang AED override. Yan na yung uso ngayon. Dati manual, meron akong dalawang manual yung sinahuli sa akin. Tapos yung AED, although meron akong AED dyan. Tapos meron darating isa nag-sponsor, Mindray. So in-sponsoran pa ako. Nag-request nga ako, sana manual na lang. Yung Zol, nag-request ako when I went to Turkey, manual ko Zol, AED ko Mindray. No, napakahirap po ng buhay ng doktor sa expedition. Kasi nung umakyat kami sa Everest, wala pa akong kasama sa tent kasi marami akong gamit eh. Tapos yung mga baterya mabilis mag-deplete. Ang hirap mag-recharge using solar. So kailangan para hindi siya mag-deplete, dinidikit ko siya sa katawan ko. Dinaduct ko po yon gabi-gabi. Paano kung makapihit na duct tape, mga AAA, AA na battery nasa katawan ko para akong suicide bomber. No? Ang hirap para lang hindi siya malamig. Tapos nakadikit lang yan sa warm, nilalagay ko sa kitchen. Kasi pag gabi wala nang tao sa kitchen, dinadala ko sa katawan ko. Or pag naihi ako, meron akong, yung ihi ko, merong tea bottle, warm po yun, tapos dinidikit ko, binabalot ko lang siya para makapag, kahit paano mapihit mo lang katawan ko. So yung pag marami na akong ihi na warm, dinidikit ko lang yung mga ano, tapos binabalot ko lang ng thermal, tinatabi ko lang din malapit sa akin, kasama sa, although hindi na nakadit sa katawan, nilalagay ko sa leg para makapihit lang ako kasi mahirap din eh, na hindi makatulog ng maayos. Should the paramedic use the AED? Yes or no. Pero ang paramedic, pag mataas na, manual na yan. So ito po yun ha. Tingnan ko, baka ang machine nandito. Ito yung pinakamaluma. Tingin. Ito yung paddles, ito yung housing ng battery 1, battery 2, andito yung control, may battery 3. Tatlo pong battery siya. Battery ba itong una? Ay hindi, dalawa lang pala itong tuma. 1, ito, parang walang battery. Ito yung control ng, naka-off to ha. Lumalabas dito ang mga numerics, ilang joules. Dito yung ECG. Ano yung ECG ng patient? So gumagamit pa to ng stylus na ang kanyang paper ay thermal paper. Mainit po itong stylus. Pag hinawakan mo, sunog yung daliri. So ito ay thermal paper, hindi po gumagamit ng ink. Ito naman yung sa akin. LifePack 10. Ayan o, LifePack 10. Pero ito, ang tawag nito, LifePack 10P. Bakit? Meron po siyang pacer. Dito ang cardioversion, saka defibrillation, dito ang pacer. So, paddle siya, tatlong baterya, 1, 2, 3. Pipili lang ako. O, pag pindot yan, ang gagamitin 1. Pag dito 2, pag dito 3. No? Ito yung machine, mabigat lang siya pero napakaganda. I love this machine. So, matagal din sa buhay ko to. So, more than 10 years ko rin siyang ginamit. Yan, si LifePack 10. Then, ito yung charger ng LifePack. Tapos, every morning, nagpa-fire ako dito ng 20 joules para lang naka-calibrate ang machine ko. So, makikita ko kung totoong calibrate siya. Pag nag-fire, boom, lalabas siya, nag-release siya ng 20 joules. At the same time, charger siya. Meron ako ganito hanggang ngayon. Nandyan pa sa bahay, sa bodega. Gumagana pa kasi yung AED ko na isa na kakarga sa ganyan. Ito yung mga bago ngayon na sinasabi ko umabot ng mga 11 parameters. Yan, ang ganda no? Sus, kailan kaya pang kaganon? Ganito. LifePack 12. Meron ding LifePack 20. Ito LifePack 12. Mas magaan na, maganda sa aeroplano, gumagana even up to 24,000 feet above sea level. Ganda rin. Okay. So, it can be pads. Tapos ito naman yung mga different kinds of AED. Ang meron sa akin is yung pinakabago nito. Luma na to. Saka ito, pinahiram sa akin dati. Maganda to, pwede mong ibalibag. Ito rin. Zol, pwede mong ibalibag. Don't get me wrong. Ano kaya? Hindi pwede gamit sa akin cute, masisira siya. Yung ECG ko nga, ruggedize eh. Hindi pwede sa akin cute. May ECG ako ganito ng tali. So ito. Ito yung ECG dot. Distributor 212 lead. Ito yung screen. Yung screen niya iPad na Panasonic ToughPad. Yung ToughPad yan. Pwede mong ibagsak-bagsak. Pwede mong basahin. Pwede mong buhusan ng kape. Hindi siya namabasa. So, ang nasira ko lang na nawala sa hindi nasira, nawala sa program, yung ultrasound ko na ganito lang kalaki. Tapos nagbabato siya sa cellphone ko. Sinauli ko kasi hindi gumagana. Sana mabigyan ako ulit. Meron ako ultrasound, medyo malaki na. Portable pa rin siya pero malaki na siya. Pero pag field. Dito sa bahay, pwede na ako mag-tayo ICU. So ang cardioversion naman, ganito yon. Kunwari, atrial fibrillation with RVR. Ito may RVR, rapid ventricular response. Siniyak ko. Tapos biglang nag-NSR. Ano ang difference between cardioversion and defibrillation? Ang cardioversion, ginagamit natin siya sa non-arresting rhythm. Ginagamit natin siya sa tachyarrhythmia na mayroong presence of, ano yan, 5. Kalimutan niyo na. Hypotension and or altered mental status and or signs of shock and or ischemic chest discomfort and or acute heart failure. Lagi mo tandaan yung 5. Pag may kandidato siya dyan, pwede mo siyang i-cardiovert, pero patulugin. So ang cardioversion ay ang gamit ng cardioversion, meron siyang algorithm. Ito yung algorithm niya. So I'm gonna give this to you. I will not really deep dive so much into this. Makikita lang natin, SBT, narrow regular, we can start at 50 to 100 joules biphasic. Narrow irregular, 120 to 200 biphasic or 200 monophasic. Tapos wide regular, 100 joules. Pag wide irregular, hindi na pwedeng i-cardiovert. Magde-defib na ako. So usually yung mga unstable tachycardia, no? SBT, atrial fibrillation with rapid ventricular response, atrial flutter with rapid ventricular response, wide complex tachycardia na hindi mo maintindihan pero may pulso pa. Polymorphic BT na may pulso pa. Monomorphic BT may pulse. Yung ventricular tachycardia monomorphic may pulse, unstable na siya, ang pasyente papuntang shock, pwede mo siya i-cardiovert. Okay. So, kailan natin kina-cardiovert? Ganito yan, guys. Tingin sa akin, tingin sa screen. Ang defibrillator, gagamit ka ng paddles. Pareho lang din. Except, pipindutin mo ang SYNC. Saan yun? Ay, ito. Tingnan nyo. SYNC. Pag pinindot mo niyan sync, makikita mo sa R-wave mo, merong dots or may dots. Meron ba akong ibang picture? Ayun, nagkakadots siya. O, katulad dito. I think this is AF, atrial fibrillation. Pero parang hindi pa RBR. Assuming nilapit ko, nag-RBR na yan para i-warrant ko na i-cardiovert. Pag pinindot ko tong sync, ayan, nag-yellow na siya, lalabas ang dots. Pag pinindot ko, mawala yung yellow, mawawala yung dot. Ang ibig sabihin dito, ladies and gentlemen, pag pinindot ko yan, may dot yan, by the time na ika-cardiovert ko, para pa rin defibrillator, okay, I'm going to cardiovert the patient. Ganun yung command eh. Pinatulog ko na, kasi pinatulog ko na midazolam. Tulog na ang pasyente. So, PP 80 systole. Okay, sige. So, I'm going to cardiovert the patient. Airway, paki-prepare lang. I'm going to cardiovert at 100 joules. Bakit 100 joules? Kasi narrow lang siya, no? Narrow. Maganda. Okay, sige, 100. 50 to 100. 100 ako. Charging to 100 joules. Kunwari, meron akong charge sa paddles ko. Kung wala, itawag dito is distance charging. Sa akin ay nasa kamay ko. Remote charging, tapos yung unit charging. Yung unit charging, yan yun. So, yung isang nurse, kasi marami kami, no? Pinindot niya charge. Tutulog siya. Tuwing, ganyan, no? From kunwari, from 0, akyat, abilis, pagbilang, pag 100 niya, yun na yung joules. Pip, 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 gano'n na. So, pag charge niyan, sabay chan ka. 1, I'm clear. 2, you're clear. Clear. 3, everyone is clear. Clear. Cardioverting, 100 joules. Boom! Pag cardiovert yan, hindi katulad ng defibrillator. Kunwari, nag-defib ako, dito nangyari. Dito siya mag-fire. Sa cardiovert, hindi. Kahit dito ako nag-fire, pero yung machine, itutugma niya sa R. Kaya tawag synchronize. Para hindi masira yung pag-beat ng heart. Kung kailan si heart nag-contract, sinabay ng machine ang pag-contract sa more. Okay, para hindi mawendang. Kaya tinawag na synchronized because defibrillation is non-synchronized or asynchronized. Cardioversion is synchronized. Pareho lang ang principle sa defibrillation except pinindot mo yung sync upang sa gayon, pag nag-fire ka, nandyan siya sa R wave mag-fire. Kuhang-kuha ng machine yan. Okay. So, ano naman ang, okay, explain ko na yan. Ano naman ang transcutaneous pacing? Dito tayo sa transcutaneous pacing. Medyo mabigat content. Dalawa yan, fix or demand. Ang pinakaluma na ginamit ko nun, fix. Ibig sabihin, ang heart niya nag-beat ng 40 na lang, nagbigay ako ng transcutaneous pacing, pinabit ko ng 70. Kahit ang heart niya okay na, 70 pa rin yung beat kasi bigay ng machine. Ang demand rate, pag umabot sa threshold, kusa na mamatay ang machine. So I'm gonna explain that about that detail. Si transcutation pacing ay class 2A intervention. To overdrive pace. 2A. Ano yung 2A? Sa classes sa COR, cost of recommendation is the benefit is 2 times greater than risk. Pero 2B siya kapag papasok sa brady-asystolic cardiac arrest. Tapos 3 siya kapag binigay natin siya sa asystole. Yan. So, paano nangyari yun? Okay, sige. Idiretso ko na lang. Meron tayong transcutaneous pacing, tapos meron ding transvenous. Ang transvenous, meron ka ng pacing wire na in-insert doon sa large vein mo, papunta sa subclavian, hanggang pupunta sa right ventricle. Then, attached to a pacer box para yun ang source of pulse mo, pulse generator. So, sa dulo, may mag-fire. Mas maganda si transvenous. Pero dahil nasa nasa field, siyan sana ang ituturo ko kasi sa ospital. Pero ang meron kasi ako, ayaw ko ituro sa hindi ko pinapractice. Ginagawa ko po is TransQ kasi wala pa akong TransV. No? Now, kailan ako transcutaneous pace? Kapag meron akong sinus bradycardia for whatever reason, ayaw umakyat sa atropine, ayaw umakyat sa dopamine. No? At saka meron akong second degree or third degree heart block, second degree type 2, meron akong junctional rhythm na hindi nag-accelerate, meron akong idioventricular rhythm na hindi nag-accelerate na ang baba ng aking hemodynamics. It can affect the rate and worse, it can affect the contractility of the heart na bagsak ang pressure ko. Diyan po ako pwede magbigay ng pacer. Okay, so paano ko magbigay ng pacer? Dito lang po yun. I-shortcut ko. Alamin ko, sa isang machine, ibang gamit nito, hindi na siya joules, ang ginagamit niya milliamperage. So, paano yon? So, pinakamaganda, demand. No? So, sa demand mode, katulad nito. Mag-start ako sa pacer at 60. 60 per minute. Ngayon, ano ang aking rate? Rate ko 60. Ano ang aking power, yung milliamperage? I can start at 40 or 30. Start ako 30. Pag start ko 30, meron akong pace pero walang capture. Paano yung pace na walang capture? Maghanap ako dito ng picture. Pace na walang capture. Ito. Meron akong pacing pero walang capture. Okay? So, kailangan taasan ko siya. So, tinaas ko from 30, 40. Wala pa rin. 50, meron pero malayo. Yung aking bilis from 60, taasan kong 70. So, 70, 40. 70 ang bilis, 40 milliamperage. Iakit ko ngayon sa 50. Aba, merong capture. So, ito ngayon, kunwari, ito, nag-pace ako, tapos may capture. Katulad nito, nag-pace na may capture. Okay. So, habang nag-pace ako, i-adjust ko ang sensitivity. Halimbawa, ang sensitivity ko ay 2. Pag ang heart ko, sorry, millivoltage pala. Ano ko lang. Dito. So, kunwari, 8 ang aking sensitivity. Pag na-sense ng machine na umaabot na ng impulse ang heart ko ng 10, mamamatay na siya kusa. So, nakita nyo rito, namatay na ang pacer. Huminto na, hindi namatay. Huminto na ang pacer, tapos kusa na lang yung heart ko. Pero pag bumagsak ang impulse into 6, pipick up ulit ang pacer, magpipace ulit siya para i-pace niya yung heart. Yan yung tinatawag na demand mode. Yan na yung uso ngayon. So, minimeasure po natin yan upang sa gayon, hindi yung fixed rate lang na nagbibigay siya tapos nadi-destroy yung heart muscle. So, katulad nito, 3 milliamperage, nagre-reply. 2 milliamperage. Pag bigyan ko sa 1 milliampere, hindi na nakukuha ng heart kaya wala na akong capture. Wala na siya. Wendang na. Ibabalik ulit sa 3. Ayan. So, ito ay magandang machine. Dito ngayon, kanina kung pinag-usapan natin 0.04 a second, dito naman, pinag-usapan natin is 0.01, 0.2 hanggang 1 millivolts. Kunwari, ang aking pacer, ang sensitivity is 0.08. 0.08. So, 1, 2, 3, 4, 5, 6, 7, 8. Pag na-sense ng machine na lumampas na siya, mamamatay na si pacer. Hinto si pacer. Sorry, hindi mamamatay. Hinto na siya. Pero, biglang nag-pace siya na ganun lang, hindi umabot sa 8, magpa-fire ang machine ko. Kasi nakaprogram siya sa 0.8 of millivolts. Kita mo yan? 0.1. So, ang aking vertical, when it comes to pacing, becomes the millivoltage. Sa pacer mo, ang ginagamit na ngayon is milliamperage. Against sa defibrillator, ang cardioversion, ginagamit joules. Kaya sa machine, hinihiwalay ang panel. No? Hinihiwalay yung panel. Okay. Kita mo ngayon, ito ang pacing unit. Ito ang defibrillator sa cardioversion unit. Yan. Ito ang pacing. Usually, hinihiwalay yan. Ganon din dito, hiwalay. Parehong battery source, pero iba ang module na ginagamit. Kasi, ang ginagamit mo ngayon is milliamperage as your output unit. Usually, ganon din. Sternum, apex. Pero sa mga bata, pwede ka rin gumamit ng anterior-posterior. Sandwich method. No? Anterior-posterior, sandwich. Ayan. Yan. So, hindi siya rocket science. Maganda kasi pag meron tayong live, no? Pwede ko siya ipakita paano ginagamit. So, when you turn on the pacing modality, the machine will automatically come on a rate of 70. Starting pala 70, and an MAO 30. So, ikaw nang bahala. Yan yung default. So, ikaw nang magpataas niyan. Pag-start mo, taasan mo. Usually, ang tinataasan mo lang itong milliamperage. Pag nag-70-70 ka na, wala pa rin. Pwede mong itaas 80 to. Iwan siya 70. Tapos ipahabol mo ng 80-80 na. You can even reach up to 200 milliamperage kung talagang makapal yung tao noon. Pero kailangan ng tao dito tulog kasi masakit po yan. It only takes 4 minutes of no cardiac output to start losing brain cells. Yung sinabi ko kanina, from 3 to 4 minutes, pag walang oxygenation ng brain kasi hindi makasipa si heart, baksak hemodynamics, hinahinay, mamamatay ang brain cells. Kaya, pacer is part of our armamentarium sa ACLS. Bakit? Kasi sa heart block. Ayan, ito yung mga dual chamber. Hindi ko na i-discuss ito mga kaibigan. Pasahin nyo na lang. So mga failure to capture, kita mo wala na. Pag ganito, wala na siyang fire. Failure to capture yan. Failure to capture. Okay guys. Ito. 0 milliamperage i-active mo sa 30. Tapos ito yung pulse per minute, 70. Naka-0. Nagtaka ko ba naka-0? Luma siguro. So, dito sa off, pag naka-pacer, ang naka-on lang ito pacer. Itong dalawa. Pag doon sa itaas, pag i-on mo sa itaas, ang naka-on cardiac monitor. Plus, pwede ka mag-defibrillator. Ito, may pacer siya. Luma siya. This is the LifePack 10P, may pacer. So, may pacer mode siya. Meron siyang monitor sa defibrillation. Yan. Ay, hindi. Zol to. This is not LifePack. This is Zol. Tama. Nabigyan ako nito ng mga paramedic. I have 2 units of this. Binigay sa akin galing Australia. Nag-aral ako sa Australia. Na-meet ko yung paramedic. Binigyan ako ngayon. Okay. So, this is a wonderful story ng cardioversion, defibrillation na kung saan nabuhay siya. So, tomorrow, I will discuss airway, then drugs, no? Airway, then drugs, then cold blue na. Any question, ladies and gentlemen, or correction? Baka mali ako, correct nyo ako. Okay, walang tanong? So if you don't have any question, I'll be seeing you tomorrow at 8 o'clock in the morning para maaga-aga tayo matapos, para manood kayo ng video at mag-exam. May exam ulit. Then, for those who will push through with first aid, which I encourage you para may matutunan kayo yung mga bagong paradigm ng first aid, please join. But if you want certificate, of course, you have to pay for it. Okay, Ma'am Joy. But if none, then just watch para makita niyo anong difference. Hindi ko naman pinagmamayabang, no, pero by quality lamang kami kasi siyempre ako, katulad ngayong September, I'll be going to Ukraine and Netherlands and France para mag-update. So, laging gusto ko estudyante ako. So, lagi akong updated. Hindi ako nagpapahuli. Bago nang dumating sa Pilipinas, meron na ako naman. From modesty aside. Kaya kung makita niyo gamit ko, ito lang, diretsoin ko sabihin sa inyo. Hindi niyo makita ng doktor na kompleto gamit pang ICU, pang field. Yung iba nasa kabila. Tingnan niyo lang yan. Puro trauma management kit yan. Ito. Nasa box. Ito. Ito yan. Field management. Ito. Bags pa yan. Puro kits yan naman sa loob. Yun. Hard case. May mga ampules, kompleto, as in. So, my mother survived because I have kids. Nag-bleeding, kompleto kami as in. Mag-lockdown, meron kami sariling hospital dito with advanced life support kit. So, hindi ako nagbibiro sa aking profesyon kahit ayaw ko maging doktor. But I need to have my own. So, darating ang araw na pwedeng magkagulo ang China, atakihin ang Taiwan, magkagulo tayo. Meron akong panggamot sa family ko. With all the drugs, kompleto ako. Even morphine, fentanyl, ketamine, diazepam, midazolam, I have them. Procainamide, dopamine, Dobue, Nor-E, kompleto. Subukan kong dalhin yung drug kit ko na naka-Pelican. Tomorrow, pag ACLS. Para makita niyo na ang tinuturo ko sa inyo ay ginagawa. So, but it might not be fully like in hospital. But it's the same. Except na hindi lang siya yung typical nakikita niyo sa hospital. Maliit lang, the little things of everything. Kasi siyempre, pang-expedition yung aking configuration. Okay, so if you don't have any question, I'll be seeing you tomorrow at 0800 hours. Relax pag may time. Kasi bukas, medyo exam tayo at medyo yun, may exam tayo. See you tomorrow. Bye-bye.
Thank
Bye,
you so
Doc. Thank
much
you so
po,
much.
Doc.
Thank you po, Doc. Thank you po.
Thank you po, Doc.
Hello po, good afternoon po. Regarding your certificates po, we will send it via email on Monday po once ready na po yung mga certificates. And sa mga gusto po mag-avail ng hard copy po, pwede naman po. May additional 200 pesos lang po, but free shipping na po siya nationwide. Sa mga gusto po mag-avail ng hard copy po, just message your coordinators na lang po or message our official page po on Facebook, PPAM Training Center po. And sa mga gusto naman po mag-upgrade to Bls-Acls with first aid po, pwede po kayo mag-upgrade. You can upgrade po anytime. Just message your coordinators lang po. If you don't have any questions na po, you can leave the meeting na po. See you again tomorrow po at 8 o'clock a.m. Thank you po.
Thank you.